Saraswati Vandana, and may I request everyone to stand and invoke Ma's blessing. To begin with, may I request my teachers, Dr. Panja and Dr. Rabin, they are there, to just share a few words, and then we'll invite the chairpersons. Sir, give 2 words, and then you, Dr. Rabin, welcome.
So, good morning to everyone. We are lucky to be present here because of Dilip. He is very energetic to organize that meeting. So without nowadays days are coming without device. That device can prolong the length of the life. It's a very important issue. So I am congratulated Dr. Dilip Kumar to organize the meeting for upgradation of knowledge and exchange our views regarding the device indication and their complication and management on follow-up. Thank you, Dilip.
Thank you. Dr. Rabin will formally welcome all the delegates and participants.
Good morning to everybody. Thank you, Professor Panja. And as he mentioned that Dr. Dilip Kumar is organizing it every year. It's a wonderful meeting. So it educates me in particular, and I'm sure everyone gets benefited by such sharing of knowledge. And the technology is adding life and also the quality of life every day that we can see in our practice. And it's very important that on behalf of the organizing committee, I welcome you all. Especially Dr. Sango Sundaram, his contribution towards the development of conduction system pacing and other things are extremely helpful for the people in general and especially for the doctors like us. And we also welcome everyone, every single person. Please share your views and knowledge. And I personally congratulate Dr. Dilip Kumar for organizing such a wonderful meeting every year and hope that it should spread all over, and we can get more and more people to come in and join to share their views and exchange their ideas and thoughts and innovations with all of us. Thank you very much. Thank you. Please, we are looking forward to having a wonderful session.
Thank you so much, sir. And may I request Dr. Rabin, Dr. Panja, sir, Sanmuga, Dr. Bishokesh Majumdar, sir, to come for lamp lighting. Dr. Sanjeev Kathuria, my friend from Delhi, please come.
pacemakers got evolved and how this timing cycles got evolved along with them. I usually put this picture in 1958. This is a very important picture in pacemaker therapy. So you might be surprised why a kiwi boot polish comes over here. But this kiwi boot polish was actually the mold on which the first pacemaker was invented. And patient was implanted in 1958, and that was the first pacemaker ever to be an implanted pacemaker. And now we go into the pacemaker ECG. This is the first ECG which we got in that particular patient. And if you can see, there is definitely something wrong in this ECG. So if the patient has an intrinsic rate and your pacemaker is programmed in a VO mode, that is the first mode which was available. So here you will be ending up with a lot of issues, and this can lead to R-on-T phenomenon. This is basically a pacemaker created one. So now we found a single chamber timing cycle pacemaker, but it was in VO mode. And this VO mode probably is not going to be sufficient. So that is the reason the need for a demand pacing came in, where you see what is happening in the heart. And after you see what is happening in the heart, you change accordingly whether to pace or to sense and inhibit. So this was the ECG after a VVI pacemaker inhibition. That was something which came up in this. So timing cycles are basically a flow chart by which the pacemaker looks at the solution for all these interactions between pacemakers and the patient. So the first single chambers came up. It was VVI and stop and allow the heart to function on its own. In case if it is not there, then go for a pacing pulse whenever there is a requirement. So this made the first timing cycle, that is the VVI timing cycle, where you have a base rate, and the base rate makes sure that unnecessary pacing is avoided. So now we decided that sensing is good. Yes, sensing is good, it allows inhibition. But if you see closely into that, this is not just evolved, they brought in something called as a refractory period. So refractory period is where I will see, but I will not do anything. So this refractory period was basically brought in a single chamber timing cycle, which starts immediately after a pacing spike, and it will be extended until the T wave is over. So refractory is, so you see, but you will not act, and that is to avoid the T wave over sensing. So one by one, the evolution of timing cycles started like this, and the refractive period was brought in so that you will be able to take care of unnecessary oversensing with this. So now this is how it happens. If you get a T wave oversensing, now in the recent pacemakers, it will say that there is a sensing, but it will not do anything. So it will just highlight for the information of the physician that there was an oversensing, but nothing will be happening for that. Now also some more things comes up. There is also something called as after potential, that is immediately after a polarization, impulse is given. The pacemaker, that is only the EGM, sees an amplitude of polarization. And this also could be a problem. So this can also lead to issues, and this need to be solved, and that is the reason the next period came in. This period, as you can see, it's a completely blind period. And this blind period is nothing but called as a blanking period, where unnecessarily this polarization amplitude will not be seen by the device. So one by one, the evolution of pacemaker timing cycles happen, basically to curtail all difficulties which were coming up because of the patient-device interactions. So now the total thing comes up. You have a base rate, then you will be having a blanking period, then you will be having a refractive period. So that is the reason why you will be able to see all these things, so which comes up one by after other. So this is how the pacing pulse happens, blanking period and refractive period comes up in a pacemaker. But when will the pacemaker actually see? So pacemaker has to see now something is happening in the heart, so that it has to see and inhibit. And that is the new period which is called as an alert period. So alert period is a period where the pacemaker actually sees and makes a decision that I should be going and treating this patient. So this is how it happens. So immediately after pacing pulse, blanking. So initially in VO mode, there was no sense, and it was completely taken care with a VVI pacing. So the problem now again goes on. We thought VVI, we have solved all those problems, but VVI comes up with throws up another issue. That is the pacemaker syndrome. So in a single chamber pacemaker, we end up with only pacing the ventricle, and we may end up with a patient having a pacemaker syndrome. So this is basically because of loss of AV synchrony. So now if this loss of AV synchrony has to be taken care, because could be a lot of issues because of this, and especially AF and HF, which are clearly documented in various trials. So now what to do? So now we come up with a solution, that is a single chamber is good, but it has its disadvantages. Now we need a different mode of pacing, that is the dual chamber pacing. So the dual chamber pacing comes in, and now you have two leads so that the atria is also tracked, and which will help you to reduce this AF and HF, possibly the mortality and hospitalizations. But still in India, we do implant VVA in many of your 6 sinus AV blocks. Basically the situation could be because some situation the patient may not be able to afford it, or probably it is because of the government schemes. So now we get the AV synchrony taken care, and now we have the dual chamber pacemaker. The dual chamber, which will have two timings, one for the atria, where sensing and inhibition will happen, as well as spacing and inhibition will happen in both atria and ventricle. And now the third D is very important, because this is the one which actually makes the AV synchrony, or it looks at the A, and after a certain time which you are programmed, goes for the ventricle pacing. So simple idea. So now AV synchrony has been brought into the pacing. So this timing cycles, if you look, there are slightly different between the ventricular timing simple cycles, because now you have got an atrial timing and ventricle timing as well. So in atrial timing, first it forms the sensed AV delay, or sometimes it's a paced AV delay if the atria is supposed to be paced as well. Then it starts a PVAR, then starts the alert period. So this is the timing cycle for a dual chamber pacemaker. No much difference here. Only thing is there will be different combinations of APVP, APVS, ASVP, and ASVS happening in a dual chamber timing cycles. And if you look at this particular ECG, it looks almost like everything is normal in the ventricle, very narrow QRS. But still there is a pacemaker functioning almost in an AA mode, which makes sure that you are able to get a very narrow QRS when your AV conduction is good. So first AP happens, immediately after that the alert period, and this is how a dual. So now this is what it is. You are able to get a perfect timing which got created, or trying to mimic it with a dual chamber pacemaker. So now this is something which you have reached, where the problem of VVA has been found and DDD has been found. Now further, I think the doctors will be talking about how placing the lead also in which position will matter. All those things will come up later. So with the two wheels, there is no restriction for people. They will be able to function as good as a normal person. And this is the choice which you can give your patients with a dual chamber pacemaker. Thanks for your attention.
Thank you very much. Can I request to my co-chairman to any comment, anything, any questions?
Yes. How would you differentiate to this with the recent advance of dual chamber and other ones?
As Dr. Rabin was already talking about the new CSP coming up, this has thrown a lot of light aspects on this. So when you look at patients who are having reduced heart failure, ejection fraction, reduced ejection, so these patients probably, if you're going to give them a pacemaker and pace the right ventricle, they have more chances of getting into heart failure. A patient who is having a normal heart with more than 50%, you unlikely will be able to create a heart failure condition in a patient who is overly.
5 to 8% cases it is available in our study, in our follow-up data also. That is the important issue. So this is very, nowadays, definitely they reduce the heart failure rate, debate that thing. Okay, and second thing, our experience of this thing, sensing failure, failure to capture, failure to pace, and unanticipated tachycardia. And again, the program, sometimes the rate is low, because basic problem is the loose of the hood and the electrode is there, you already mentioned under sensing. Dislodgement of pacemaker, and the child you implant the pacemaker, when vigorous playing and dislodge the pacemaker, lead electrode is called so electrical impedance. Second thing, in cases of particularly electrical interference, you already mentioned very nicely, lead and myocardial fibrosis. There is
Will make sure that crosstalk will not happen. So,
okay, thank you very much.
thank you very much,
Thank
sir.
you.
Thank you for the time.
Next speaker is T.K. Gavin. He will talk to an lead technology. So may I request Gavin?
Govind is always there in our device update, and there are some interesting developments happening in lead technology. Now we have leadless pacemakers, and Medtronic is coming up with a CSP with leadless. I will like to have some words from Govind if he is aware about the developments. Yeah. CSP with left bundle with leadless pacing. How people are planning it out. Yeah.
Good morning, everyone, and thank you, chairs, for inviting me up to this stage. And thank you, Dr. Rabin Chakraborty and Dr. Dilip Kumar, for organizing, giving us an opportunity to support your wonderful program, which is the device update, and giving me an opportunity to make a presentation here. Thank you so much. My talk today is about lead technology, which is fairly well known to you. Please do consider this as a brush up before you go into more serious topics. Let me take the pointer out. Okay, so the unsung hero of the pacing system or any device system is actually the lead. The device that has a lot of algorithms looks a little flashy. Of course, a lot of technology is involved in that. But the real unsung hero of the device system is the lead. A lot of technology goes into that. We tend to ignore that. When you look at the fact that if the patient's heart has to beat 60 beats per minute over a period of about 13 years, the heart is beating about 500 million times, and your implanted lead in 30 years is going to flex so many times, 500 million times, but should survive all that stress in a very hostile environment, which is the human body. And so I believe that lead is the unsung hero, and some of the components of that is very well known to you. Just to put it in context, so lead has several components. A few of them: the tip electrode, which is in contact with the myocardium, and then the conductor that connects the tip electrode that is in contact with the myocardium with a pin. And then there is an electrical insulation on top of it, and of course the connector pin, which is connected to the device that you have implanted. These are the components, and this is an example of a unipolar pacing system where you have several strands of wires that are coiled, and then that has an insulation. And then in a bipolar lead, there is one, just like a unipolar system, there is a coil here with multiple strands, which is insulated. On top of it is another coil, which is also again insulated. So you can consider this as a coaxial cable that connects to the tip electrode, which is in contact with the myocardium, and at the proximal end with the pin. And in order to reduce the diameter of the lead, the more recent technology, which actually existed a long time ago, it's made a comeback. Now the leads are coming like a co-radial leads, which is the anode and the cathode conducting electrodes are running side by side, not coaxially. As a result of that, the industry is able to make a smaller diameter bipolar, quadrupolar leads. So that's made a comeback again. That's become pretty popular, particularly in the LV leads that you can see here. And the conductor wire material is typically a nickel alloy, which is called as MP35N in most of the conductor wires. But in the ICDs, it is a similar one, but a silver cord one. So that's a little bit of a difference between the pacing lead and the ICD leads. And the current that goes through the conductor to the tip from the pin has to be contained without any leaking, and so the purpose of that's why you require an insulation, so that contains the current, and also it prevents the corrosion of the conductor material, so you need an insulation for that. Several types of insulations are being used. One is silicone, the other is polyurethane, and less commonly used one is fluoropolymers, which are usually used in the inner insulation of the leads. And while you are using silicone and polyurethane, you will actually not, during the time of implantation, not find much of a difference while at the time of implantation. And today, with the advancement of technology, even clinically that doesn't provide a significant difference. So both insulations are available today easily for most of the companies. And then the tip electrode is the one that is in contact with the myocardium, and then that delivers the stimulus to the myocardium, and it also senses the electrical activation that happens intrinsically to send it back through the conductor to the pin. So this tip electrode should be able to provide a low stable threshold and then provide relatively high pacing impedance, so it reduces the current drain, and it should not itself have a high impedance, so that it is able to deliver the energy well, and it also should have good high fidelity sensing characteristics. And you are aware of the pacing lead, the passive fixation lead and the active fixation lead. The olden days there was a fixed screw active fixation lead, which is actually making a comeback. The current one that you're using more popularly today is the extendable retractable screw in leads. That is what you're using. And then the tip electrode that is in contact with the myocardium is actually designed in such a way that it has a small diameter, so that it provides a higher electron density, but at the same time is corrugated significantly, so that the diameter corrugated, so has a larger surface area. So they are very, very efficient in terms of providing a good pacing threshold and good high fidelity sensing characteristics. And then these leads do, as you know, have a inner lumen through which you can pass the stylet to maneuver the lead at the time of implantation. And now you are more familiar with the CSP lead that has become fairly popular, and that is a lumenless lead. As you can see here, the construction is slightly different, although it's also a screw-in lead. The inner electrode is not a coil, but it's a cable that has an insulation. On top of it is the anodal conductor that is actually running as a coil, that has an additional insulation. And because this does not have an inner lumen, this has to be delivered through a catheter, which is what you typically use in a CSP implantation that you do. That's actually a very, very old lead that is repurposed or found to be useful in the new situation, CSB. So that is what is the 3830 Select Secure lead, which is delivered through the delivery system catheter. And there's a little bit of a difference with the ICD leads. So the pacing leads I explained as being a coil, coaxial cable, but then the ICD leads are cables running from pin all the way to the tip electrode. If you look at the cross section of this is how it looks like. This is the tip, this is connecting to the tip electrode, and then this is the defibrillation conductor, which connects to the SVC coil. This is the one that connects to the RV coil, and this is the anodal conductor. So this has 4 electrodes running. If the lead is a dual coil, true bipolar ICD leads, because it has 3 ports, like a patience port, an RV coil pin, and then the SVC coil pin. The proximal end will have 3 pins until recently. So the device will have 3 ports where the physician, after implanting the lead, will have to connect to 3 pins. And as I pointed out earlier, the conductor material is made of MP35N tube. It has a silver core. So that withstands a high energy delivery that has to be delivered at the time of the defibrillation. So now we have moved over to the DF4 leads, which makes your implantation comfortable and the pocket becomes a little smaller. And a little note on the development of the LV leads over the years. Some of you, probably Dr. Rabin Chakravarti has definitely implanted a delivery system without a delivery system, a CS lead. So that was the earliest lead, which is 2187 unipolar lead. You imagine that you have to deliver a CS lead without a delivery system, not an over-the-wire lead all the way into the CS. That was the first one that doctors like Dr. Chakraborty started with the CRT implantation. Then a series of over-the-wire leads came. So today you have a benefit of a over-the-wire quadripolar lead. So this has a few things. One is a bipolar lead, and here is what the quadripolar lead is. And this is a co-radial construction. As a result of that, the diameter can be made smaller. So because it is co-radial and each electrode has to be separately insulated with a special insulation, on top of it there's another insulation. And very recently, you know that Medtronic is providing an active fixation LV lead, where the active fixing mechanism is on the body of the lead, which is kind of a little piercing coil after implanting the lead in a vein branch where the physician would like to place it. By making several clockwise turns, this little coil will go and bite the intima of the vessel and stay stable. So that's an active fixation lead that's available. So that's the overview of the different leads and its journey from a single ventricular lead all the way to a quadripolar active fixation lead. Thanks for your patient hearing, and thank you so much.
Thank you, Kevin, for the excellent presentations. My question is, see, enough development of the technology of the electrode is already there. Still, just this year I got 2 perforations. One during the procedure of CRT. So from an experienced person, I include myself, some perforation during the procedure. But when the patient hypotension, then index of suspicion must be there, immediately echo and the heart movement will be there. Second thing, another patients, after 3 months after pacing, we can diagnose the pericardial diffusions. So person that you take it away, you should lead to cardiac tamponade. I call the Dilip also, together we have done this corrected. Whether, what is the cause, whether the myocardial fault, whether the electrode fault to cause the perforations? Cause of the perforations of the electrode, either CRT, during the CRT as well as during the particularly electrode of the pacemakers. Which is the electrode responsible for the perforation?
I think
Cause of perforation after electrode.
I will take the question. Yeah.
Whether myocardium or whether is electrode.
Okay, so the perforation, I would believe, it's more a clinical, aspect.
Yeah,
I would request the EPs to comment on that. But then I would believe that it's not the electrode that's the reason, because the lead is made pretty soft. If you're talking about perforation at the time of implantation, one of the small mistake, not so experienced implanter might do is, the stylet is inside fully, and with the stylet fully inside, if you push a little harder, that becomes stiffer and it has a higher chance of perforation. So when you are inside the cavity, have the stylet about 1 centimeter or so, back into the lumen, and then maneuver, so the chances of, perforation becomes lesser. So I don't believe its perforation is due to the electrode or the lead construction. Very often it's the, pressure that you do at the time of implantation, and then maybe because if it is a slightly later perforation that can happen, that you have in mind, then it's probably because of the the lead lie that happens there, and it puts persistent pressure over time. It might, but my answer may not be appropriate. I would request the EPs to make some comment on that.
I think mostly it is operator dependent.
Yeah, that's
how we are doing it.
No, one thing is, so many varieties of lead is coming. Whether whenever you are going to perforate, is there any impedance is changing?
It will change.
If it is changing during the performance, so we can watch that, like the spike is coming or it is the impedance is coming, it is not connected during that time. because after putting this lead, we are searching for the impedance.
Agreed. But seldom it is due to lead actually.
And that
Nowadays
lead is
leads are so
available or not?
advanced. Only thing, as Govind said very rightly, if you force it through once,
Force, then
and secondly, the good old days when the screw used to be fixed, then it used to go through. But
No, in
nowadays they are quite malleable.
Robin, in case of the CRT implantation,
It's operator dependent.
myocardium is dilated and thin also. That is one of the contributing factors.
Yeah, but with the
Thin
new-
myocardium,
with the
there
new
is
lead,
also.
is seldom there. Govind, just a quick question. You said about these coils, but new generation of ICD, they don't have SBC coil.
ICD,
Huh? You got single coil, no?
yes, so both are available, sir.
So what I'm saying is how then those kind of outlets are being connected? You showed a slide.
Yes.
So, but you did not show a slide where the single coil and then outlets are different.
Actually, one lumen will be free in that. Actually, it will have a lumen, but that will be free without a coil, actually.
That is one.
That's how
The
the
other
single
one is
coil.
conduction system facing the lead that you have doesn't have a steelhead as of now.
Sir?
The conduction system facing the ventricular lead
Yes.
doesn't have a steelhead as of now.
Yes.
Now, but the question is that if you really put a steelhead,
Yes,
do you
sir.
think it will be advantageous for the placement of the lead in a better position? I don't know.
Okay, so if you want to put a imagine that you want to have a stylet into that lead. Now the lead diameter becomes bigger because you want to make space for the lumen. And that's the very reason why the 3830 lead was made deliberately like that. I'm sure you will remember that because it was used for pediatric purposes in the olden days, and that was the original idea with which they came up with a smaller diameter lead. And in order to make it smaller, if you remove this the lumen, you are saving that much diameter area, so the lead becomes thinner. So maybe in the near future, future leads might come with a smaller diameter, with a co-radial construction and a stylet inside. So otherwise,
It was an adapted lead. It was not primarily meant for conduction system pacing. It was a pediatric lead and for doing site selective pacing, for example, back milk bundle pacing. And it was specifically designed to reduce the diameter of the lead. The lumen was taken off, and a lot of other advantages are there. I'll be discussing briefly in my discussion what is the advantage of that lumenless leads over the stylet-driven leads. And for that matter, now these days we are deploying even the stylet-driven leads in the conduction system. So only thing is that we need to have a dedicated sheath. So stylet doesn't matter for the lead, which has other properties, which has other beneficial properties over the STL. But yeah, future has a lot of new things to offer.
Okay, thank you very much, gentlemen.
Next speaker is
thank you,
Arijit
sir.
Ghosh.
By the time Arijit is
About
setting up the
longevity.
presentation. Yes, sir. अच्छा सर ना ना सर इटाई इटाई चलो सर नहीं नहीं
Respected Chairperson, and thanks Dr. Kumar. My topic of discussion will be device longevity. This is how the history of devices began. In 1950s, this was an AC-powered pacemaker, and today we are thinking of something futuristic, that there will be no battery, and the devices will harvest cardiac motion to power the pacing circuits. So this is the variation and the journey. So these are all trials which are well known, which speak in the same language that drugs and devices have changed the natural history of HFrEF patients. So we get almost 70% of the patients with a 5-year survival. If we implant these devices in younger patients who are living with channelopathies or in ARVC, they have a definite mortality benefit. So what I say is, it is obvious that especially these young patients with an extremely good survival are the first advocates for maximizing the longevity of a device. Do our patients require a longer lasting device? Yes, because today they are living longer, patients getting devices at an early age, and they are living longer and need longer lasting devices. So this is what is a repeated replacement. Repeated replacement causes morbidity and mortality. Along with that, there is a cost which incurs a lot to the health system, as well as there are chances of device infection, lead malfunctions, and increased rate of lead revisions. So what actually impacts the device longevity? It is the pacing output, the pulse duration. These are the clinical aspect. the pacing rate, pacing percentage, lead impedance, and remote monitoring frequencies, and shock delivered during a therapy. There are some engineering parameters as well: circuitry efficiency, battery capacity, capacitor reform frequency. These all count for device longevity. So the historic perspective was the zinc mercury powered pulse generator was the first pulse generator in use, which had miserably failed, and the unpredictable failure and short service life made it imperative that we require some other potential sources of energy. And therefrom, the journey began, the lithium oxide battery. The concept was mooted by this gentleman, Wilson Greatbatch in 1971 from Australia. When we talk about the power sources, we predominantly divide it into three major categories. One, low power sources, the zinc mercury, the lithium oxide. These are suitable for pacing. But when we come for higher end devices like the ICD or the CRTD, we require batteries which are powerful enough. So the lithium, silver, vanadium oxide is the first category of battery in this, and it has been subsequently managed by lithium manganese dioxides. The CIED batteries, we were quite comfortable for the last 4 decades by using lithium dioxide. But when it came to the question of implanting an ICD, there were requirement of more powerful batteries. So lithium, silver, vanadium oxide has become the technology of choice or the default technology for most of the ICD devices. And this is the way that it gets decayed over years. This is a curve. This is the curve of decaying of lithium iodide discharge battery. So what an ideal battery means? Without much size restriction, the ideal ICD would have independent batteries for both pacing and the tachytherapy. And lithium iodide is good for low current functions like pacing, and lithium SVO batteries will be required for the higher rate functions, that is the charging of the capacitor and the RF telemetry. And lithium manganese dioxide is an even advanced form of battery. So these are the major batteries which are used by the different manufacturers. They are currently banking on the lithium SVO CFX or the lithium manganese dioxide. And this is very typical of the Boston devices and the Biotronic devices. So regarding the chemistry of battery, what we find is that what is actually the capacity of a battery? The capacity of a battery is measured in ampere hours. That is the amount of electric charge that will support a current of 1 ampere for 1 hour. So in that way, the most efficient battery is the lithium manganese dioxide battery, which has an ampere hour of 1.8. These are well-published literature which shows that the manufacturers which use the lithium manganese dioxide battery have a longer shelf, have a longer longevity. So 2017, the NICE came up with a guideline that lithium manganese dioxide might be the most appropriate device for the treatment of patients with reduced ejection fraction who are implanted with the CRTD. So factors that affect the device longevity, it is the background current, the collection and storage of an EGM, the capacitor reformation, the requirement of pacing, the quadrupolar lead in the CRT devices, and repeated device interrogation and remote transmission of monitoring. So what actually the background current means, this is actually the housekeeping current that keeps the pacemaker alive. Collection and storage of EGM, which is very important for a proper diagnosis and management of tachyarrhythmia, but at the same time it is done at the cost of the battery life. And it has almost a very high battery depletion rate. The capacitor reformation means that the ICD discharges itself to recharge it again. So this also has a brunt on the longevity of the battery. And last but not the least, multi-system, multi-point pacing might be a very useful CRT technology, but it is also at the cost of the battery longevity. So what as physicians we can do? We got to know our devices better. We got to program it better and use the unique features that are present with each of the devices. So we have something known as the ventricular auto capture. These are nomenclatures for a particular manufacturer. These are the same things might be there with the other manufacturers as well. So it reduces it keeps on checking the ventricular amplitude, and it delivers current according to the need. There are various other parameters which reduces the unnecessary right ventricular pacing. These are VIPs, MVPs, rhythm IQ, according to the different manufacturers. We can set the pacemaker at an auto mode switch to sense the high atrial rate and to reduce the unnecessary RV pacings. So there is something known as adaptive CRT. What do we actually mean? This is also a pacing device we don't want unnecessary RV pacing. So what it does, it respects the intrinsic conduction of the heart. And it finds that the intrinsic conduction of the heart is quite okay. It allows the native transmission to the right bundle and fuses it with a left ventricular pacing and prevents the unnecessary right ventricular pacing. So it has a backup biventricular pacing, but in most of the cases it might allow an LV pacing alone. In CRTs, this is an MCQ, which of the following programming changes would cause the most significant hit on the battery longevity? It is the ATP before charging or ATP during charging. It is the ATP during charging which consumes the most electricity of the battery. So there are some important points. The pulse amplitude should be programmed to 2.5 or lower if possible. It is usually better that we keep an amplitude of 2.5 volt and in turn change the pulse amplitude rather than increasing the output of the battery. So in conclusion, longevity depends on the battery capacity. Pacing output should be programmed as low as possible but not compromising the patient's safety. Make use of the capture output management features. Implant and accept relatively high impedance when it happens. So if you are finding a place where there is more than 1000 ohms, you should be placing your lead there rather than placing in a place where the impedance is more than 500 milligrams. This will cause a decrease in the current drainage. Chronic atrial fibrillation, you should be consciously and actively programming your device to the VVIR mode so that the sensing function is off. Atrial sensing function is off because it consumes a lot of battery. Minimizing pacing is always the principle. And in ICD, more ATP therapy than shock and ATP before charging might be helpful in preserving the ICD battery. Thank you.
Thank you, Dr. Ghosh, for excellent presentation. In our experience, you observed when I used to Medtronic, it is to minimum, that is the longevity of the pacemaker, minimum 20 to 30 years. That patient coming even now. There's very lithium power is a little bigger size, no doubt our chance of bigger size means extrusion of the pacemaker is all there, infection also there, no doubt at all, but longevity far better. Now enough development thanks to the science and enough development, but resulting the longevity average 8 to 10 years, that is happening. Most of the patient wants to live for a long time, those are the poor patient, 24, 30 years, that chance of the battery power is we are losing. So any comment of that thing?
I don't know whether it is comparable or not. If you had a Nokia mobile, it used to last more. 2 days, a charge was there for 2 days, 3 days. But now with the development of all these smartphones, even the smartest of the phones do not allow you a charge of more than 24 hours. So I don't know, the Sangmoga will be saying or Sir will be saying whether these two things are analogous. The more complexity is there in the device, the charge depletion is going to happen more rapidly.
But even
so
then,
it is always a trade-off.
But even then among the makers like Medtronic, Abbott and Boston, you feel the magnesium oxide batteries additional, they have caused difference? And
yeah, this is something which should not be promoted, but it is not something industry driven. It is published in the literature. The lithium manganese dioxide battery is quite efficient and has a remarkable increase in the longevity of the battery.
Coming down because of auto capture and everything, because the battery is also using more and more into auto capture, because sometimes there is a certification, 1 or 2 beats is coming, they capture. In that way the battery longevity is now coming down. That is the main cause.
I think one point, Arijit spoke so well. One point you mentioned that the ATP, if there is during ATP, some of the algorithm of ICD in particular, or even pacemaker, it, especially on ICD, it already starts generating to deliver shock. And then after some time, especially in Medtronic, that algorithm used to be there. And then if it doesn't deliver, then it dies off on its own. But that number of ATP itself could reduce the battery life. It is still there, Govind, I don't know.
Can I call to Dr. Hajra, please? Thank you, Dr. Ajit, for excellent presentation and discussion.
Dr. P.K. Hajra is on his way, so I request Dr. Kathuria, if he's ready, he can
Next week
give his presentation. Yeah.
Hajra আসেনি তো? আসবে? এখন তাহলে কে বলবে? সঞ্জীব? কাটুরিয়া কোথাকার রে? কোথাকার লোক?
Time,
Sanjeev is there?
Yeah, sir, asked. Dr. Kathuria is setting up, so I was just talking about CSP with a leadless pacemaker. So, Samnuka can little highlight on that topic.
Okay, Dr. Sanjay, please start your lecture.
So I think everything is going
I-
leadless these days. So we know the advantages of leadless and of course the disadvantages of leadless. So just to combine the two latest technologies, physiological pacing with the leadless technology. So both, in fact, all the industry partners, they are working on it to club both these things together. They have a specially designed pacers, which is of a miniaturized model of the current one. And the site of pacing is going to be matter. I cannot reveal much because some confidential agreements have been signed. But yeah, the site of pacing is going to matter, and experiments are already on, reached the stage of animal experiments probably in the near future. It's going to get into a human trial. In another 3-4 years, I think all the industry partners, they'll be having a leadless conduction system pacing.
For World Pacing Series, and everybody was excited about this CSP and leadless pacing fusion, and I was totally unaware, and that's why I was asking. Yeah.
Good morning, everybody. So we're talking about ICD therapies, the ATP. As we were mentioning later only, because what's happening now is the ATP going to, the ATP during charging is a concept which has come up even in VF. So the ATP is now a therapy absolutely better than shock because it's a painless therapy. Promotion by a lot of trials itself. So I'll just talk about how ATP have evolved. So as we all know, the agenda in an ICD will be, you'll have to, if you're going to start with the ATP, you'll need programmable features, the burst ramp, the ramp burst combination, quick convert. Of course, the shock has all the other forms, the biphasic shock and everything. So I'll talk about the ICDs. So where does this concept of ICD at the ATP comes from? So you have two primary concepts. You have a rotor pinning and anchoring and strategies for unpinning. That's the place from which where actually the VF or the AF starts. So you have a dynamic rotor control for external forcing. So how does it actually help? Now what are rotors? Rotors are attracted, pinned and stabilized by areas of electrophysiologic heterogeneity. So what are these heterogeneity means? These are areas with reduced excitability like scars, fibrosis, which possess biophysical properties exerting certain pinning forces. So the whole concept of ATP is that you're going to enter a circuit which has the pinning property and unpin it. But it's not essential that every time you try to enter the circuit, you'll be able to do that. That's why ATP will be effective, but not be effective every time. So how does it work? The basic premise is to deliver a critically timed pacing pulse that will interrupt the re-entry circuit. How will it re-interrupt the re-entry circuit? Because you have entered into the circuit during the excitable gap. So you have created another wavefront. So the two wavefronts, the original wavefront and your wavefront will collide. So this is how it will work. The excitable gap, you'll have the target cycle length minus the wavelength, which is the one which you need to target to enter into the circuit. So ATP is delivered as a sequence of train of 3 to 10 stimuli. And this, as I said, will terminate the VT by causing a bidirectional block. The stimulus propagates antinomically to collide with the head of the circulating wavefront. This is what we are looking for. But remember, this will not happen every time. It will block orthodromically in tissue rendered inexcitable by the preceding wavefront. So your wavefront coincides with the wavefront, which was the original wavefront, causing the VT so as to stop the VT. Adaptive shift ATP is the concept. The cycle length of ATP is programmed as a percentage of the VT cycle length. So what are the advantages? It's effective against reentrant tachycardias, requires less amount of energy, is painless. That's a very, very important thing. So now, importantly, three things which come to our mind. What actually happens if you're going for a shock? The shocks can lead to decreased quality of life. The shocks have higher mortality, cycle length every beat. So these are more aggressive protocols. So you'll have to remember burst, scan and ramp. So what it actually does is, you have a cycle length that's there, you have a time, you'll have to give it a time for the ATP to act. It cannot happen that you're giving a longer period for the ATP to act, especially in higher VT zones. So what it'll do is, it'll give an initial burst, increase the burst on its own, and try to see whether it has been able to enter the circuit or not. But remember, for all this, there is a timeout. You cannot unnecessarily prolong the therapy, this ATP therapy for long, because this can lead to patient losing its consciousness also. So the settings are, the most important thing in any setting is the coupling interval. The shorter the coupling interval, the more are the chances of you hitting the bidirectional block which you want to create so as to prevent the VT from propagating. So the shorter interval means you're going for a more aggressive therapy. So fixed, it depends upon the VTs. Now there are algorithms with different companies, especially there is an intrinsic adaptive ATP which is present in Medtronic. Then there are some algorithms in Boston where they see the cycle length and adapt themselves to the cycle length so that the ramp and scan can vary in them. So the burst cycle lengths intervals also can change for the ATP scheme depending upon whether you want the more aggressive protocol to come into picture. The important thing is the adaptive one. Adaptive CRT means, the burst pacing means you have already taken a percentage of the cycle so that this much amount of aggression you have already shown in your first ATP burst itself. There's the same thing again being shown, the basic cycle length, then you convert it into the burst into slower, fast, more aggressive protocols with your aggressive decrease in the coupling intervals. You can also have pulses which are delivered at decreasing intervals. That means you can decrease the time itself for the interval with the next burst can come. So that means you can become even more aggressive via protocols. And you can have a scan decrement and a ramp decrement also. That means you are decreasing not only the coupling interval but the time to the next coupling interval. So that this just shows that you're becoming more aggressive. So this is how actually 1 to 2 for faster VTs, at most one sequence for fastest possible in the VF zone. The time interval, as I said, ATP timeout is very, very important. The ATP timeout is an interval which you will again program according to the requirement. If you have VTs which have been unstable, of course you're going to decrease the ATP time zones. And the timeout interval will be, this is a classical example, you have a detection window which is met. You have a duration which expires, so you initiate an ATP therapy, start an ATP timeout. If not able to take care of the VT in that timeout, then you'll have to go for a shock. This you can totally program. It's just, you can see the first VT zone is 140, the other is 180, and the third is 220. So it depends upon you how many bursts you want to keep, depending on the time zone. As I said, in the lower you will have more burst, in the later, in a higher VF zone you will have less burst. The quick convert ATP is the one which we are talking about right now, ATP during charging. Now this is a concept which has come up even in the VF zones. You can detect 4 consecutive V cents of pace. You will be able to take care of the fact that the charging will be stopped. This is just again an example of a quick convert to see whether you are able to get, this is the VF zone which has reached. So if the quick convert is able to convert it and see the first beat which is skipped, it will stop the charging less. Convert it and see the first beat which is skipped, it will stop the charging less. Shocks are painful. So I started with a slide where I showed there are 3 disadvantages of shock. So the ATP improves the quality of life, reduces the hospitalizations for VT, and does not depress. It started now, most of the devices do have that VF zone also. And VT is converted with ATP in approximately 90% of them. Thank you.
You have told about the ATP, but all the pacemaker has got the ICT. It is right, the ATP is very effective in case of VT, but in case of VF it is not much effective. So how repeated the ATP can be given just before VF, how repeated the ATP can be given just before VF or during VF. How many times the ATP will be charged on?
Most of the devices right now which are programmed have only one burst available in the VF zone. It is also possible if you're putting it, if a person has, if the history says you have had a VF 4 or 5 episodes in the last 5 months, you can turn it off.
Effective is the monitoring, home monitoring, how much is effective in this patient.
Like to put the
Of course. Yeah, of course, that has to go to anti-arrhythmic drugs. component stays, even if you're looking for shock or but ATP effectiveness will definitely increase. That is a suitable drug.
I want to use drug, amiodarone versus mixed with which drug to be preferred?
So again, once again, it's dependent on a lot of things.
Not to
It depends on a lot of things. If you have an LV dysfunction or if you have a patient which has, and that can help.
Wonderful presentation. I think the idea of giving this topic was IATP, intrinsic ATP. So besides the ramp and the burst pacing, the intrinsic ATP, the smart ATP, which is now available in some of the Medtronic ICD devices.
Which one?
Just like intrinsic ATP.
Yeah, intrinsic ATP, yes.
So that's what
So-
the
so
idea
the
of
it-
giving this talk.
So the intrinsic ATP is especially for in Medtronic. What it does is every cycle it reassesses so that it can get into that coupling interval. It make the aggressive trajectory interval so it can break the tachycardia. That the basic concept of intrinsic ATP is that it will enter into the circuit more likely to enter into the circuit because aggression is much more.
So we can move on with the next one. Thank you, Dr. Sanjay.
Thank you.
Next speaker, I'm happy to call Dr. P.K. Hajra, who is working at the interventional cardiologist with enough experience of device from MRI, Dakori Hospital. Dr. Hajra, please. He will talk on subcutaneous, utility of subcutaneous ICD, what the advantage, disadvantage, altogether and techniques. Dr. Hajra, please.
Thank you. Thank you, Dilip, my teachers, Ravinda. So we started with epicardial ICD in 1980. Then we had transvenous ICD. We have subcutaneous ICD, followed by EV ICD from EV ICD and followed by EV ICD from Medtronic. Now there are many trials now. The latest one will be untouched ICDs, and we have over 8,000 patients so far living with subcutaneous ICD, and EV ICD is not available here. But UK had many implants, more than 300 implants of EV ICD. Latest will be modular subcutaneous ICD, Empower from Boston plus SICD from Boston. And that is basically a concept where you have brady pacing backup and ATP. No ATP or brady pacing is the Achilles heel of subcutaneous ICD. And ATP success depends on your fight between head and tail. And you increase your energy or you come very close. The head, when the dog wants to kiss his tail, the tail has to come to the dog's mouth end, or the mouth has to come to the dog's tail end. So these modular ICDs, the distance between the wireless pacemaker and ICD should be as minimum as possible, and it should be at vertical orientation rather than horizontal orientations. When these two forces meet together, most of the time it is terminated. Now we are talking about artificial intelligence or IATP with the shocks, unnecessary shocks or inappropriate shocks from Medtronic. Smart shock algorithm can reduce the inappropriate shock by 70% from 50%. And I do it under general anesthesia. Take these patients and put a old subcutaneous ICD on the lateral chest of the wall. You mark with the marker pen and you check whether your ICD, the device itself, is falling onto the greater mass of the cardiac tissue. That on your AP, you take that into account on fluoroscopy. The rest of the procedure can be done without fluoroscopy, without the cath lab use, because most of the things are done by a surgeon or I do it myself. It needs meticulous dissection. You can use cautery. You can use other forms of local anesthesia. Now, if you really want to know the difference between three forms, the size matters. Definitely, size matters. Transvenous ICD is 30 to 35 cc, Boston 60 cc, and Medtronic 33 cc. 95% efficacy is 40 joules, Boston 80 joules and 30 joules. ATP bradipacing, yes, no, yes. Backup at 40 per minute. Sensing, not there in either form, not in Boston, not in Medtronic. Event recorder is there in the Medtronic one. TOA oversensing has been reduced significantly by the smart shock or intrinsic or artificial intelligence in that algorithm. The complication is definitely much less. A defibrillator, it is endocardial versus epicardial. We started with epicardial, then gone endocardial, then we come back to the epicardial again. Battery life is 12 years, the maximum with the Medtronic one. Variable depending on the number of shocks in transvenous ICDs. Cost is definitely higher with Boston one and the highest with EV ICD. Young age, less attractive because of the mobility and the fracture of the lead. It's very attractive in 30, 35 years, primary prevention or secondary prevention even in children. Old age, because one ICD can suffice in its life, and MRI, all are MRI compatible. Extractions is hell of a job. You have to use laser, but infections is very rare in subcutaneous ICD. You can just pull it out, endotac. And the problem with Medtronic ICD, it is substernal. There is tons of mediastinitis, which is not there in Boston one. Teen patient monomorphic VT, ATP is disadvantaged. But as I said, in the modular, you have this Empower pacemaker in the right ventricle that can give ATP, but it is a one-way traffic. That means your subcutaneous ICD can talk to the leadless pacemaker, not the leadless pacemaker talks to the ICD. The reason is battery life. Subcutaneous ICD, the more battery life, it makes sense for the ICD to talk to the wireless pacemaker and the RV coming, they can whisper each other if the distance is smaller. Anesthesia, I started with general anesthesia. The last case we did under local anesthesia, and subcutaneous ICD can be done. The last defibrillation is very painful. We still do not know why patient gets pain after ICD shocks. We are moving towards painless ICDs in the near future. Now, in EV ICD, there are two handles, one on the top of the sternum, that is basically a radio opaque, and that guides you to go under the substernum. Those things are not needed in Boston ICD. Lead insertion is very simple. If you have 3 positions lead, that means ICD, xiphoid, and a stitch in the substernum, the number of inappropriate shocks comes down by 50%. Now, initially, first ICD I did was 2 stitch because we thought the lead would get stabilized. But lead, if the lead moves, that gives inappropriate sensing of the muscle potential, and that can give rise to inappropriate shock. So when I started doing 3 stitch, that means sternal suturing, xiphoid suturing, and the pacemaker suturing, the incidence of inappropriate shocks comes down. T-wave oversensing has come down significantly. 3rd generations, air should not be there in the pocket, and you can close. And the pocket should be so deep that it does not extrude in time. So it should be under latissimus dorsi. The Empower or the dual chamber leadless pacemaker on AVR has been done in more than 300 patients in UK. This is just not a new thing. You put this pacemaker, but should be in the septum, so that the current will be vertical, and then you can generate this ATP, and ATP in subcutaneous ICD from Boston can terminate this. This is an animal experiment, but human experiment is human implantation has also been done. Now we can argue about ATP. ATP is required only in 2% of patients. Most of the time it is not required. So that may be a blessing in subcutaneous ICD. Most of the young patients, they don't require. But if it is there, fine. And the inappropriate shock has come down. The last slide. The cost of any device, whether it is micro pacemaker or subcutaneous ICD or EV ICD, is there. So inequality, you have an apple tree on the left side of the tree, the girl is waiting for the apple to fall in her hand. And the other side is richer side, on the other side, that means on the right side, the girl is waiting for the apple to fall, but in the apple tree there is less apple on the other side. So what do? You give support. That means government gives support to the girl equally, so it's falling into equality. Even then, there is inequality because there are less apple on the right side. Equity. The doctors also reduce their fees for implantation so that the patient can save another 2-3 lakhs. So you have raised the bar, you have raised the ladder so that the girl can reach to the tree, can catch some apple. Even then, there is no equity because there is less apple. On the other hand, if you just rotate the tree and gives more support so that it bends towards the poorer girl's side, everybody can have the justice, and both the girl can have the same apple. So that means insurers, the hospital, the society, if somebody needs subcutaneous ICD, because if you had infection in transplants ICD, they should get subcutaneous ICD. Thank you very much for your credit. Change the girl, I'll be there.
Thank you, Dr.
Change the
Hajra.
girl.
Yes. You already justified the meaning of equality as well as justice is far better than inequality and equity. Thank you very much for your experience. Any question from this delegate?
I have one question. When you don't need a pacemaker, it's fine to consider this, but when you need a pacemaker what is the advantage of giving 2 devices? You are already going inside.
Okay, somebody who is Brady needed pacemaker for Brady. This is another therapy for BT, VF, shocks.
Yeah, but when you are putting a leadless pacemaker anyway, so then you consider a subcut ICD and a leadless pacemaker, or just give one?
Subcutaneous ICD for VT, VF does not require any. You can treat the VT,
No,
VF
as you
without
say,
touching
na,
the heart.
There is one-way crosstalk. So there are situations when you put both the devices.
If you need Brady plus VT, VF therapy,
Yeah, that's
then
what
you
I'm asking. Yeah.
Okay, thank you.
Thank you. Next speaker is Dr. Dilip Kumar. He will talk on primary result from ADOPT response global randomized trial.
So good morning everyone, and Dr. Punish Adana could not make it. He's my friend from Dehradun, so I am chipping in his place, and I will be talking on, so we will be talking more of micras and leadless and CSPs and future therapies here. So when we implant a micro device, there are something which needs to be known to everyone, that these are not the same device, same programming parameters are used in these devices, just like pacemakers. So these are my disclosures. I will start from a case which we did, I think, 1 year back, and she was a lady, 140 kg body weight. She came with complete heart block and she was restless. TPI was done, and thrice temporary pacemaker was repositioned in the night itself, and we had to intubate the patient, ventilate the patient, and we had to do something like a rescue pacemaker to the lady. And then after 3 months, she got an infection, and you can see, and next time we were prepared. So this lady is not going to give us 2-3 days time on temporary, and we'll remove the leads and device, and I think we can lose the patient if we put her on temporary. It will be, it will go away and then dislodge, and again you have to reposition it. So we wanted to do a micra, and then the same day, same time, maybe same setting, we'll remove both the leads and device. And one of the registries of micra, they have done it in 40% of cases. They have done on the same day, like what we deal with pacemaker infections. We remove the leads, device, wait for 2-3 days. Sometimes if there is a bacteremia, we still wait for more than 2-3 days time, 1 week or 2 weeks time, with arrangements like you with the lead you paste from the outside, same lead. But in micra we can do that, and chances of infection in micra is very less. So we did that same approach. We did the micra device, you see, it was micra AV, and then once we were in and it was pacing, then we removed both the leads and the pulse generator. Patient next day when we saw the ECG, this was something like this. So there was a AV block, and then we realized we have not turned off the AV mode conduction search. So here the AV conduction search is different as what we see, and the mode switch is different than what you see in dual chamber pacemakers. Here the pacemaker, the micra, AV will go into a VVI plus mode of 40 pacing. So to just preserve the battery. So here they are not seeing the the sensing the P and the sensing the mechanical and the ventricle. They are just going in VVI plus mode at 40 heart rate if the AV conduction mode switch is turned on. So we turned it off, and then we see there was a atrial mechanical sensing and ventricle pacing. So these are some of the important tips and tricks when we implant Micra, and these are very, very fundamental. When we implant a Micra AV device, during the procedure we don't see the sensing. It's just the ventricle threshold we are measuring. So during the implant we see the Micra in VVI mode, we just pace and see the threshold and we come out. Now after the procedure, the atrial sensing is set up by the device itself, and it takes some time. It takes 1 to 3 hours time. So until this time you are still blind whether the device Micra AV is going to sense the mechanical AM and pace accordingly with VDD pacemaker or not. You are totally blind. Next day only or post-op after 3-4 hours, you can just check it if the atrial sensing setup is done. And then and that's why it is important. It is important to go for a see the VVI pacing, the threshold at which the leadless the Micra is pacing, and then these are also some of the changes which are there. The threshold which we keep in acute setup in Micra is 1.5 volt over the highest pacing threshold in the last 2 weeks, and the chronic is only 0.5 volt over the highest pacing threshold. So this is different than what we do in normal pacemakers, and the acute phase we say it is up to 100 is not 0.4 millisecond as it is there in normal pacemakers. This is 0.24 milliseconds, and that's why Micra has shown very done. The device itself looks for the vectors, the 3 vectors, sensing vectors, the thresholds, A4 threshold, A3 threshold, A3 window end, and then finally comes up and automatically adjusts the system. So here you can see atrial sensing setup in progress. So even if you see that pacing, it is not AV synchrony is happening, it means you can't do anything at this time. Just after the implant, the atrial sensing setup is in progress. Just have to wait and watch for 3 hours, 4 hours. Once the setup is done, here the setup is done, and then go with dual chamber pacing. And similarly, if you need more heart rate, then it goes into activity mode switch, which is a VVIR mode. And once there's there's a activity mode switch, the machine, the Micra AV still keeps on sensing the atrial mechanical, but it paces as per the required heart rate for the patient if it senses the activity of the patient. Coming to AV conduction mode switch, I just highlighted with my case. AV conduction mode switch is not something where Micra AV is waiting for ventricle to happen, and if it is not happening, it is giving. It is kind of a program parameter of VVI at 40. So it's only sensing ventricle at 40. So if a patient has a 45 heart rate, he will continue to have a 45 heart rate. Machine will not go into a dual chamber pacing, programming mechanism. So it will be a kind of 42, 45 heart rate of VVI will go on. So this is the AV conduction mode switch of Micra. So these are some new Micra AV diagnostics. I will not go in detail, but here you can see here how it looks like. This is the ventricle, this is the R, and you can see here the A3 window end, and this is the A4, and this is the A3, and this is the A3 window end. So you can see the thresholds of both these A3 and A4 is higher than what we see the the activity here. So the device is not sensing. The atrial mechanical is not being sensed. So what is needed to be done is A4 threshold we bring it down by the MAM test, and then finally we program it, and then the device starts doing AM sense and V pace. Suppose this is situation. Here you can see the P wave and the atrial mechanical is sensed, and this is paced, but this P is not sensed. So what's happening here? So we can see here the P wave is followed by a mechanical sensing. So it is sensing something, but why it is not pacing? It's not pacing because the A3 window is very much prolonged. So it has to be shortened. So A3 window has to be shortened, and then it can start sensing. sometimes when the heart rate is higher, in situations like this, heart rate is higher, you can see V followed by A. It means must be rate is high, and this is not being sensed. And here there is a A3, maybe A4 summation, because it is a tachycardia. And then you should get a ventricular pacing here, which is not happening. Then what is needed is you have to reduce the threshold of A3, and also you need to adjust the atrial blanking and P-warp, and maximum you can go to 115 beats per minute. So with this, you can maximum minimize up to 550 milliseconds P-warp, and you can, and then you have to play with atrial blankings and reducing the P-warps to get more tracking check. So I will end with, because there is a bell is ringing, I will end with these three just small questions and answers. In this case, what adjustment should be made? What we see here, the blue line is A3 threshold, which is higher than the sensing the activity which is going on. A4 is also high. So what needs to be lower down, A4 or A3? Or A4 threshold is low, increase it, or A4 threshold is high, decrease it. So whenever these choices are there, we have to go for A4. In tachycardia, A3, A4 both get summation, and it is called A7. And if A4 is very less, A3 still we can sense, then we can come down A3. So the answer is A4 threshold is too high, decrease it. Here in this case, what adjustment should be made? A3 is sensing, and A4 is also sensing. So we want A4 to be sensed. So answer will be A3 threshold too low, increase it. So we want to sense the A4. If A4 we can sense it, it is perfect. If A4 we are unable to sense, we go for A3. And finally, what needs to be adjusted here? So A3 window end, because one case we had, A3 window end is very prolonged, it has to be shortened. With this, I leave it here. Thank you so much for the patient here.
Thank you, Dilip Kumar, excellent presentation. My question is, what is the shortcoming of dual chamber pacemaker? What is the futures of the Micra dual chambers pacemaker later on?
What all we are discussing, a lot of excitements are there, sir. The conduction system pacing, I think, going to replace normal pacing systems. And once CSP is there, leadless technology is also coming up. So how we can fuse there? So just asking, and I was a jury of a world pacing series in Morocco, and our fellow chairpersons were talking about this fusion and how a CSP will be happening with a leadless pacemaker. And they didn't tell me anything about that. No, it's a secret, top secret. And that's what I was asking. I just wanted, and then, huh?
Dual chambers, Micra.
Sir, this is what I was talking about. Dual chamber leadless, and now we have a St. Jude's, which you can also pace the atria. Sense the atria, pace the atria, ventricle. Here we are sensing only the mechanical, actual mechanical.
Dr. Hajiras have done the largest number in India. What is the final comment and conclusion of this?
Sir, atrial dual chamber is reality now. More than 300 cases has been done by Devi Nair, a lady from UK. Now, you have a small like a gadget for atria and a gadget for ventricle. It is not preloaded like Micra. So there is sheath there. So you go to the right atrial appendage on the AP and RO and LO, and you have to put it where the distance between the atrial pacemaker and the ventricular pacemaker is the shortest. So that A is, talking to V, V is talking to A. So this is done under some angiogram on the right atrial appendage. The base of the appendage is the base side. You can go to the posterior and anterior. If you have eyes, that gives you the best idea of putting the right atrial wireless pacemaker in the right spot. But with experience, I think everybody we can put it in because we are quite familiar with the dual chamber pacemaker going into the right atrial appendage. So you measure the distance. If the distance is good and sensing is good, the crosstalk is good, you just leave it there. Then you load the ventricular pacemaker. This is separate on the same sheath. Load it. There is basically a knob. You just tighten it and put it in the ventricle like the Micra pacemaker. Micra is basically VDD now. Maybe in the future they will come up with dual chamber pacemaker, but it's already there. St. Jude Avier dual chamber leadless pacemaker is reality, and many cases have been done. Not available in India. Atria is good. There are two fixers there. The beauty of St. Jude is Like once it is touching the myocardium, it can go for mapping. You know the threshold, so that before you release the micra, you do not know what threshold you will get. But out here, there are two helix. So one helix measures the mapping and threshold, and once you're happy with the threshold, you just release it. If you're not happy with the threshold, don't release it. But out here in micra, you have to release it, and once the thread is out, then you check the threshold. If the threshold is not good, then you retrieve the micra, go to a different place. But that is not there
Okay,
in the
Doctor.
center. Okay.
Okay, thank you, Dr. Hajar. But how much possibility of embolism? Sometimes no, times not properly, not controlled. Chance of no report on the embolism. I come at one case report that is leading to pulmonary embolism because.
In context to Dr. Dilip Kumar's talk, I think one comment I have is that
Yes.
for micra pacing, the programming has to be done by the implanter himself.
Yes.
Most of the time, you don't just leave it to the institute. You just be with the patient and do it yourself. So many things to be done.
Okay, thank you very much, Dilip. And can I invite Dr. Akhtar Khan? He'll talk on the cardioneural ablations. I have not gone through this.
Good afternoon, good morning. So I've been given to talk about cardioneuroablation. So truthfully, this is a branch that is really upcoming, and I think as all electrophysiologists, we do ablations. Professor Robin Chakravarti is also here. He would agree that these are still areas which are still emerging, and truthfully, I have not done any cases of neuroablation as yet, and I'm sure many of our colleagues who are doing a lot of EP work would also give the same answer. So this is an innovative technology that basically targets patients who have recurrent and refractory vasovagal syncope. I think we all do head up tilt table tests for our patients who present with syncope, and we classify them into type 1, type 2, type 3, where type 1 basically is the mixed response, type 2 is the 2A is the one with bradyarrhythmia without asystole, and type 2B is one with asystole. And then you have the vasodepressor, that's the type 3. So we know that we've been trying many of these medications. We've tried fludrocortisone, we've tried midodrine, we've tried the SSRIs. And we know that this really does not work for many of our patients, especially when they're young. So when we're looking at these patients, especially the young group, with a cardio-inhibitory response, so we're talking about 2A and 2B responses, that's the target where cardioneuroablation has really tried to be focused on. We also know that there are other therapies that have been tried, pacemakers with the RADROS response, and the Biotronic, the closed loop stimulation system has also been tried for this group of patients. But we all know that the results are often quite mixed, and we don't have a good data on this. So how do we target our patients with a neurocardiogenic, cardio-inhibitory form of neurocardiogenic syncope? And as I said, it's the young group that usually gets this form of therapy because you want to avoid putting them on a pacemaker. This therapy has been also tried for what we call as a functional AV block. So it's important that once you're trying to attempt this therapy of cardioneuroablation, you have to make sure that you rule out an intrahesian or an infrahesian block. So if you have a broad QRS, well, this gentleman is not one where you'd want to do a cardioneuroablation. And these are patients who probably would be better off with a pacemaker. But one has to make sure that there is only a functional block and no anatomical AV block. And this we usually do it on an EP study. But outside the lab, you can try an atropine. So if you get a good response to atropine, and if you get a stress test which shows a normal acceleration, well, this is a gentleman who probably has a functional AV block rather than an anatomic AV block. So who are the candidates where we talk about cardioneuroablation? And these have to be patients who have severe syncopes. So you do not start putting in for patients, or even a pacemaker, we don't put in for patients who don't have a serious syncope. So these are patients who really have recurrent syncopes affecting quality of life, or who have a prodrome that's so short that they do not get time to to respond, or patients in high-risk jobs, for example, athletes or say pilots or people who have high-risk competitive sports. But if it's not severe, we would not want you to start putting it either a pacemaker or even try to do a cardioneuroablation. So it's important to identify these group of patients. And as I said, we do it only for patients who have a pure cardioinhibitory form, not the mixed or the vasodepressor form. We need to be understanding that the caveats here. For pacemaker, we've known that we've used it for a long period of time, but there are problems with the pacemakers, the need for replacements, and the young patients who really have problems with the device. But even the CNA is something that's emerging. There are no RCTs that we have. And of course, as I said, we do not use it for patients who have an anatomical disease, either in the SA node or the AV node. And there are concerns of reinnovation and other problems that we'll talk about. So this is a diagram that I think we just need to gloss over, and what we need to understand that the cardiac autonomic nervous system has an extrinsic part and an intrinsic part. And what we are basically focusing is the intrinsic cardiac autonomic nervous system, which basically includes the ganglionated plexi. And these are present in the epicardial fat, usually present on the atrium, and they have these branches or the postganglionic fibers which enter into the myocardium and into the endocardium. So because of the fact that you have these fibers entering into the endocardium, and you can ablate them from the endocardium through a 3 millimeter right atrium, which is usually a thin wall structure, you can possibly go and ablate these epicardiac ganglionic neuron nerve plexuses. And basically a nomenclature has been attempted to be made, and basically you need to do a three-dimensional, cannot do it with a conventional mapping system, you need a 3D mapping system here. And what we do is target these ganglionic plexi. The most important of these is the plexus in the SVC aortic junction, which is ablated from the right side, and the others need to go transeptal, and the other plexi which are in the right superior pulmonary vein or near the coronary sinus ostium or on the left superior pulmonary vein. So these are the ones that need to be targeted again. Different operators have described other plexi also. So rather than 6 ganglionic plexi have also been determined. And the target has also been either the low amplitude fractionated electrograms or the high amplitude fractionated electrograms. So any electrogram that gives you more than 3 deflections is what we talk about, and you need to make changes in your bandpass filters. So 200 and 500 is what we normally would advise the filters to be kept. So again, you need to understand that the targets are very different, and the initial data which was usually done was the high frequency stimulation. But this was pretty a technique which was quite cumbersome. And now most of the operators would probably do an anatomical guided along with an EGM morphology guided technology approach to do a mapping and then look at the endpoints. The endpoints could also be very different. It could be just an elimination of the fractionated potentials, or it could be basically absence of a heart rate response to atropine. So if you give atropine post-procedure and you do not find an increase in the heart rate, that's basically a proof of the fact that you've denervated the parasympathetic part of the cardiac system. And the other one is extracardiac vagal stimulation, in which what is done is a small catheter, a multipole electrode catheter is put through the inferior vena cava to the internal jugular vein, and the IJV is at the base of the skull, and the IJV is close to the vagus nerve there, and then you make stimulations there, and then you look at the vagal activity. So pre-CNA we would find with a vagal stimulation a long pause, with post-CNA you would find that there's no pause or no bradycardia, which is basically a marker to say that you have done a parasympathetic modulation. This is again slides which are borrowed, and you would see this, an AV block, a functional AV block that would be noted, and post-ablation you would find a resolution with a 1:1 conduction. And this is again another patient where you see bradycardia, and post-ablation of the right atrial ganglionic plexus, you would find that there's restoration of sinus rhythm. So this busy slide will basically tell you that we don't know what we are doing basically, and the historical approach, Panchon was the one who in 2011 described his first cases where he did ablations both on the right and the left side, and then there have been other approaches. There are some who have targeted all the sides, targeting only the right atrial side, targeting only the left-sided. So the Chinese group have done only the left-sided approach, and the others have done only the right-sided approach, targeting a unilateral approach. So these are the basic studies. It's a busy slide, but what it shows is there are less number of patients that have been studied. That follow-up duration has been for only a period of 2 years or so. And again, as I said, the techniques are very variable. Induction is variable. But what it shows is that there is definitely a response, and it's a safe technology. There are no major complications with this therapy. But again, patient selection is important. We would suggest that if at all you want to try this, you should be doing it in patients with a pure cardio inhibitor, as I said, with a significant debilitating symptoms. Patients with an anatomical block have to be excluded. It's the young patients with symptomatic AV block where you have ruled out an infrahesian block, or a patient with functional sinus bradycardia. So it's an sort of an important therapy in a group of patients where we really did not have much to offer in the past. But again, with a word of caution, there are a lot of lacunae that are still there in our understanding. We don't know what is the technology, the technique of doing the mapping. We don't know what targets to be done, and we don't know the endpoints. There is still concern about what we are doing right now, and we don't have sham control studies also to tell us what we are doing, whether it's correct or not. The concerns are when we are basically ablating the parasympathetic term, the pathways, you are likely to exacerbate the sympathetic tone. And we know that for cardiovascular risks, a higher sympathetic tone is known to be associated with many of our cardiovascular diseases, and therefore the consequences in the future are really not known because we have short-term studies. To end, I think I'll end with this slide. I think we need to understand that though we have CNA and pacemakers are effective therapies, it does not, I don't want any of us to go home with the idea that they're always necessary. So this is a therapy that is for a reserved group of patients, and both the pacemaker and CNA are not therapies for each and every patient who has a vasovagal syncope. Thank you for your patient hearing. Yeah.
Thank you, Dr. Abdul Khan, for an excellent presentation. You know, medical therapy indicates the neural mediated syncope, another name of that. It is phosphodiesterase inhibitors only important, fludrocortisone, and you have mentioned the medical therapy, refractory to medical, then ablation to medical. How will diagnose the proper time atrial ganglion? How will diagnose it?
Sorry, I didn't get the question.
How will diagnose prior to the ablations, the site of ablation?
Right. So I think that's what the thing is, that we don't really know what are the targets. So there have been different methods. So what has been tried is high frequency stimulation to identify those targets. So basically it has to be targeting the ganglionic plexi alone. But where these ganglionic plexi are located, well, there are certain ideas based on anatomy. But really, if you have to look at functional evaluation, it is by high frequency stimulation or by targeting the low and the high frequency fractionated electrocardiograms. So it's something that is done in the EP lab. And to understand whether this is really a functional evaluation, we do what we call as an atropine test, where we show that there's 1:1 conduction, but we also look at the HV to make sure that there's no intra or infrahesian block. So if you have an intra or infrahesian block, this is not functional. This is an anatomical AV block, where of course a pacemaker is more of a therapy rather than a CNA. Yeah.
How much sensitivity and specificity of ablations?
So that's what I said, sir. We are all over the place. There's no data to suggest, and there's no randomized trial. There's only one study which has shown some benefit, but these are all mostly observational or retrospective studies. We don't have really percentage to tell, but of course that's a therapy that we can offer to these patients who earlier had no major therapies to be offered to them.
Thank you,
Yeah.
Doctor. Very interesting.
Just a comment, sir.
Oh,
So,
yes.
In the last 3 years, I've done 3 cases of CNA. So all these 3 cases were primarily decided on, like he said, atropine challenge. So we suspected a functional block in these patients, and we did an initial EP study to rule out disease in the His bundle or in the AV node. And when we found that the atropine is increasing, we documented the atropine challenged AH interval, and we took that as an ultimate endpoint for the CNA. And the approach which we used was an anatomical approach with an intracardiac electrogram guided one. Because the stimulation part, we don't have a measure, because this requires a stimulation at a pulse width of 30, at a frequency of 30 milliseconds. The current EP system will not go below 100 milliseconds, what I heard from the EP system guys. So that 30 milliseconds can be provided by a neuroablator. So neurologists, they use it for a NCV and EMG study. So when I inquired, they said, yeah, they can stimulate at a 30. But still, these days, dedicated CNA machines are coming, so which can give an impulse at 30. And anatomical guided approach, you have to look for electrograms at the venous entry sites into atrium, be it in the right atrium or the left atrium. And superior ganglions predominantly control SA node, and inferior ganglions in and around the coronary sinus os controls the AV node. In all these 3 cases, when we ablated the superior ganglion, SA node was predominantly affected, especially right upper pulmonary vein and LUPV ostium. So all these are right superior ganglionated plexi. And the main thing is PMLGP, posteromedial lateral ganglionated plexi. So that is the one which predominantly controls the AV node. But in all these 3 patients, when we are ablating that PMLGP, we got a good response from the AV node. So the ultimate endpoint is to ablate till the disappearance of the local electrogram, and these patients are doing well, but these are all random cases. But the main concern is the latest article which got published in Heart Rhythm, whether we are like denerving the heart, where we are just removing the support, vagal support from the heart. So you need to have a real long-term data to show the real efficacy of this ultimately benign disease to create an arrhythmogenic substrate for the patient.
Right.
Yeah.
You know, the person who has done in
Another question that I asked you, that is the report, there is neural mediated syncope, another name. There is phosphodiesterase inhibitor, that is the aminophylline, also effective. So do you believe it in your experience? Aminophylline, yes, it is there.
The person who has done in,
session.
done in thousands, the US guy, he does underwear. like pericardiotomy, because most of the ganglia are outside. So if you have 10 millimeter atrial tissue, if you go from epicardium to endocardium, first 2 millimeter from the epicardium side you have the ganglia. So whatever energy you give from the endocardial surface is not going to be effective. The percentage of success is best when you go from the epicardium. And the phrenic nerve, right-sided phrenic nerve, is the Achilles heel. So you have to separate the phrenic nerve, you have to map posterior medial, right superior ganglia. All four, if you can do, in 90% chance that you will have the complete elimination of neurocardiogenic syndrome. But if you really want to intervene, not the neuroablation, it is the pulse field ablation, where the pulse field ablation will penetrate further down in the myocardium of the atrium, and it will cause apoptosis rather than thermal injury.
So I think we need to understand, I think the last slide was very important. So this is for patients who are young and who have neurally mediated syncopes. And therefore, the data has been mostly from endocardial ablations. And I think when we use our cool path technology, we can penetrate, because these are thin-walled, these are atria which are thin-walled, and we can definitely do. Epicardial for a young patient is probably something that we not.
Thank you very much. All the speakers done a wonderful job and good discussion. Thank you very much once again. Thank you.
So now we are moving to the second session, and may I invite the chairpersons, Dr. Soumitra Roy, Dr. Ranjan Sharma, Dr. P.K. Hajra, Dr. Imran Ahmad, and Sumit Shankar. Yes, sir.
Yeah. Who will start? Oh, Sammuga, yeah. What is that? Oh, নামটাই বা কোথায়?
ওই সমুদ্র সুন্দরম হচ্ছে তোর CSP stylus driven and lumenless lead.
Okay, there is a slight change of program because of some problem with some of the speakers. So we'll invite Dr. Shanmuga Sundaram to deliver the talk first. His subject is CSP, stylus driven and lumenless lead. I think it's almost as a continuation of the last session. This session is almost in continuation. So Dr. Shanmuga Sundaram, please.
Audio visual team, can you help Dr. Yes. So SS has to catch a flight at 2:20, so I request him to club both his presentations.
Morning everyone. At the outset, I'd like to thank Dilip sir for giving yet another opportunity to present and discuss about conduction system pacing. So probably for the next 10-15 minutes, I'm going to discuss about the merits and demerits of using styler driven as well as the lumenless lead. These are my disclosures. We know we have evolved a lot in the field of conduction system pacing. The Narula did the very first physiological pacing in the year 1970. That was a temporary hismodal pacing from the quadripolar catheter placed from the groin. The first breakthrough came in 2000 when Dr. Deshmukh published his seminal experiment on inhuman implantation of hismodal lead using the conventional styler-driven leads. Then left bundle came in 2017. Thanks to Dr. Wang, now we are flying with wonderful colors with the availability of lumbar branch optimized CRT, which actually expanded the scope for many heart failure patients. So any scientific terminology needs a definition. There is still a confusion when it comes in terms of defining what exactly is left bundle pacing. So this definition is based on the recent ESC guidelines, as they have defined it as a left bundle branch area pacing rather than left bundle pacing, because they wanted to include LV septal pacing as well. So left bundle branch area pacing includes main left bundle pacing, the fascicular pacing, as well as the LV septal pacing. This is just for convenience, they've included LV septal pacing as well. So, but when you say left bundle branch pacing, it is more precise. It indicates you are capturing either the bundle or one of its fascicles. I'm not going to discuss about the complex criteria for confirmation of LV capture, but to be more precise, you need to have a QR in lead V1, which indicates that you are pre-exciting the left bundle, so along with a short and constant LVAT. So if you are doing it in a lab where you don't have any other EP systems, if you just take these two things, a QR in lead V1 and a short and constant LVAT, left ventricular activation time in V5, that confirms that you have captured the left bundle and it is good enough for the patient. So coming to the main part of the talk, tools for implantation. Since we are deploying the lead in the proximal interventricular septum, well away from the conventional RV apex, we need to have dedicated catheters and dedicated leads for performing the procedure. So the delivery catheters can be of a fixed curve or it can be a deflectable one. The most commonly used catheters are fixed curve catheters. Medtronic has C315 and Biotronic has Selectra and Boston has SSP. Now, BORD has come out with Locator 3D, and deflectable catheters are less frequently used. These are predominantly used for doing a his bundle pacing and not for left bundle pacing. Pacing leads are either lumenless or with a styler-driven one. The lumenless, the only available lumenless lead which is being extensively used is the 3830 lead, which was discussed very well in the morning by Dr. Govind, Mr. Govind. And styler-driven leads, any styler-driven leads for that matter, if it is compatible with the delivery catheter, probably we can deploy the lead in the proximal interventricular septum. So engineering aspect, I'm not going to go into the detail because it's already discussed, but just want to highlight the importance of having a lumenless lead versus styler-driven lead. So since they wanted to reduce the diameter of the lead, the lumens were removed, so that gave the advantage of reducing the dimension of the lead. But more than that, when you have a lumen, it is more susceptible for the conductor kinking, so that is going to increase the incidence of conductor fracture. And the tensile strength, when it applies to the coil, it tends to elongate. So these are the two other important drawbacks of having a lumen in the lead. So when you have a conventional styler-driven lead, it's more prone for a kink or conductor fracture. And when you're going to pull the lead, like for when you're doing a lead extraction, it is going to get elongated. So these two advantages are there with the lumenless lead. The incidence of conductor fractures, as we have seen in the last 3-4 years, it's more common with the styler-driven lead as compared to lumenless lead. And as far as the extraction is concerned, though we don't have a data, but whatever case reports are available, it's still easy to extract this lumenless lead from the deep septum. And we don't have data on lead extraction for the styler-driven leads, but being a lead with the styler, probably it has some advantage when you can use the conventional tools which are meant for doing a lead extraction. Sheets will be discussed. The most common sheet used are the fixed curve one. It has two different curvatures. One favors the entry into the right ventricle and the other favors to deflect the lead towards the septum. So whichever be the industry partner, they have these two different curvatures for facilitating the lead deep inside the septum. But the leads, the lumenless lead, we know the 3830 lead and the fine line lead from Boston. There's one confusion regarding this fine line lead from the Boston Scientific. Here, the lead tip, though it is a fixed curve, the lead tip is not active, so it is going to be inert one, and it's going to pace just proximal to the lead tip. So when you are going to deploy the lead in the septum, deep inside the septum, and when you want a left bundle capture, when you go drive deep in, the tip might get perforated into the LV before the proximal part captures the left bundle. So the chance for lead perforation is more, it's not the chance for lead perforation. If you want to capture the left bundle, you may have to really penetrate the septum because the tip is not active. As far as the Biotronic Solia lead is concerned, there is a weakest point in the lead. It occurs at the inter-electrode segment, and we know a lot of case reports are there, which tells you that that is the weakest segment, and when it acts as a hinge point, it is going to get fracture either immediately during implantation or during long-term follow-up. About now, previously Agilis His was there, which has distal electrode to map the intracardiac signals, but that primarily helps in doing his bundle pacing and left bundle pacing. We don't want to find the intracardiac electrograms. All we want to know is what is the pace QRS morphology at the implantation site on the RV side rather than the intracardiac electrogram. So the Agilis His has been rolled back now, and they're coming out with a 3D locator catheter with 3 different curvatures to suit the heart model. And the lead, the tendril leads are the one which were used previously. Now the bot is going to come out with a dedicated conduction system pacing, ulti-pace lead. Probably this gives more advantage in terms of torqueability and effective penetrability into the septum. Implantation technique, just to compare the implantation technique in stylet-driven leads versus lumenless lead. This EP system, if you have an EP system, probably you can set up the lab in this way. If you don't have an EP system, connect the patient to a continuous ECG monitor. Either it can be a 12-lead ECG system or a treadmill system. But for deploying the stylet-driven leads, you need to lock the stylet from the other end and pre-deploy the helix first. First put the lead in the sheath and expose the helix, then take the lead to the other end of the sheath, then start deploying the lead by rotating the whole body of the lead. So it goes slowly inside the septum. You don't have to give rapid penetration. Here the lead is bulky, so even a simple rotation will effectively deliver the lead inside the septum. But you need to monitor the pace QRS morphology. So here, being a stylet-driven lead, it has the option of continuously doing the pacing when you are deploying the lead. So when you have a stylet in, you can always connect the stylet to the connector pin, and you can pace while deploying the lead. So you don't have to interrupt to look for the pace QRS morphology. Give slow rotation, continuously see the QRS morphology, and when you see the QR appearing in the lead V1, then probably that is a point where you have to stop giving rotation. But here the problem is, since you are pre-deploying the lead, there is a chance that because of tension, the helix might tend to come back. So that is the main issue with the stylet-driven leads, and I know the industry partners are working on just troubleshooting that issue. They have a lot of stylet locking devices which is going to just fix the helix of the lead so that it will not retract back. But for 3830 lead is concerned, it is simple. Just take the lead to the distal end of the sheath and go to LAO position. That is my favorite view of deploying the lead. Give rapid rotation and look for PVCs getting generated from the lead. Since there is no stylet here, you cannot do continuous pacing, but again there is a revolving connector pin which will be soon introduced into the market, which can be connected to the other end of the lead. And with the help of that revolving connector pin, you can still do the continuous pacing, but still the availability of that, probably you can give rapid rotation, generate these PVCs. The PVC morphology will change from QS to QR. Once the QR morphology is reached, then probably that is the ultimate endpoint where you have to stop giving further rotation. So here it's very simple, but the only thing is that being a small flimsy lead, it may be difficult to rotate it when we are used to that usual 6 French, 7 French pacing lead. So this being a 4.1 French size lead, there may be initial difficulty, but once you learn how to deploy it, then probably this is probably the easiest lead to deploy. And regarding the septum lead behavior, this is well studied with the lumenless lead. This was a first ever study by Marek, which was performed in the animal model. So he has demonstrated how the lead will behave when you are deploying inside the cadaver. But we analyzed our data from the human during implantation. What we found was there are 3 different septal responses which can commonly come across. Type 1 is the normal response, which when you are deploying the lead in a normal heart, or a non-scarred cardiomyopathy heart. There should not be any scar. So when you are deploying the lead in a normal heart or a non-scarred cardiomyopathy heart, there will be a gradual progression of the lead into the septum, just this one. So it will just go gradually, and you will be able to see some resistance for deploying the lead. And on the other end, the type 3, which will be seen in the scarred septum, when the septum is completely scarred, for example, old anterior wall MI, completely thinned out myocardium, the lead will just not go in, and you can see the distal end of the lead getting buckled. And in between these two, there is probably a tricky septum, what we call it as a cheesy septum. Here the septum will be very much cheesy. Just if you give just couple of turns, the lead will just penetrate across the septum into the LV cavity. So this is very important to recognize on table. This happens in almost 3.5% of the patient. The main issue is when you are going to leave the lead in the septum in this cheesy variety, the next day you will find the lead either in the LV or in the RV, because it is very prone for macro dislodgements. In fact, we had some 9 of these cases. The initial 2 cases we had dislodgements, one into the LV and other into the RV. But so then I started avoiding performing a deep septal pacing in this group of patients. So I just abandoned, and fortunately all these patients had a normal LV function with the normal septal thickness. So I didn't have to worry about the resynchronization part. Septal perforation, again, it is well studied in lumenless lead, but this can be extrapolated for styler-driven lead as well, because what we are primarily looking for is the current of injury. So you are going deep inside the septum, you have to make sure that you have not penetrated the septum into the LV cavity. So make sure that you see adequate current of injury, and you make sure that your unipolar pacing impedance is more than 500 ohms to show that your lead is staying inside the septum, not into the LV cavity. So. But this data can be easily extrapolated for a styler-driven lead as well. Sheath removal, there is a tricky part with the lumenless lead. Being a thin, flimsy lead, when you are going to remove the sheath very slowly, like you are doing it for a CS lead, probably this lead might get pulled up and it may even get dislodged. So what we started adapting is you just try to remove the sheath very rapidly so that this will not produce any micro or macro dislodgement of the lead tip. Clinical data, we have vast clinical data for lumenless lead because we are using it for almost 5 years now. So this is the largest series of single center series experience from Wang's group. They have shown that it has a good long-term stability. But when you come to styler-driven leads, the data is scarce, but it is building up now because only recently these leads are adapted for doing left bundle branch pacing. And the acute performance, which got recently published in Europace, they have shown that the incidence of LV septal pacing is little more, and the incidence of fascicular pacing is little more with styler-driven leads, because you will be going more distally because of the bulkiness of the lead. It will not allow to go really proximal, and both intra-procedural and long-term follow-up, the chance of micro and macro dislodgements are little more when it comes to styler-driven lead as compared to lumenless lead. And we know about the helix fracture because the weakest point in the lead, especially in the Solia model, is the interelectrode area where it goes for a hinge effect, and in the long run, because of the myocardial deformation, the distal helix can go for a fracture. Long-term follow-up data, so ours, we showed that almost 4.6% of the patient, they can have loss of conduction system capture, and 1.5% may need a redo procedure. So this was a preliminary data, though the numbers are 12%. The recent one, the styler-driven leads, the loss of conduction system capture is nearly around 4.5%. That is from the European registry. So when you compare head-to-head, I think it all depends on which patients we are performing and what is the underlying indications for doing the procedure. When you are not comfortable with that small size lead, probably you can use the styler-driven lead, which can be easily rotated. So procedure-wise, it is very easy because we know we are using it almost for decades. And best keep in mind that on the long run, there is a chance for helix retraction, which may lead to increased incidence of loss of conduction system capture. So as far as I'm concerned, I probably choose the styler-driven leads for performing bradyarrhythmia, where I'm not worried about a consistent capture of conduction system. But when it comes to a resynchronization therapy, I'm very particular about a consistent capture. So I'll prefer a lumenless lead as compared to styler-driven leads. Thank you.
I think as you have got another talk back to back, we'll take the questions after the two talks.
Yep.
It is almost in continuation, that is troubleshooting. So let's.
It will march into another zone. I think he is one of the pioneer of this LBB pacing in our country. We started doing in 2015 with the Medtronic one, then we moved to your Biotronic, then your St. Jude one, currently Boston. If you really want to do LBB pacing in 10 minutes, 20 minutes, please do the RV angiogram. This is my take. After doing hundreds of CSP, if you do not see the septum from 11 o'clock to 5 o'clock, if it is a saucer separate septum from 10 to 4, most of the time your lead will slip, either go up or go down. So as he has shown, it's vertical thing, at the septum, and it should be at 90 degree, almost 90 degree angle. Now the perforation, as you have said in Boston, last 5, we have the 5th case was perforation. Once you push the Boston lead, automatically it goes in because there is stylus and already helix is outside. It's already not retrievable, unretracted or retracted. This is unretracted. So be careful, but nothing happens clinically. So what if I ask you, without any diplomacy, without any conflict of interest, out of these 4 leads, which lead you think the youngster or the new beginner will start with? To begin with.
So it's a difficult question to answer, though, but just like his bundle pacing versus left bundle pacing, though left bundle pacing is easy to perform, left bundle pacing is like a luminous lead. It is like easy to perform. You can easily master the technique, but you should know how to do his bundle pacing as well because it comes as a rescue. So similarly, yeah. So similarly, when you compare the styler-driven leads versus luminous lead, I would choose 3830 probably little over than the styler-driven leads because of the very fact that on the long run, because it's not the procedure is not going to stop on table. You have to follow the patient clinically. On the long run, you want to have a consistent capture of conduction system pacing. So probably I would choose 3830 over styler-driven leads, but the styler-driven leads, they are improving, they are coming out with a new design, they are coming out with a new technique to make this distal helix stand still. And when it comes to the torqueability, ease of deployment, the styler-driven leads are a little easy to deploy as compared to luminous lead. But you have to see both these things, both acute on-table performance and long-term performance.
So you don't want to commit. Let's move ahead. Yeah, okay. Any comment, Dilip?
One comment from my side. Like once you start doing conduction system pacing, I think better to start with 3830. You get an idea and then go for that. And many of initial cases will be deep septal pacing. You just see a QRS narrowing and a little R. You just stop there and you see LVAT and all. So what I urge everyone to go for a current of injury check. If it is still more than 20, still you have scope to go in, and then you can get a better R in V1 and a better LVAT shortening. So don't stop there. Stop when your current of injury comes down to 12 to 14. This is an additional marker which many times gives you a better end result. So initial cases, I had a lot of deep settle pacing and we could have better the results in initial cases, what I think.
Yeah, so it's a very simple dictum. Not all QRs are left bundle branch pacing. Almost 40% of LV septal pacing can have QR. So if you are a purist, if you want to capture the conduction system, follow the criteria. Probably the simplest one is to have a short and constant LVAT at high and low output. I'll pace at 8 volt and I'll pace at 2 volt. If at 8 volt, if the LVAT is 60, and if at 2 volt, if the LVAT is 80, that means that I'm still away from the conduction system, I'm still away from the left bundle. I will try to give 1 or 2 more turns so that I'll hit the left bundle. So even that 80 LVAT at 2 volt looks promising, but still it is not a conduction system capture, it is LV septal pacing because at 8 volt, it is coming down to 60 milliseconds. So it's the simplest way of confirming whether you are capturing the left bundle or not.
Last.
Okay.
Yes.
It's only one reported in the world, and that is from my own experience.
Short question.
Yeah,
one short question,
couple of years
sir.
back which I did.
Congratulations on your excellent talk, sir. I started left bundle pacing after your talk in the previous device update. So I've done a lot of cases, all of them were success, except for one case where it was a dilated cardiomyopathy with ejection fraction of 20%, where I was unable to reach the septum. So what do you suggest? How do we move forward in such cases?
Yeah, probably I'll touch about that issue.
Not
in this
affordable
next
to
topic.
CRT.
Yeah, I'll touch about that in the next talk, troubleshooting, both at the time of procedure as well as during follow-up. We'll just briefly discuss about the question which you have asked.
Let's move ahead with the second talk.
Yeah, can I have the slides? So CSP troubleshooting, so I'm going to discuss about the troubleshooting which we have to do it at the time of implantation briefly, and about the troubleshooting which we have to do in the device clinic in a detailed way. We know the CSP has gained a significant momentum in the recent few years with the availability of better hardware. The procedural success is much better now as compared to before. Though we have a dedicated catheter, so-called dedicated leads, but the devices are the same. So the same pacemakers and the same CRTs and the same dual chamber ICDs, we are going to use it for a conduction system pacing as well. So proper device programming is essential to ensure the patient safety. So I'm going to discuss in 2 aspects. At the time of implantation, what are the procedural troubleshooting you may have to do, like the question which he has asked, and during follow-up, what we have to do in the device clinic. Because the most common doubt is whether all these devices can be used from the right side as well. Yeah, you can use it. Though Boston has a dedicated right-sided catheters, all the companies' catheters from the left side can be used from the right side as well. The only difference is it's going to prolong the procedural time, it's going to prolong the fluoroscopic duration, and many of the times you may not end up in capturing the proximal bundle, you will end up capturing the fascicles. The procedural success will be little less because the catheters will not give enough support, so you have to give additional torque like what we are giving for rotating the lead. Just tell your colleague who is supporting you to give additional torque to the sheath so that it gets opposed to the septum. And as far as the rotations are concerned, I tend to give rapid rotation. If I feel some resistance, I'll give a really rapid rotation so that will drive the lead inside the septum. And the most important thing which happens during implantation is the sheath may not reach to the adequate side. The sheath may either prolapse into the RVOT, that happens less frequently, but more frequently the sheath may not reach the site and it goes very inferiorly. This happens with all the company sheath irrespective of the makers. So it goes more below because of the dilated atrium. So it happens more often with the larger heart. The smaller heart, the sheath tends to prolapse into the RVOT. With the larger heart, the sheath tends to go a little inferiorly. So what we always do is, since the sheath has a distal curvature which will deflect the lead towards the septum, we try to float the lead. It happened here. Sorry. You can see the sheath was going below, my his catheter is up, so I want to go the initial 2 centimeter up. So I just floated the lead and allowed the lead to float back, and once it hits the septum, it tried to get attached to the septum by caudal measures. And then with that support, I try to lift the sheath little bit and thread it, so that will allow the sheath to reach the target. So this we call it as a floating lead technique. Similarly, when the lead is not going in, so when the lead is really not going in despite giving rapid turns, so you need to see whether your sheath septal orientation is perfect. So see in LAO whether the sheath and the septum looks in an L-shaped configuration, and the distal end of the curvature, distal sheath is really hitting the septum at a 90-degree angulation. So when you are getting this 90-degree angulation, if it is an unscarred septum, definitely the lead will go in, whatever be the force you are going to give for the lead. And the rotation technique, so for deploying the lead, just before deployment, I usually start wearing, I start the procedure with 2 gloves, and just before deploying the lead, I'll remove my outer glove, because you need to have a very dry hand and a dry glove and a dry lead part to give effective rotation, otherwise the grip will not be there. So start with 2 gloves just before deploying the lead. Once you reach the LAO side, just before when you are about to give the rotation, remove your outer glove so that you will have a good grip over the lead. And try to give rotation closer to the sheath, not from the end of the lead. Many people tend to give the rotation from the closer to the sheath, from the end of the lead, because when you give at the end of the lead, there will be dead space outside the sheath, which has to be negotiated before the torque gets transmitted to the other end. So give closer to the sheath, and rotations when you are giving, rather than giving slow rotation, because in patients with a compromised heart, cardiomyopathic heart, there may be some interstitial fibrosis. When you are going to give interrupted rotation, like give 2-3 turns, look for pace QRS morphology, look for impedance, there is a chance that at the mid-myocardium you may get stuck up. So what I give is, I give rapid rotation. So even if there is some mid-myocardial resistance, because of the rapid rotation, the momentum of the lead will take the body as well, and it will just jump across the mid-myocardium. I have seen a lot of leads jumping across the mid-myocardium, because that is a usual site of resistance in cardiomyopathic heart. So when you really increase the rapidity of the rotation, when you really increase the torqueability of the sheath, just try to torque the sheath a little bit more, you'll be able to penetrate any kind of unscarred septum. So that's the one important thing which you have to know, whether the septum is scarred or not. And anatomical challenges, I think Dr. Dilip sir has a publication of this kyphoscoliosis. Once rarely you can come across an anatomical challenges where you may have to do really sheath angiography. I don't do sheath angiography quite frequently, but in this case it is required because we don't know how the septum is oriented. So once you do the sheath angiography, then the procedure will be simple, because you know the orientation of the septum, you can deploy the lead. Scarred ventricle, so the one which I was discussed just a couple of minutes back, you need to know what is happening at the lead implantation site. So the other side, we have given the ASC 17 segment model, and you can see the predominant site where the lead goes in will be the overlapping zone of 2 and 3 and the overlapping zone of 8 and 9. That means that the basal and mid, inferior and anterior septal area. So anteroseptum, infroseptum junction at the basal ventricle, anteroseptum and infroseptum junction at the mid ventricle. So these are the site where our left bundle lead predominantly goes. So what we can infer, do a pre-procedural MRI when the patient comes for a device therapy, CRTD or CRTP, do a pre-procedural MRI, see where the scar is. For example, in this particular case where the scar is over that 1 and 2 area, the lead deployment zone is the 2 and 3 area. So you can see that the 2 and 3 area is completely free of scar. So you can see the next post-procedural CT, the lead was getting deployed at the 2 and 3 overlapping area, and you can very well capture the left pattern. On the other hand, if you see the scar over the 4, 5, 6 zone, the lateral wall, infralateral wall, that is the site where our conventional LV lead will go, the infralateral area. So that means that if you find a scar in this zone, then definitely you will not be able to get a good pace QRS from the CS aspect. So you will be having a scar, the threshold will be high, the QRS will be bizarre, even it may induce arrhythmogenesis. So in this particular patient, it is better to avoid putting a CS lead. You will not get a good parameters. Go for a CSP where the septum is completely free of scar. So we can have a lot of combinations of scar pattern, and based on the scar pattern, we can decide about the device therapies. That is what we did in our last year's late-breaking clinical trial. We did a cardiac MRI for all patients who came for a device therapy. Based on the quantification of the scar and distribution of the scar, we had chosen the modality of therapy, and we found that when there is no scar in the septum, in patients with a non-ischemic cardiomyopathy and left bundle branch block, a simple dual chamber will work a lot. Lead extraction can be done for any reason, whether it be an infection or because of a microdislodgement resulting in conduction system capture. This is an area which is a lot of queries. So we have case reports where until 3 years the lead can be extracted. Remember, this is a stylet-less lead. There is no lumen to put the stylet to extract the lead. So probably in the future we may get a dedicated tool to extract this lumenless leads. So this, the second part, what troubleshooting we may have to do with the device cleaning. It should be an integrated approach because many of our patients will have an underlying heart failure. So you have to have a clinical history, 12-lead ECG, PSA, echocardiography, and plus minus objective assessment of heart failure by doing NT-proBNP and 6-minute walk test. So these are things which we always follow in our device cleaning, and the regularity will be after 15 days of implantation, then at the first month, then after that every 3 months. So once the patient is stable, once the EF is normal, then you can call back them at once in 6 months or once in a year if you don't have a remote checkup program. It's very important to label the device because, as I said, there is no dedicated CSP device available. Whatever we are using are the conventional devices, so you always label them either as a his bundle pacing device or a left bundle pacing device and mention the connections. This is very important because you can see this is probably the simplest connections which I can show you when you have both options of CSP as well as the LV lead. But there are a lot of complexities when the patient has an underlying AFib but they have a CRTD indication, the connections will be a little more complex. But I'll try to make it as simple as possible. If you have a simple dual chamber pacemaker, the ventricular lead port will get this left bundle lead. If it is a lot CRT, when you are going to put a CS lead as well, the LV lead will go to LV port and the RV lead will get the conduction system pacing lead. When it comes to a dual chamber ICD, you can convert the dual chamber ICD into a CRTD when you use a DF1 lead. So in patients who requires an ICD, we always choose a DF1 lead, which allows us to use a left bundle lead liberally. How? You can see the DF1 lead will have a forked end, so the RV patient's fork will be capped, so it will be buried inside the pocket, and the shocking pin will be connected to the shocking port, and the left bundle lead will be connected to the IS1 RV port. That means that the pacing will be through the left bundle lead, it will pace the left bundle, and the shocking will be through the shocking coil. So this gives an option of using a ICD as a CRTD. We label it as a left bundle branch optimized ICD. When it comes to a patient with a very wide QRS, intraventricular conduction system, intraventricular conduction disease, or with a non-LBV morphology, your simple left bundle will not correct the problem. So you may have to have left bundle lead as well as the CS lead. In that case, when the patient needs an ICD, you may have to put 4 leads, and that 4 lead option will be provided by the DF1 lead. The similar settings, cap the RV patient's fork and connect the left bundle lead to the RV patient's part, connect the LV lead to the LV port, and RV shocking lead to the RV port. But remember to label the device, because when the patient comes to the device clinic, you need to know where the lead is connected, whether it is connected to the atrial port or the ventricle port or the LV port. So it's very simple when it comes to single chamber and dual chamber. The confusion occurs in the CRTP. When the patient is in sinus rhythm, it's very simple. A to A, CSP to RV, and CS to LV. When it comes to atrial fibrillation, the CSP lead will go to A and RV to RV and CS to LV. This we rarely perform because atrial fibrillation will try to put either a single lead or a dual lead chamber, not a CRT-PG. Pacing mode. So single chamber, there is no other option available. You have to pace in BVI. But the dual chamber, the biggest question is whether you are going to give a committed pacing for the ventricle or you are going to keep it as a backup pacing. When you are confident, when you see that the left bundle capture is consistent, probably you can go for a consistent capture rather than a intermittent capture. So depending upon that, you can keep the managed ventricular pacing on or off. But when it comes to CRT, you want to have 100% capture of the conduction system. Make sure that you switch off all the MEP algorithms. When the CSP is connected to the atrial mode, probably DDDI is preferred because you don't want to put a pacing spike on a ventricle which is refractory or which is very prone for developing ventricular fibrillation. Pacing polarity, we know his bundle pacing, we consistently pace in unipolar configuration, but in left bundle branch pacing, almost always I'll prefer a bipolar pacing configuration. I don't prefer unipolar configuration. Having said that, we know that there are two electrodes, tip electrode which is a cathode and a proximal electrode which is an anode or otherwise called a sling electrode. What is the pacing output which you are going to program? They are going to capture both the electrodes continuously or are going to capture only the distal electrode. So what I do is, so just try to pace both the electrodes by pacing at 5 volt and see the QRS morphology. So this bipolar capture along with the anode, majority of the times when the patient has an underlying LV dysfunction, is going to produce a bizarre QRS. Because the diseased heart, when you pace from the right side of the septum, the QRS will be bizarre. So any bipolar pacing, above the anodal capture, the QRS may or may not look good. So what is the use of anodal capture? In patients with baseline right bundle branch block morphology, for example, you are dealing with the patient with a DCM, RBBB, LV dysfunction, and when you do this anodal capture, capturing both the right side and left side simultaneously will mask the right bundle branch platter. So that's what we have shown in our collaborative study group where we have taken 120 patients with an RBBB, so where we try to achieve an anodal capture so that there was a better reduction in QRS morphology. So outside this RB morphology, I'll try to avoid this anodal capture. So I'll assess the anodal capture threshold. Majority of the times it will be above 2 or above 2.5. So I'll try to program at 1.5 or 2 volt so that I can conserve the battery and I'm not going to produce a bizarre QRS with a perfect capture of the left bundle. So choosing the
last.
Yeah.
I mean, the time is up.
So AB delay optimization, that is based on the QRS morphology and the QRS duration. So in patients with the DCM, if you are choosing a dual chamber pacemaker, you can always increase the AB delay with the EP system monitor or with an ECG monitor and make sure that you are achieving a native AB fusion to get a better QRS morphology when you are using a dual chamber pacemaker. And just to finish off this one, so we having discussed about the use of left bundle lead for ICD lead as an alternative modality for a CRTD. There are some issues which we have to think about before just jumping into this strategy. So these are the patients where the left bundle lead is connected to the pacing sensing port of an ICD pulse generator. It can be either a dual chamber ICD or a CRTD ICD. This means that the left bundle lead is going to sense the ventricular events, and the RV shocking coil is going to give the shock. So whether the left bundle is consistent enough to give an appropriate sensing, so that's what we have analyzed. Almost 254 ventricular events were detected, and almost 90% of the time the ventricular sensing was appropriate, and in the remaining 10% it was an inappropriate detection of ventricular arrhythmias. So we have analyzed it still further, and what we found was the inappropriate sensing was purely because of T-wave oversensing. This is one thing which is very worrying. When you have something good, too good is also not too good. Like when you have something which we know that left bundle senses the ventricular electrograms in a better way, but it is sensing in such a good way that it is picking up T waves so much beautifully that a lot of devices are coming with this T wave oversensing. So this one particular patient had a significant T wave oversensing resulting in inappropriate delivery of ATPs. Luckily he didn't have shocks, so we had to do some troubleshooting to mask this T-wave oversensing. So a lot of options are available. Reduce the ventricular sensitivity by increasing the sensing parameter, or change the polarity from true bipolar to integrated bipolar, or we have some dedicated T-wave oversensing algorithm which can avoid or detect or even avoid giving inappropriate therapy. But for that particular patient, we have increased the sensitivity because changing the polarity will put the patient at risk of oversensing the P-wave. So things to look for during follow-up: see the capture threshold, both unipolar and bipolar, pacing impedance, both unipolar and bipolar, sensitivity, and confirm that the patient is getting a consistent left bundle branch capture during follow-up. Thank you.
Thank you. If I ask you two questions, 110 millisecond by CRTP versus 110 millisecond by LBV pacing, which one is better? And second, in CTGA, and if you have a tricuspid valve prosthesis, how do you do LBV pacing?
Yeah, so regarding the QRS duration, so at implantation, I'm not bothered about the QRS duration when I'm doing it as a CRT, when I'm doing it for a CRT indication. Rather, I'm more bothered about, more particular about the LVAD. So I'm going, I'll see whether I'm going to get a good LVAD. For example, if the LVAD is 80 or 85, anything less than 90 we accept. Even with the QRS duration of 130 or 140, I will accept it because I know I can achieve another further reduction.
I'm not asking that question. 110 by CATV versus 110 on LVB pacing.
Obviously,
Outcome.
110 LVB pacing will have a better outcome because it is all conduction system capture as compared to a myocardial capture of the CSP.
Any other questions or comments on the tricuspid valve prosthesis and CTGA?
So, tricuspid, CCTG always you can go deep septal because we want the right side of the left side of the ventricle, which is a morphological right ventricle, to have a synchronization. Rather than capturing the left bundle on the left side, you go deep into the septum, try to deploy the lead in and around the right bundle area to have a synchronized activation.
Right. Any question, Dr. Clare? Any comments, sir? Yes. He has a comment to make. Can you identify yourself? I don't know you. Okay.
So when I'm using a dual chamber pacemaker, the usual programmed AV delay will be 60 to 80 milliseconds. When I'm doing a lot CRT, when I'm going to use a triple chamber pacemaker, I'll pace the CS left bundle first, CSP lead first, left bundle lead first, followed by, if required, the left ventricular lead. So the LV lead will be activated last probably 10-20 milliseconds later than the CSP because the impulse starts from here and then it goes there. So that time interval you have to take probably 10-20 milliseconds after the CS pacing will be good. You don't have to pace the LV first. You have to pace the CS first, left bundle first, then the left ventricle.
I think in the interest of time, we should move forward. One comment from Dr. Karthikeyan. LVB pacing 110 versus CRTP 110.
Definitely left bundle pacing.
Jadab? Right. Wow. Dr. Clare raised his hand. Okay, I pass on to left bundle. Okay. Next speaker. Next speaker. Should we stay back or? Okay, so I'm privileged. Thank you, Shamukha, for coming and beautiful talk. You always learn from your deliberations and always new things, new technology, new thoughts come from you. Dr. Radha, you already announced, no, Dilip?
Dr. Athar Ali.
Okay.
Prakash Da, if you can introduce Dr. Athar Ali to everyone. Prakash Da. Dr. Sharma. So Dr. Athar Ali is the pioneer in Bangladesh electrophysiology society, and he has started so much work there, and he's doing ablations for many years, and we seek his guidance when we go to Bangladesh, and we have been close friends for many years. So Dr. Ali, for you. Yeah.
If any problem, can I have my laptop?
Can somebody help me, Dr. Dayal? Can somebody help Dr. Akhtar?
Is there any problem? I can have my laptop.
Hello, organizers, please help him. Come fast. So we'll be speaking on pacemaker infection.
After this, Dr. Clare and then Dr. Karthikeyan, then Farida.
Okay.
So anyway, we have time, so let me introduce Adar Ali. Adar Ali is our student from Scott Heart Institute, and very capable. He was professor and head of the EP and National Institute of Cardiovascular Sciences at Dhaka. After retirement, he is now in a private setup, and he is the man to go in EP in Bangladesh, for the time being at least.
Thank you, sir, for introduction, and thanks, Dr. Dilip Kumar, for inviting me in such a program. And my teacher, mentor, and trainer is here, Dr. T.S. Clear. Actually, I was trained under him in 20 years back, so it is a good opportunity to share my experience here, as because most of our patients in our country, sir, with this problem comes to me. I have to deal them, and some of the patients finally comes to India, and I want to share my experience how these patients are being treated. As because the device infection is a very long problem, and particularly it starts with the adherence and ending is not known. Finally, some of the patient dies and some of the patients takes a long way to go to the treatment, and particularly because there is a wide variation of approaches for treating these cases. Actually, what is written in the books, what is written in the guidelines, most of the times we could not apply these principles for the treating these kinds of the patients. And there are limited access for services for these kinds of the patients. Most of the time, most of the physicians hesitate to deal these kinds of the patients. Although the problems are uncommon, but very much difficult to deal these kinds of the issue. So this is the reason I am actually discussing these issues here. In this my lecture, actually particularly CID means particularly pacemaker, ICD and CRT. These three items I have called them CID. And regarding some terminology, that is the implantation related terminology. Primary implantation means the first time implantation, and secondary implantation means that the implantation at the end of the life, or during infection, or during the upgrading. These are the terminology I have used. And some conception regarding the understanding of the current situation of the CID infection. There are many limitations of the understanding of this limitation. It is agreed in the book, as because most of the conception on this fact are retrospective, based on the respective data and from the claim data from the company on the insurance. And still now there are some lack of knowledge regarding the diagnosis and treatment of this problem. And this is the unique problem where the infection has got both the cardiac and extracardiac connections, and many of the times both the patients and physician try to salvage the infected system and kills that time, and these are the reasons for difficult to deal kinds of the patients. So there is no universally agreed definition. Most of the working definitions of that is the working party consensus. These are the main areas of challenge of this kinds of the problem. This is one of the slides I want to show. That is this is one of the long follow-up slide. That is the 16 years. Although the results actually published in 2008, but it gives the idea of the 16 years result. The slide shows that from the until the 2004, the rate of infection was almost steady, but from 2004 onwards, there is a sharp rise of the infections, particularly because some introduction of the new devices, there is the complex devices, there is the ICD, CRT like this. These may be the reason. That is since that is from 2004 onwards, there is a sharp rise of the infections, and the infection rate is actually twice the rate of the implantation rate. So these are the global incidence of the infection. There are two terminologies for defining the infection rate. In the infection rate, that is the number of the patients getting the infection as percentage, expressed in percentage, or the number of the devices infected as infected devices per 1,000 or per device life year time. So these are the two ways of defining the infection, that is the incidence of the infection rate. The overall infection rate is 1 to 2% in case of the pacemaker, but the infection rate varies in case of the pacemaker, ICD, CRT, and in first 6 months, 12 months, or like this. So there are different data regarding defining the infections, that is the prevalence of the infection, but it is the rate of the infections, the most of the time that is being used. And CID infection, there are some categories of the infection, that the infection may be limited to the generator, that is the CID GPI, or the infection may be limited to the lead, that is the lead infection, or the infection may extend up to the endocardium, that is the infective endocarditis. So these are some categories of the infection, and the complications of the infection, most of the time the patient has got the morbidity, particularly the all cause of mortality and the quality of the life, prolonged morbidity, and particularly the draining of the huge financial. So financial cost is a very big problem, is one cause of the morbidity. And mortality is also a definitely problem. That is nearly 0 to 35% of the patient has got the mortality. And the mortality rate varies depending on the in-hospital mortality, 6-month mortality, or 1-year mortality. These are the different kinds of the defining the areas of the mortality. And cause of the disease, that is the pacemaker infection, is either the agent factor, host factor, or the procedural factors. And the patient-related factors are very much important, particularly comorbidity. Most of the patients may have got these kinds of the comorbidity, end-stage renal disease, diabetes, prior device infection, malnutrition, heart failure. These are the patient-related factors. Some procedure-related factors are very important, that is the post-operative hematoma or the complex devices like the CRT, long procedure, many persons inside the cath lab during the procedure, reoperation during the procedure-related factors, and some of the device-related factors, particularly number of the leads or the complex leads or the reusing of the leads or the devices, that is the old leads. So these are the related factors. And the agents, in most of the studies it is shown that the staphylococcus is the most common agents. Nearly about more than 75% of the cases it is staphylococcus, and other gram-positive organisms. In total, the gram-positive organisms is nearly 80%, staphylococcus including the streptococcus. And in another study, it is a Cleveland study, it was in the guideline published study, and it is in the Cleveland data. They almost similar result. Here also shown that the nearly 50% of the patients may have the culture negative data. Culture negative may be the one of the kinds of the problem. And pathogenesis is one of the stages of the pathogenesis, particularly after the colonization of the bacteria. There may be some biofilm formation, there is erosion, lead infection, and endocarditis. These are the stages. The patient may experience these kinds of the stages starting from colonization to endocarditis, and it may take a long time, starting from few months to several years. And this is one of the unique characteristics of the pacemaker pocket infection, that is biofilm formation. This is one of the battlefield for the bacteria. The bacteria uses these kinds of the protection material for them, that is to protect them against the bacteria, particularly when the colonization happens on the rough surface, particularly the metallic surfaces. These kinds of the that is the pathological protection may be done by the organism, particularly by the staphylococcus. So biofilm formation is one of the mechanism, and this is the reason why the antibiotic does not work in case of the pocket infection. So presentation of the patient may be simple swelling, that is the similar to that of the cellulitis, or the formation of the erosion, or the perforation. There are the three kinds of the presentation. Systemic presentation is that the systemic symptoms are most of the times lacking. The local problem is the main cause of the presentation. And diagnosis is one of the difficult problem, particularly when there is erosion or perforation. Diagnosis is not difficult, but at the level of the cellulitis it is difficult, as because it has to be differentiated from the hematoma or something else, whether there is a device extension or antibiotic should be given, or this is the big question. So these days, that is the hematoma is the very big problem for the diagnosis, but when there is a perforation or cellulitis, it is not a problem. And sometimes the ultrasonogram may help, that is whether there is any collection of the material or not, so it is also helpful. And treatment, in the case of the cellulitis, it is a prophylactic treatment, but when there is a pocket infection, there is no question, it is clearly written in the guideline that the device, the whole system should be explanted. But this is not done properly, as because most of the times that is lead is kept in situ, device is explanted, and the infection continues. This is the common practice. But this is not, is actually clearly written is that the whole system should be explanted. But the lead extraction is not a simple problem, as because it is a very complex problem, lead extraction, and it is a, this service is not available all the while. Many of our patients, we can do it, but some of the patients need some special center services. So prevention is the main issues, and these are the number of the patients I have dealt in my country. These are the patients I have dealt in my country. And this is my take-home message is that repeated antibiotic challenge should be avoided actually. Killing the time and repeated antibiotic challenge to control the infection is not the logical practice and is not actually not written in the guidelines. So proper treatment should be done, guidelines should be followed. That is, there is no questions about the whole system of explantation. So thank you very much for giving me the time. Thank you.
Thank you. Any comment from the professorial comment to your fellow?
Well, I think though it may not, and some of the people may not be interested, that's a common subject, but let me tell you, device infection is the most painful complication in electrophysiology or in cardiology. We should never take this thing lightly. I want to tell you just few from the data that what are the most important reasons for infections. Number one is early intervention. If you have to reopen the patient in the same admission, so your your pocket preparation, your proper bloodless field leave no reason for hematoma formation. Number two is a patient on steroid. Number three is patient has renal failure. Number four is CRTD versus pacemaker and ICDs. If you have CRTD, the number five is if there has been a history of fever less than 24 hours before the implant, even the counts may be normal. So you should avoid implanting the device if there is a history of fever less than 24 hours. So we say, no, today there is no fever and the procal is normal. I would suggest that one should wait more, be careful. Then we also know that the repeat procedures are more infection. I don't know why, but maybe we are careless. Oh, it's just a replacement of the PG. Then TPI is also source of more infection. So what we have done in our center is that we don't use TPI at all. We use the atrial lead. First we put the atrial lead into the septum, we use as a TPI. So we have stopped putting in CRTD in any patient. So these are the important reasons that one should avoid. And of course, the most important time when the infection occurs in the cath lab. Of course, there could be device infected from the manufacturer, but that's less likely. Sometimes there may be bacteria there also, but mostly 90% of the infections occur in the lab itself. So your lab's SOP should be very, very strong. I've seen patient entering without the nose is not covered, I mean, you should be very strict with all those people, minimum number of people in the lab. Antibiotic, no. Antibiotic, we give antibiotic, but the thing is that antibiotic should be given 20 minutes to
I'm
1
just
hour.
asking a counter question. Can you demonstrate that his nose bacteria is there in the pacemaker ever?
Say it again.
The person who has sneezed or coughed, can you demonstrate that his bacteria is ever found in the bacteria which is in the
I don't think there is study for that. So anyway, so one should be very, very careful. So I think this is the most important, serious point. You put a CRTD, 12 lakhs gone down the drain. I want to commit suicide if my patient gets an infection. It's a topic is very important.
Right.
You think, sir, you think using Tyrex upfront can prevent infection?
We have data with like if ICD devices or replacement, we are going for that. In those cases, I think it's
Dr. Clare is coming up. I think there is a large data from Israel published in 2021, how to salvage the lead with vancomycin 4 weeks, 6 weeks therapy without lead extraction, without doing the. Yes, Yadav.
I follow the Taiwan technique. What they do, before patient get admitted at least 1 day earlier, and they put gauze piece and soaked with chlorhexidine and keep it for 12 hours. So that because most of the bacteria is contaminated bacteria around the skin, and so they keep around 12 hours at least, and then take the patient for implantation. And what they have demonstrated by randomized study that those have been given and not given, they have shown significant decrease in infection.
I think there is not a single answer, like Dr. Clare.
Yes,
Makes sense, but nobody knows what causes the infection. It's microbiota, some people are saying. A PET scan has shown the positive scan, but the culture is negative. They have demonstrated a genetic study, microbiota.
Last
Yes,
comment
Dilip.
before sir starts.
Yeah.
So I kept this topic because I really feel it's very important. CID infections, and once it is done, it is a headache for doctor and a very, very trouble, botheration for patient. So antibiotics, post-procedure antibiotics have no role. This has to be known to everyone. Chlorhexidine is more effective than betadine. So you can go with betadine, then chlorhexidine, scrub is very good, effective. And if you are giving antibiotics, the patient should have taken antibiotic at least 30 minutes before patient comes to your operating table, before you put a scalpel over the chest. So these 3 points are very important.
He wanted to make a quick comment.
One very basic question, sir. If the patient
Dilip,
has
question to
already
you.
had pocket infection, so based on affordability, can we reuse the same device with after doing ETO, or we have to use a new device?
Yes and no. There are many yes, many no's.
No, certainly not at all. If you ask me, we should not use the. But there are very parts of the world are poor like we. So in situations where patient can't afford, I re-sterilize them twice.
Yes, double sterilization.
The device is sterilized already, it's lying in the lab, but I re-sterilize again before implanting. Then when you remove the device, you must thoroughly clean it.
Yes.
With the injection, remove everything. So it can be used, but technically says
No studies have shown increased chance of infection when you are reusing the device. China, they are.
So prevention is the best thing to prevent infection. Now we move on to the Dr. Clare's topic. Everybody knows who Dr. Just we can take up the question later on, if you don't mind, because time is done. CSP live implant from Boston. Over to you, sir.
All right. First of all, Dilip, thank you very much. I think he has been holding this symposium every year, and devices make almost 30 to 40% of our electrophysiology practice. We know that everybody knows that we have been fighting since many years. What is the best mode of pacing? We have also learned that the right ventricular apical pacing is not the best pacing, and there are papers to show that there is a decrease in ejection fraction. There is a pacing-induced cardiomyopathy in these patients. So that is how we went on to conduction system pacing. Of course, if you can mimic the nature, there is nothing better than that, because nature doesn't do anything wrong. So that's how the people started thinking of conduction system pacing, and conduction system pacing is a broad term. It could be his bundle pacing, it could be right bundle pacing, it could be left bundle branch pacing, it could be left fascicular, some kind of fascicular pacing, and it could be left ventricular septal pacing, and it could be deep septal pacing. When I say left ventricular septal pacing, means that you are putting your lead deep into the septum so that you capture the left side of the septal endocardium first. So you have to have a QR in a lead V1 to understand that this is the left septal pacing, not the right septal or the mid septal pacing. Well, of course the duration of the QRS, it follows, depends upon if it's his bundle, usually 55, left bundle 35, then left anterior fascicle 25, and then you do distal fascicle, then almost the QRS will start immediately after that, and depends upon at the level of the where do you pace. It depends upon the QRS morphology. For example, if it's left anterior fascicle, you have a 2-3 positive, or if you have the main trunk, again 2-3 will be positive. But if you have the septal fascicle pacing, then 2 is positive or isolectic, 3 may be isolectic or negative. If you pace the left posterior fascicle, then 2-3 will be in negative. So that's one of the ways to recognize where we pace the ventricle. So I think this we can. So I think there is difference in this slide. This is not this. So okay. So I need this was more in detail. So in the interest of time, I will just go. Now, what does the data say? Where should we pace actually? Whether the outcomes differ or not. So this is a study by Vidyanarayanan. This is the same outcomes for hard clinical outcomes. Like if you say death and heart failure hospitalization, whether you pace the his bundle or the left bundle, there is no difference. So this was almost 360 patients. The paced QRS duration during left bundle area pacing was similar to the his bundle pacing. There was no statistical significant difference between the primary outcome of between the left bundle area pacing versus the his bundle pacing, and secondary outcomes of death and heart failure admission were also not different in this study. His bundle pacing versus left bundle pacing, another study by some other authors. Here also, so you should understand that the his bundle area is less, around 2 square centimeters. Left bundle pace area pacing is much more. That's why it is easier to do. So it will depend, the time taken will be less in the left bundle pacing as compared to his bundle pacing. Again in this trial, pacing thresholds were lower, whereas R wave amplitude and lead impedances were higher in left bundle pacing as compared to his bundle pacing. The primary endpoint was more frequent in left bundle pacing, with left bundle pacing independently associated with the 9-fold increased odds of optimal device performance. Why? That's why, because in his bundle pacing the thresholds are high, the failures are high, but in left bundle pacing is much more device optimization. Left bundle pacing was less likely to have increased pacing threshold more than 1 volt as compared to his bundle pacing. At follow-up, the secondary outcome was less frequent in left bundle pacing than his bundle pacing, with left bundle pacing trending towards higher event-free survival because of the stability of the leads. Another study, pacing characteristics of his bundle pacing versus left bundle pacing. So if you see the implant success rate, procedure time, fluoroscopy time, implant success was better and the procedure time is less in left bundle pacing. The R waves, the at implant follow-up, the capture threshold at implant, at follow-up, they were better in the left bundle pacing as compared to the his bundle pacing. What about the QRS duration? Left bundle pacing has similar QRS duration and similar left ventricular improvement in patients where you want to do CRT in these patients. When we compare outcome of left bundle pacing area compared to his bundle pacing as a primary, another systemic review and analysis. Again in this there are 10 studies, implant success rates were higher in left bundle area pacing as compared to the his bundle pacing. Left bundle area pacing was especially with the lower capture threshold at implant and even follow-up, shorter duration, shorter fluoroscopy time. Compared with his bundle pacing, the left bundle area pacing was associated with decreased risk of all-cause mortality. This may be because of some of the failures which can occur in his bundle pacing. And there are little bit data to show decreased heart failure, rehospitalization also, but basically most of the studies there is not much difference. No statistical difference were found in the lead revision and QRS duration before and after pacing in his bundle pacing versus the left bundle pacing. Now we go to another concept, left ventricular septal pacing versus left bundle pacing. Septal pacing, as I was trying to tell, that you penetrate your lead so that you capture the left side of the septum with a QR in V1. What about this? So here also the procedure time was significantly increased in left bundle pacing as compared to septal pacing. The pacing QRS duration decreased more, 14 plus minus 41 in left bundle pacing as compared to left ventricular septal pacing. The left ventricular activation time was obviously more in the LV septal pacing as compared to the left bundle pacing. During 12-month follow-up, pacing threshold remained low and stable, and there was no significant difference in significant decrease in cardiac function. No adverse events were observed during follow-up of these patients. So does longer wait and greater QRS duration lead to more mechanical dysynchrony? This has been also studied. In 56 patient data was collected during left bundle pacing and left ventricular LV septal pacing. LV septal pacing resulted in longer wait. It's also understandable as compared to the left bundle pacing. But all three groups had similar QRS duration. There was no difference in the the strain pattern on echocardiogram vertical and radial, and the posterior septal delay between left bundle pacing and left bundle fascicular pacing, anterior or septal or posterior fascicle, and LV septal pacing. There was no difference in the echograph findings. So, if I have to conclude in my very brief talk, his bundle pacing is the most physiological form of the pacing that can be achieved. I think we all agree. Left bundle pacing can be easily be done with a better success rate as compared to his bundle pacing. His bundle pacing and left bundle pacing have comparable primary outcomes as far as the death and the heart failure readmission is concerned. Of course, when we do left bundle pacing, you have to understand we are creating some degree of interventricular dysynchrony, because the right ventricle will get delayed activation, but it has not resulted in any kind of clinical endpoint difference. Left bundle pacing has a better pacing threshold, better R waves, lesser long-term threshold rise than the his bundle pacing. Left bundle pacing has established itself a preferred mode. That's the scenario in the world today. I don't know the future. The left bundle pacing has better LVAT and QRS duration, shorter QRS duration than the left LV septal pacing. LV septal pacing has comparable mechanical synchrony and the left bundle pacing than despite having longer LVAT. Now, why people are even thinking of LV septal pacing? Because some of the people it may be still difficult to capture the conduction system. If it gives the same result, then we don't have to be very, very particular. But I think these things will evolve in future, and we are still learning as far as this topic is concerned. I think thank you very much.
Thank you very much, Dr. Clare. Good talk. Now we have very encouraging data on pulse field ablation on atrial fibrillation and heart failure. A patient AF and heart failure, if you are given two choices, AF ablations and AV nodal junctional ablation followed by his bundle, which one will be preferable?
No, can you please repeat the question? Sorry.
Okay, AF with heart failure, one arm you have AF ablations, pulse field.
AF ablation.
On other arm you have junctional ablations followed by his bundle pacing or LVB pacing. LVB pacing will be more comfortable and safe than...
Yeah, I'll answer before you finish the question now.
Don't ask me questions.
I will do AF ablation as compared to ablating the AV node and doing the conduction system pacing. Because if God has made the atria, it has a meaning. So certainly I want to keep the AV synchrony.
Okay.
But yes, where AF ablation is not possible or there is recurrence, the atria are large, then certainly AV nodal ablation and physiological pacing.
There are also...
ABBA CHF trial, the same thing has been compared. Pulmonary vein isolation versus AV node ablation along with biventricular pacing. And what it showed that PVI is better as compared to AV junction ablation and biventricular pacing.
And there is
replaced biventricular pacing with the conduction system.
In continuation to that, many cases everywhere in India, maybe AF with sick sinus syndrome, we tend to put pacemakers, but the first line of treatment is AF ablation. If you ablate these patients, PVI isolation you don't require a pacemaker, and the patient will not having bradycardic episodes.
So in your vast experience, what has been the incidence of pacemaker-induced cardiomyopathies? And in sense, like ventricular septal pacing never really came up. So that taking these two together can give us an idea whether LVB pacing can become the default pacing mode in future, sir.
Yeah, I think in left, the cardiomyopathy induced by the pacing, our philosophy previously was to do a bi-V pacing, but now we do a left bundle pacing.
There is a trial, ESC, upgradation trial.
There is data also.
Data on that. Dr. Karthik, yeah.
So, answering to your question, I would say if there is a Brady indication, if the patient had syncope and possibly had sick sinus, I'll prefer first do AV nodal, first do his bundle pacing or left bundle pacing. May not do AV nodal ablation because we have seen, and in fact the studies have also shown that once you do conduction system pacing, the chances of AF also reduce. I can leave AV nodal ablation or AF ablation later on if the patient has recurrent AF with symptoms. No, if the patient has a Brady indication, syncope, then even with the AF ablation.
That's correct, Karthik, because we have seen, I think all of us have seen patients with cardiomyopathy, AF, and when you do the CRT, conduction system pacing, LV remodels. LV remodel, the chance of AF go on decreasing and decreasing.
So I think in the past hour we are listening to these talks. So ultimately, what about the good old CRT? So what is the indication left? That is what we need to.
Yeah, very good question. That's my own view. That's not recommended by AHA or European Heart Rhythm Society. Our standard of care is conduction system pacing for every patient who needs CRT or Brady pacing. We don't do traditional CRT, but when we do the conduction system pacing, which practically means left bundle pacing in our center, if the QRS duration we are not happy. See, most of the times with left bundle pacing alone, you get less than 110 milliseconds. Many patients less than 100 milliseconds. But if you are on 120, 125, there we put LV additional lead, because these are the patients who have distal conduction system disease, where we would like to synchronize between the conduction system pacing and the LV lead. And you get further narrowing reduction. So this is the concept of hot CRT and the lot CRT.
I think Dr. Claire, as usual, is moving ahead from guidelines. As far as the guidelines are there, HRS 2023, less than 35% ejection fraction, typical LVB, CRT indication. Still CRT is the treatment of choice. If we can't do CRT, there's no good vein is there.
Yeah,
only then CSP can come in. But the patients with 35 to 50% ejection fraction, there we need to go a CPP kind of cardiac physiological pacing, and then both CSP indication stays there as a class 2 indication. So there we can put with guidelines recommendation, but less than 35%, I think guidelines still endorses CRT. In future maybe it will change because of the...
See, for guideline changing, they take long enough time. Yeah, they will take a lot more data to change the guideline.
Sir, my question is that actually the real life scenario 2 days back I encountered. 77-year-old gentleman came for battery replacement. So we did the echo. Echo is 30 to 35%. His effort tolerance is 3 flights of stairs. He's absolutely asymptomatic. Never echo was done. He just came to check the routine battery. And now the EF is 30-35, no symptoms. And what shall we do? We shall...
I will always.
Even without symptoms, we should upgrade.
He's 70. I will.
77, sir. 77 years, sir.
Yeah, whatever he is, we will do a left
bundle and upgradation. Sir, thank you very much, sir. In the interest of time, should move forward. Can you introduce our next speaker?
I call Dr. Karthik, sir, for his presentation on CSP way forward. Latest catheters in pipeline. Thank you.
We met Karthik in many forums. He is one of the innovators, thought leaders in the field of electrophysiology, pacing, and devices. Our pleasure, and we're blessed and quite, happy to. I'm waiting for his lecture. Karthik Bhargava.
Thank you, Dr. Hazra. My dignitaries on the dais, Dr. Claire, my mentor, and Dr. Dilip, who has invited me here. Thank you very much for the same. So I am going to present a new catheter which has just been introduced, in fact not even launched right now, which is an Abbott CSP locator 3D catheter. And through this we can do conduction system pacing with the stellate driven leads, and the Abbott leads, the Trendle lead. So this is, I'll just show a couple of cases. So this is a 41-year-old lady, recurrent history of syncope, has been treated as seizures for last 5 years. But the ELR done typically showed paroxysmal AV block with total underlying normal QRS at baseline. All her investigations, including echo, angio, MRI, have all been normal. And so this is a typical paroxysmal AV block, and patient was planned for a dual chamber pacemaker with conduction system pacing. So we used the new Abbott tools, the CPS locator 3D, the helix locking tool, and the required Agilis Hispro slitter. So this new catheter again is available in 2 different sizes, 42 centimeter for the usual lead length of 58 centimeter, and if we need to use a larger 45 centimeter catheter, we need to use a larger 65 centimeter length lead. And again available in 3 different curves, small, medium and large. We have used medium curve in both the patients, and I believe that is the usual curve that will be used in most adult patients. It has an outer diameter of 9 French, so if you need to use a smaller introducer sheath, so maybe larger than 9 French will be needed. And if you can use directly, it has an inner diameter of 7 French, so any lead less than 7 French or so can be introduced through this. It has a radio-opaque soft distal tip and a hemostatic valve with a side port for flushing and for contrast injection if required. Along with this, there is a new tool, a helix locking tool. We know with Biotronic we have a stylet guide which locks the stylet also, and so a new accessory has been developed by Abbott, which is the helix locking tool, with which we can extend or retract the helix, and also maintains the helix in extended states, pre-tensioning the lead, the helix before we start rotating it into the septum, and also allows the PSA alligator clip connections to be put on the lead pins. Also, one can use this same tool to rotate the lead while to penetrate into the septum. So penetration I'll show with you in the next video. So this is how we just, the same way that we implant the lumenless lead, except that it has a lead which is a stylet, and the helix need to be extracted once the lead is inside the catheter but not outside of it. We position the catheter, I typically do it in RAO view, and look at the fluoroscopy and the ECG morphology. And traditional morphology lead 2-3 discordance, 2 a little positive and 3 more negative. AVR and AVL positive, AVR negative and AVL positive, again a discordant, and a V1 showing a QS pattern with a notch in the downstroke of S wave. And once we start rotating at the target location, looking at fluoroscopy, we can again connecting the alligator pin to the stylet, do continuous ECG paced QRS morphology monitoring, continuous impedance monitoring, and midway when we measured here, the QRL looks quite narrow. The LVAT was 78 millisecond, which is quite acceptable, but the V6 V1 interpeak interval was a little shorter of 24 milliseconds, and the QRS but about 120 milliseconds. So we did couple of 2 more turns, and in this patient we got an LVAT of 65 milliseconds, which is quite good, and that's usually we see when the QRS at baseline is usually narrow, and the interpeak interval became 40 milliseconds, which is quite good, and the QRS was about 100 milliseconds or so. Now left bundle potential, typically if we look for it, we will see it in about 70 to 80% of all our patients, and it was very well seen here with the left bundle potential to ventricular QRS potential interval of 22 milliseconds, and this is the ECG during unipolar VVI pacing that we saw. And these were the final fluoroscopy lead position. Typically I rotate the lead in the RAO view after confirming in the LAO view that I am against the septum, because it makes it more convenient to use the RAO view, because it doesn't hinder in your movements. This was the final, this is the baseline ECG of this patient, which is narrow QRS. We reduced the AV delay just to demonstrate that how does the QRS look like with pacing. So this is unipolar pacing. You can look at the QR pattern in the lead V1, and the lead 2 shows a positive QRS and a very short left ventricular activation time. Even the bipolar VVI, where you can see the intrinsic beats as well as the pace beat, you can look at the difference. The QR pattern during pacing is very well evident. In the second case, elderly gentleman, traditional Brady indication, bifascicular block with prolonged PR and recurrent syncope, normal LV function, normal coronary. So this was the baseline ECG, quite broad, about 145 or 150 milliseconds QRS. And this is how we do the catheter preparation, simple flushing of the catheter through the side port, and then with the lead we attach the helix locking tool at the end of where the lead pins are. We can just slide it through the stylet because it has curves in between, and then extension of the helix, I do it once the lead is inside the catheter, not before entering, because sometimes it can damage the valve of the catheter, or the helix also can get damaged while you are introducing into the catheter. So this is the helix locking tool. as I says, once the catheter is in mid-right atrium, I put the lead inside and then extend the helix. And once the helix has been extended, I give 4 or 5 more turns, and the helix locking tool keeps the extended helix in place, does not let it to come back or retract back. You can also see that we have placed an atrial lead as a backup in the RV before we will pull it back into the RA and place it just for as a temporary pacing backup. We tend to avoid transfemoral temporary pacing in most of our patients. And again, in the RAO 15 or 20 degree view, we find we enter the right ventricle, and then with a little counterclockwise torque and pulling the catheter a little back, we find in the area from the estimated site of the His bundle to the apex, the line joining, and just about 2 centimeter or 3 centimeter distal to the site of estimated His bundle, we place our catheter tip, confirm in the LO view that we are at the septum, perpendicular to the septum, and then confirm the ECG lead location with the paced QRS morphology, which is again, as I said, 2-3 discordance and AVR-AVL discordance with a QS pattern in lead V1 with a notch. And then we do the, in the RAO view, typically I do the rotations, lead rotations. And with this catheter, which is the new catheter, it's quite stiff compared to the Biotronic catheter. And so I think it gives much better support for rotation of the lead. And we don't need to rotate the lead too much. The torque transmission with this catheter of the lead is quite good. And once we rotate, after just 4 or 5 turns, we find that we will see the template beats, the fixation beat or the template beats, and a QR pattern in lead V1, suggesting that we have reached the lead bundle, the left bundle area. And if you simultaneously look at the QRS morphology and the lead impedance measurements, you can confirm that you have captured the left bundle. You can do your measurements, measure the threshold and the impedance, look at the R wave and the current of injury and left bundle potential if it is there. If you have a good current of injury, be assured that your threshold over long term are going to be good. And then again, you measure your LVAT at 2 volts and at 5 volts. And if they are short and constant, again a good sign. And then finally, you measure your interpeak interval, that is the interval between the peak in lead V1 and V6, which if it is more than 40 milliseconds, confirms that you have captured the left bundle branch conduction system. So just a short tips about how do you look at the criteria for confirmation of left bundle branch capture. There are a lot of criteria which are available, but to be simple, if you get you look at the QRS before you start screwing on the right ventricular side of septum, lead 2-3 discordance, lead AVR-AVL discordance, and V1 showing a notch in the downstroke of QS. Then once you start rotating, look at the QR pattern in lead V1, which usually should be there. And for left bundle branch confirmation, capture confirmation, look at the left bundle potential, the LVAT at 2 volts and 5 volts spacing, and the interpeak interval between lead V1 and V6 should be more than 40. So if you have at least one of these, you are 99% sure that you have captured the left bundle branch conduction system. Looking at the current of injury, as I said, if you have good current of injury, the chances are that your thresholds are going to improve further over short term. And this is measurement of LVAT at 2 volts and then again at 5 volts, which was quite good, about 72 milliseconds in this case. You can do continuous monitoring of impedance and current of injury and the QRS morphology when you are using stellate driven pacing leads, because you can attach your alligator clip to the stylet, which is just outside the lead and does not hinder with your rotation of the lead into the septum. And this is a particular advantage over using the lumenless leads in the present time. And this is how you look at the ECG continuously while you are rotating, which is not possible with the lumenless leads. And in this patient, you see that once we attain the final position, the QRS does show a QR pattern, and the QRS is much narrower than the baseline bifascicular block pattern. And this was the final fluoroscopy position. And these were the ECG. This is the baseline ECG showing right bundle and left axis with prolonged PR, and this is with unipolar pattern pacing at a shorter AV delay than is PR interval, showing a narrower QRS with a QR pattern in lead V1, and again a bipolar even looks much better. So in summary, CPS Locator 3D is a new delivery catheter for conduction system pacing. We have just done about 2 cases with this till now, not done any His bundle casing, because most or almost all patients' conduction system pacing cases are with left bundle now. Available in 2 lengths and has good torque transmission, allows conventional stellate driven leads to be used for conduction system pacing. Helix locking tool is a useful accessory to lock the helix in extension, and also allows the alligator clip to be attached to the stylet, and can also be used to rotate the lead for drilling into the septum, though I prefer to rotate the lead using the lead body closer to the end of the catheter. And these new delivery tools are the latest in the armamentarium of CSP, and will likely allow expansion of CSP to more implanters by shortening the learning curve and the procedure time. In fact, I would say that the time required for conduction system pacing, in my experience, is actually not more than the conventional RV lead, because when you place the conventional RV lead in the septum, you need to take time, take the stylet out multiple times, reshape the stylet. So all that consumes much more time. And with this technique, it hardly takes any extra time over your conventional RV lead. Thank you so much.
Thank you. Before I take a few comments, like, as I said, the first thing is to entry into the RV. How do you enter? The Karthikeyan has shown his own style. If you start from RA, then you enter the RV, there's always a probability chance of catching the septal leaflet. And if you try to push through the septal leaflet, you get a lot of resistance, it may be a failure. So try to enter in the RO, has mentioned that you try to enter in the RO, complete RO in AP with the wire, with the sheath, everything. You start from the apex, from the below, then move upward. This is number 1. And number 2, sometimes you know that the helix retreats back. I mean, it gets inside again, you fail the resistance forward. And then you, as he has mentioned, you go to the RO again, check the helix is actually out, otherwise you will get displacement. Third, once you're done with the voltage, try to pull the little bit so that your sheath dives in rather than your whole thing is coming up. If you see the sheath is moving forward, you are sure this is not going to dislodge. With that, I will take up few questions and comment. Yes.
Suppose a patient post PCI enteral MI, the thinned septal part of the LV area around 7 millimeter or 6 millimeter. Would you stop much earlier than screwing into the septum? Because there are chances of perforation of the septum in that case. And the second part of my question is, who is already having an LBBB and QS complex because of the infarct. So what is the ECG criteria there? It will be that you will stop that you have touched the LV area or so forth like that.
So first question, if the septum is thin, of course that's the major advantage I would say of using stellate driven lead for conduction system pacing, because you are continuously monitoring. You don't need to go beyond the left ventricular side of the septum and then reposition your lead, because you are seeing once you are through, once you see the QR pattern and see your LVAT has shortened suddenly, you are sure that you are capturing the conduction system, so you don't need to make any more turns. So it's difficult to perforate with that. But 3830, because you have to intermittently check, there is a chance of perforation. Having said that, in our practice, we usually do not look at the septal thickness specifically in patients who are being taken for this pacemaker procedure, but it's a good idea to check that. The second question was patients who have left bundle branch block post anterior wall infarction, you said. So in fact, I would like to say that first of all, this thing that patients with anterior wall MI and left bundle branch block is actually quite uncommon. Contrary to the popular belief, if a patient has anterior MI related left bundle branch block, his damage is so extensive that ultimately he is going to have complete heart block and left bundle branch block. In fact, patients who have inferior wall MI may have residual left bundle branch block, and in those patients, the criteria should remain the same. I don't think there should be any difference.
Okay, so thickness is important, whether it's thin or thick. You have to know that if you give too much of pressure and forward, it can perforate. But perforate is not going to kill the patient because it's a very small person. Arijit. No, it can come back. It can come back. Medtronic one. It can be very thin lead. Very unlikely. Anyway, it can any bizarre thing can happen in life.
It is the other way around. Sometimes in the stylet-driven lead, it will get stuck up, and the reason is some implanters, what they do is once it is inside and you retract the helix, that should never be done. If you do that, then you are taking the tissue inside the lead, and then the lead won't come out. The lead will get stuck. So that thing should never be done. You need to rotate the whole lead counterclockwise and pull it back. If you retract the helix, once the lead inside the septum, you are taking the tissue of the septum inside the lead, which is then the lead is stuck.
And especially it goes through the septal leaflet. You give the negative turn. Yeah.
One of the concern is like 3830 is a thinner lead, and 3-4 times you reposition it, try out new places. It doesn't give a large area of damage in injury, but this stylus-driven leads, if you reposition twice or thrice, we are apprehensive about the amount of injury which you are causing at septum.
See, with the experience, I would say that now the repositioning, the chances are actually quite less. I usually, with the ECG morphology and the fluoroscopy position, we usually implant the lead in the first position itself most of the times, unless the lead is not getting in because of very firm septum or some issues like that. But position wise, it is usually not the problem. So I would say that it's not a big problem. I have never seen any problem with in fact, all the complications that have been reported, few complications like lead fracture and all, I think if your implant technique is good, it's very unlikely that your stylet-driven lead is going to have problems. But if your implant technique is bad, you can have problems with both the leads.
But you have to remove the meat from the helix by using insulin syringe or a syringe, 20cc syringe with saline jet. Arijit.
So this is, I will be sharing one experience. Shubhashish, please supplement me if I am wrong. So this is implantation that we have done 1 week back. So I can show you the ECG. We are not having classical RBBB in V1, but we are having RBBB which starts from V2.
Yeah, so in fact there was a recent paper which also had looked into this and have suggested that if you place your leads one intercostal space below, its sensitivity of recognizing this pattern becomes much higher. And in fact, I would think that it is much more important to do so in patients who have large emphysematous chests. And so look, the body habitus and the lungs of the heart is very small and looks vertical. It is a good idea to place one space below, and then you are more likely to see a QR in V1. Having said that, there is another explanation given that you may still confirm lead bundle branch capture, but may not see QR pattern in lead V1 at all, and there are multiple explanations have been given, hypothesis for that, but that is a very rare scenario, happens in 2 to 3% in literature.
Thank you. I think we can move on to the next presentation. Dr. Parida?
This is in fact simpler. 3830 you need to rotate very rapidly. This you can do at your pace. This is in fact, I find this much simpler than 3830.
Yes, now we are moving into a very interesting case presentation by Dr. Parida. Yes, Parida, yes.
We have a live,
from Durgapur.
Live case from Medica, from Boston CSP at 2 o'clock. So we will not do some of the presentations which are there before. 1:30 we'll disperse for lunch, and half an hour we'll come together. Yeah.
Good afternoon. This is thanks Dr. Dilip for inviting me for some case presentation.
Which cure is better, Kartike, RBB or a narrow LBB like? After CSP, you get RBB, typical RBB, versus narrow LBB like.
Purists would say that QRS duration does not matter actually. In fact, the widest QRS you will see when you have selected blood-bundle capture.
So answer is RBB. Go ahead.
Yeah, I will present some challenging CRT cases. Doing CRTs, we faces lots of problems sometimes. We are almost doing 10 to 15 CRTs per month, but some of the times we face challenges. And this effectiveness of CRT decreased 30% of recipients for several reasons. Loss of LV stimulation plays important role, mostly due to lead dislodgement. So epicardial lead is a suitable option in this condition where there is lead dislodgement. So loss of LV stimulation chiefly because of LV lead dislodgement and this ratio around 2 to 12%. And this precludes clinical improvement. This is one case where a 55-year-old man was planned for CRT, and this is the ECG before the CRT, and we did the angiogram for the to see the CS anatomy. And we deployed the LV lead, but after the deployment, after the slitting, and we have started stitching, and we found the lead is dislodged. So after dislodgement, again we put the lead, second time also it got dislodged. So in this case, what to do now, already 1 hour has passed, so we planned for stenting. So how to do the stenting? We took the sheath and 2 wires, and in one wire we took the LV lead again, and another was kept for the pacing sheath. And side by side we took the RCA catheter, catheter, and took the wire alongside the LV lead. And this lead entrapment behind the deployed stent was deployed. It is 3 into 15 millimeter stent, which were deployed at 8 to 10 atmosphere. And this is the final result. So you got successful after 2 failures, and this is the final result. The same again, another case where we did the same stenting. So this deploy stent at a nominal pressure 3 centimeter distal to the venous branch take up, and distal part of the stent was 1 centimeter before the LV ring. The retention stent should be smaller by 0.5 to 1 millimeter than the vein diameter. And the concern is insulation defects of silicon cover and difficult to retrieve the lead if required. Coming to venoplasty before LV lead deployment, this is another case, and this is the anatomy of the vein, that tributaries. So this is the only vein which is available to put the lead, but there was stenosis. So initially we tried to take the LV lead, but it was much difficulty. We were not able to cross the lesion. So what to do? We planned for plasty before putting the lead, and we serially dilated the vein with 2 millimeter balloon followed by 3 millimeter balloon. And after the venoplasty, we were successful to place the lead. And this is the final result. Coming to cornea sinus dissection. So, in this case, the anatomy was very suitable for a LV lead placement. Sorry, it is hang ho gaya. No, इसको पहले इसका पहले या इसका पहले ये इसका हाँ ये हाँ हाँ So it took decapolar and cannulated the CS. We put the lid, but while slitting the sheath, the lid got dislodged. Then again we took the decapolar and cannulated for putting the LV lid, but this time we are not sure where is the sheath, because this time we are not able to aspirate the blood. So we thought it might have dissected. Showing this case is important because at that time you should not inject to see whether you have dissected or not. So we took another wire side of this sheath, but that also we are not sure it is showing it was going somewhere else. So what we did, we took this angiogram, and this angiogram showed that we have dissected and the sheath has perforated the coronary sinus and it is outside. And in the echo showed there is a mild pericardial effusion, but no evidence of tamponade. So we tried 2 to 3 hours, and in this case Dr. Yadav was with us at that time. He was in our cath lab. So Dr. Yadav came into picture and he tried for 2 to 3 hours and put the another wire and removed the previous sheath, and this is the final result. But removing after the removing the sheath, there was pericardial effusion, though there was hypertension, but there was no need of any aspiration, and successfully done. And this is another case, LBB with follow-up case of dilated cardiomyopathy presented with syncope. And this venogram showed that it is LSVC. So in this case, whether to proceed or not, go for epicardial lead, till you plan to do it. So we took 3 wires, and the sheath was placed in CS and the vein initially, kept the lead there, then it put the RA lead, followed by the LV lead. LV lead put through the curved catheter of LV pacing, and after putting both the RA lead and the RB lead, then we deployed the LV lead. Then at last the sheath was removed and it was successfully done. And this is the final result.
How many hours?
Took just 1.5 hours. It was initially we thought it's very difficult, but it was done nicely. in 1.5 hours. And this is the final result. Thank you.
Thank you. Excellent demonstration of difficult cases. Any question from the panel, or Dilip?
What was the problem from going from right side in this case?
Pardon?
Why didn't you go from right side in this case? Last case, see, LSVC.
Left side it is.
Left side. No, right side connection was there or not? You could have gone from right easily, could have done it.
Because we have
Already
done,
given an incision.
many LSB cases in dual chamber pacing. So we thought it will be easy, but vein was visible. So we thought we should try from the left side.
And for that we use a CS lead.
Sheath from Abbott or any other thing is very easy to enter into the coronary sinus. The sheath of CSP is so good, and if you have to exchange, once you enter into coronary sinus with the CSP catheter, then you have to exchange your original, or you can go over that. Okay, so
In this case, you see the RV's catheter, RV's lead is in the mix.
As the next speaker, can we have Dr. Sanjeev Mukherjee? Thank you, Dr. Parida. Dr. Sanjeev will be speaking on possible combinations of lead connections in LOT CRT.
Respected chairpersons, my dear friends, good evening. So I am standing between lunch and Dilip, thank you. He wanted to have these connections discussed once. I think Dr. Shanmugam has already discussed once. No. So we'll just go through this. Third session. So I think I have kept it very simple. It's mainly because this one, yes. Yeah, so possible combinations of lead connections in LOT CRT in the next 10 minutes. So as you all know, it's, what do we do in a CRT? Simply we do a BIV using both RV and coronary venous pacing, and it does improve symptoms, mortality benefit in a case with LVBB and LV systolic dysfunction. So LVB area pacing has come up in the past 2 hours. We have discussed about LV area pacing. It has definitely become an alternative to his bundle pacing, and does give us a stable threshold and produces a short QRS. So LVB area pacing with a sequential optimized CRT is what we call as LOT CRT, and it combines actually both of LV area pacing and CRT as far as device is concerned. So why do we need it finally? What is the rationale behind going for a LOT CRT? And that's because of the limitations of CRT. And why is a CRT limited? And these are certain points of it. We know that in a CRT you put the RV lead where it is muscle to muscle conduction, and that itself has got a desynchronizing impact. You've got a single area non-physiological epicardial pacing. When you pace epicardium, it is not a physiological area. Again, it has to come from fiber to fiber down. There is some amount of intrinsic latency that you have, and very often you have got a suboptimal LV lead positioning because of unfavorable anatomy. So these are limitations. LV scars, especially in a ischemic cardiomyopathy, when you are putting a CRT, you will come across a lot of scars which will cause some amount of delay as far as capturing of conduction system is concerned. So because of these reasons, CRT has got a 1/3 rate of non-responders that we all come across, and this can be higher in anatomical aberrations. So that is a reason why we need some amount of alternative, and there LVB area pacing has come. Is it the final solution? Answer probably is no, because we know that patients who are put in LVB area pacing, they have got underlying conduction system disease, which is many a times progressive. It can be a Purkinje network which gets diseased, myocardial level disease. So over time, your LV area pacing also can cause QRS widening. So in that subset of patients, probably LOT CRT is the answer. We still do not know. Do we have data as far as QRS narrowing is concerned? Answer is yes. If you do a BIV, QRS narrows by about 6 to 20 milliseconds. LOT CRT is about 38 milliseconds. And if you do a His bundle optimized CRT, it comes to about 60 to 63 milliseconds, which is maximum. Because in a LOT CRT, there is an intrinsic RBBB that causes some amount of delay. But we know that in a His bundle pacing, your area of target is very small, and we have all moved to LOT CRT now, which is more helpful. How does it act? Of course, the major rationale that they say is direct depolarization of the conduction system. We have all discussed that, and you actually avoid cell-to-cell conduction. What are the limitations? Again, before jumping in any kind of a solution, you must know what you are going to encounter. And I think time consumption, these are patients who are sick. You should select your patients well. Data is still small. We do not know. And probably which is the subset of patients where you are planning a LOT CRT. I think that is not well defined. If you give me a choice, I think it's an ischemic cardiomyopathy subset with a very wide QRS. The QRS may not be typical LV. So this probably is a subset where we can think about doing a LOT CRT. And what do we do? What are the connections? Now, all of us who implant devices nowadays, if it is an ICD, we all implant a DF4 lead. What is a DF4 lead? After 2010 ISO, this is a 3.2 millimeter lead which has got all pacing, sensing, and both defibrillation in a single lead. So that is what your DF4 lead means. Whereas previously we used to put DF1 leads where you have got 3 arms of the lead. One is a pace sensing, other 2 are defibrillation ports, and it is a bulky device. When you put a DF1 lead, it's a bulky device. Normally we prefer putting a DF4 device because of various advantages. It's a small device. The chances that you can miss out on fixing the leads, that is like what we call, you can put the leads wrongly. So those kind of things are avoided in a DF4 lead. But when you are planning a LOT CRT, you will have to take a DF1 lead, a DF1 device, because you have got these choices where you can fix your leads. So you will have 3 arms. The pace sensing, on the top you can look at DF4 lead. This is how a DF4 lead looks like. All 3 ports, everything is there in a single lead. In a DF1, you will have separate ports. You can select separate ports and you can play with them to put in a device. So how do I do a LOT CRT device? So LBB area pacing, you put a lead in LBB area pacing and you have got a bipolar LV lead. So this is how your connections will be. Your CRT leads goes into the LV port. Your LBB area pacing lead goes into the RV pace sensing port. And you have got your defibrillation lead which will go into the defibrillation port, and you need to cap your RV pace sensing port. So this is how your combination of leads will be when you are putting in a LOT CRT device. It has to be a DF1 device, and this is how you'll be arranging your ports when you connect this device. You can, as Dr. Shanmugam said, that this is another way of doing it. If your patient is not very affording, you want to do a LOT ICD, where a dual chamber ICD PG can be utilized, kind of using it as a LOT CRT, because then what you do is you put a LBB area pacing lead, that lead goes into the pace sensing port. You have got your RV defibrillation lead which will go into your, these are your defibrillation ports, and you'll have to cap the pace sensing lead. So this is the simplest combination you can use when you are using a dual chamber PG of an ICD for using it as a LOT CRT kind of a pattern. Quickly going into programmings, I'll not give much time here because this will need some amount of understanding. But normally a pacing mode, when you talk about, if you have put a device in a dual chamber mode where your LBB area pacing lead is there in the ventricular port, it has to be a DDDR or DDI. But if you, in a patient of chronic AF, where you have put in your lead, your LBB area pacing lead in an atrial port, there DDI is preferable. Pacing polarity, again, unipolar is preferable, but bipolar, if it is anodal capture, is required. Here I'll just add one word of caution. Make sure that LV capture management is not on, and this is specifically true when you are using a Medtronic or a Boston device, because what the device will do is, suppose you have kept your RV sub-threshold, I mean you have kept your RV apical lead and you have kept it sub-threshold, then in that case, if you have kept your LV capture management on, then the device will pace at the rate that you have kept. I mean, suppose you have kept an amplitude of say 0.5 to keep it sub-threshold, that is what it will pace at when it is going through an LV capture management. And in that case, the patient might develop an asystole. So therefore, keep your LV capture managements off when you are using a Medtronic or a Boston device, but if you're using an Abbott device or a Biotronic device, you can keep it on, because when it goes for a LV capture management, the backup threshold is 5 at 0.5. So it is not going to go into asystole, but if it is a Medtronic or a Boston device, LV capture management must be switched off when you are using a LOT CRT arrangement. What about sensing vectors? Again, usually we all keep a bipolar sensing, and this is CSP lead in atrial port, sensitivity of atrial chamber at highest value. Again, if you are putting in your, suppose patient has got an atrial fibrillation, and if you have put your LB area pacing lead in the atrial chamber, then you keep your sensitivities high, and the highest that you can program is 4 millivolts. Keep it at that, otherwise there will be sensing issues as far as this lead functioning is concerned. Sensitivity, normally LBB area pacing, R-wave sensing is very, very good. Don't have to worry. This comes in when his bundle is concerned, but we are all doing LBB, so that is not a concern. What about auto capture? Very often we use auto captures in our normal pacemakers. And here also, let the device check. If the auto capture thresholds are good, you can actually keep an auto capture on. What about AV delays? AV delays, again, in an LBB area pacing lead, you don't have to worry much. It is about 20 milliseconds of difference. So a standard programming, 160, 180, 140, 160, similar kind of programming you can use. So a minute more, if you have put the lead in the atrial port, then obviously you have to see the QRS to determine the AV delays. What about VV delay? Keep it at maximum 80 milliseconds, that should take care. Quickly going into other parameters like ventricular safety pacing. When we are doing a CRT, we all use this ventricular safety pacing. In this case, I would say rather simply keep it off. So ventricular safety pacing, keep it off. What about auto AV-VV optimization in CRT? Again, inactivate when you are doing a LOT CRT using the same PG. So off VSP, off automatic AV-VV optimization. What about triggered ventricular pacing algorithm for CRT? That whether you use that, again answer would be no, inactivate if you are using a LOT CRT. And as far as ICD programming is concerned, if you have put a CSP lead in an atrial port of an ICD, dual chamber discriminations are not going to work. So what you do is switch them off, only keep your onset stability and morphology. So meaning by that these devices are not meant for CSP, they are evolving, and so you have to do certain amounts of programming change before you use them for a LOT CRT. I think I'll end it here, thank you.
Can we have some quick questions from the floor before we break for lunch?
Yeah, I think it's very important, many times we do the, procedure and the company reps their program and they forget to do many things which needs to be done. And auto capture has to be stopped and turned off, and LV capture management and many things. So it was very important, pertinent topic, and we should be giving more attention to it.
Yeah. Thank you.
Thanks, Sanjeev. So I think thanks to chairpersons, moderators, and everyone will disperse for lunch. And our live case will start at 2 o'clock. So we will grab lunch and we can come inside and sit. And
হ্যালো হ্যালো চেক দেখো হ্যালো 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 চেক হ্যালো 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 চেক হ্যালো হ্যালো চেক হ্যালো 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 চেক হ্যালো একদম হালকা তো একদম আগের থেকে কমে গেছে তো পুরো চেক হ্যালো হ্যালো hello, 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 check, hello, 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 check, hello, 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 check, hello, hello, check, hello, hello, check, hello.
ठीक है, ठीक है।
ऑन कर दीजिए, लाइव ऑन कर दीजिए।
कल SSP बोलते हैं।
Good afternoon, everyone.
Corrective side. SSP
Yeah, there's no.
2 and 3.
Mic is not working.
From the right side. From the right side. Yeah. It is not defective enough.
They'll at least chairpersons like CSP live.
Good afternoon, everyone, and I request everyone who has completed his lunch to join us in the room. Live case is just, I think it has begun, and Devpriya, I can see him going for a puncture. May I request chairpersons of this session, Dr. R.D. Yadave, Dr. Mayanak Mukhopadhyay, Dr. Silanjan Roy, Dr. Colonel L.S. Monga, Madhumanti, and Ishita Majumdar to kindly come to chair the session.
Sir, can you hear us?
Sunil, Devapriya doesn't have any earpiece and mic with him.
Hello.
Sunil, there is any problem? Do you have this code here?
Small pacemaker, so small property is enough.
Can you hear us, Dr. Claire?
Hello.
Yes, sir.
We can't hear you. I think there needs to be some adjustments to audio is to be made. Devapriya, we can hear you. You are saying something which can hear. So you can start, the clinical summary of the patient. You can go ahead. We can't hear Dr. Claire's voice. You can increase the audio settings.
Mumbai, sir, good afternoon from Medical Specialty Hospital, Chatlar. Warm welcome from all of us, Department of Cardiology. We warmly extend our welcome to our Honorable Dr. T.S. Fletcher for being here with us to have a demonstration regarding conduction system pacing. In short, we have our lady, 78-year-old lady, who was admitted elsewhere with a left femur spontaneous osteoporotic fracture. On investigation, she was found to have multiple comorbidities. She has history of hypertension, ischemic heart disease, atrial fibrillation, with a significant sinus pause in Holter. She had urosepsis, which was treated, and she also had a history of bilateral total knee replacement, and she was turned down for surgery because of all these comorbidities. And now we are here to do a conduction system pacing to take care of the cardiac part so that the necessary operation can be done. So that is the background, and we'll invite Dr. Claire sir to show us his tricks and tips regarding the implant of a conduction system. Welcome, sir.
I hope 12 leads are being given to the patient. All the ECG and the intracardiac signals are there. We are ready with that?
Yes.
Yeah. So, this is normal PLI of 7 French, or this is larger?
8 French.
8 French.
All CRT patients and for
I quickly go. Turn the screen towards Thursday.
So you have taken the long wire now, long wire, okay.
Yes. We are getting active.
RO?
Yes. RO 30, please.
Patient looks like, having a high heart rate, maybe 110, 115. Atrial fibrillation with 6 sinus, yeah. So there is no need, we can pace at 130 and we see. The sheath is gone and let's see how the sheath goes to
Please, to do the
now.
So let me know if you want a CNS.
Okay, we go to the now.
Deopriya, can you tell us the steps now? Are you in LAO reaching the septum or still you have to take, this is an LAO, isn't it? Or it's AP, it's AP projection, sorry, AP projection, you are still in right atrium, huh?
So what we do here, we do in check both the positions, the RO and the LAO position, but we start doing the LAO position. Mr. Dinesh is going now, can you show it to Dhoro?
Yes, sir. Sure is on. So, sir, Boston lead is not a lumenless lead, this is with a lumen, yeah.
Can you go to RO now? We have to go a little bit lower down. Very
Because apex back on apex back on. Alright, look.
There we are in
Unipolar.
unipolar. No.
Okay, so spring is there.
So you're pacing from here, can we see the ECG, intracardiac signals?
We are not yet pacing. Do you have any R-wave?
No, sir, the system is not switched on.
No, I think just give me 2 minutes more, their system is not on yet.
So, sir, basically, then what will be our method to localize when we are doing fluoroscopically?
You know, the thing is that you have to keep in mind that you know the roughly position of his area. Just go around 1.52 centimeters below that. First we usually go into the area view, then check in the area view so that your feet should be perpendicular to the septum. And when you go with the pacing catheter, pacing lead, then you will see what signals you get, what kind of RNA you get. And based on that, when we screw, first of all, it is on the right side of the septum, so you will get W pattern usually. That means you are placing the septum on the right side. And when you start screwing the lead, go a little bit deeper and deeper, then gradually the configuration will change. The W component, the second component starts decreasing, and ultimately when you are able to pace the left bundle, you will get typically R' prime pattern. So let's see what we do in this patient and what we get here. So just wait for a minute.
What are you waiting for, Devapriya? Shilanjal, please come. So I think to re-emphasize and to everyone who are yet to start, when on RV side, which positions you need to choose. So there are 2-3 electrocardiographic markers are there. Lead 2 should be up or isoelectric. Lead 3 should be isoelectric or predominantly negative. And AVR, AVL should be discordant. When you pace at this side, you get a kind of a LBB pattern and a notch at the nadir. This is the exact position where you need to go in and screw in. And once you go in with the stylus driven leads, you can still have a ECG in front of you, and you can see how the QRS is changing. Intracardiac signals you can see and make out. In 3830 lead, you go in and then you recheck it how much you have gone, the current of injury, how impedance, and you can see the QRS, the notch has gone up or not, and from LBB, W pattern to a QR pattern, you have got it or not. So let's see what happens now. We are waiting to see the pacing from right ventricular side, RV septum, and choosing the right place.
Devapriya, what is the septal thickness of this patient? Hello, Moinanda, it is 1.2 centimeters. Okay. 1.2 centimeters.
So do you feel that in non-cheesy septum, the stylet driven lead will have some age more than the lumenless lead?
I think with more and more use we can make out in which cases which is better, but I still have doubt on stylus driven, I tell you.
In many cases in the non-cheesy septum where there is relatively more fibrous tissue, is very difficult to penetrate.
So we have to go, Devapriya, you continue the case, we will come back. In the meantime, we can have a presentation here because people have to leave. So you just go on and record things, we'll come back and, explain the things and, yeah. So I think next, let me invite Dr. Samir Mehrotra for his talk. Samir is my friend, he is my batchmate, in fact, he is in BL Kapoor, or he changes his hospital every 2 years. I really don't know. He was in JP or Medanta or now in BLK. I am really confused.
These are the higher 120, 130. Yeah.
The impedance is 909.
Hello, please.
So we'll go live after this presentation from Samir.
So you want, sir.
So basically we are batchmates, long time. We started our studies together 20-25 years back. So it's good to see, to come and to be invited to a conference organized by Dr. Dilip. And regarding changing the hospitals, at the end of the day, we all are practicing cardiology wherever you sit. It really doesn't matter, it's a corporate circus. So, so coming on to I have to talk about the CSP in guidelines. So first of all, I would like to tell you that these guidelines were the consensus statement that were given in 2023, but the data and everything has been collected way back in 2021. I'll not be discussing anything beyond these guidelines, but in the last 3 years, lot of data, especially in terms of randomized controlled trials, has emerged for making a clear mandate on this physiological pacing, whether it's a left bundle pacing or whether it's a his bundle pacing. But at the time when these guidelines were written and then they were published, so conduction system pacing has not been established as such. If you define it, any form of cardiac pacing intended to restore or preserve the synchrony of ventricular contraction, that is what is known as cardiac physiological pacing. There can be two ways to do that. Nowadays, we are trying to engage the intrinsic conduction system via the conduction system pacing. You can go for the his bundle pacing, or you can go for the left bundle pacing, or you can go for the left bundle branch area pacing. And the other thing which we have been doing from the last 15 years is cardiac resynchronization therapy. So CPP involves CSP as well as CRT. The guidelines have been written with the intention of defining the indications for cardiac physiological pacing. If you look at the conduction system pacing, you can very well see, you can go opt for his bundle pacing, right bundle branch pacing, left bundle branch pacing, left fascicular pacing, LV septal pacing, or you can go for a deep septal pacing. This is how the lead starts working. As somebody was asking when we were talking outside that why do we look for a positive QRS in lead 2 when we are doing a conduction system pacing? It is because you want to connect above the bifurcation of the bundle branches somewhere around this area. So when the lower you start coming down, the negative the inferior leads will start becoming. So these are the various options which you have when you go for a conduction system pacing. Now this is based on 2023 guidelines. I am showing this slide because most of the cardiologists know about the class 1, 2, 3 indications. The blue chart is important. Even in the blue chart, there has been written level B R, level B NR, level C LD. So this is very important, which we will be seeing frequently in the next slides, which are showing the guidelines. So R means that there have been data from few randomized controlled trials. NR means there is not any data from the from randomized controlled trials. They are usually registries or observational studies or non-randomized trials. And LD means that studies with limitations of design or execution. So this is something important when we are going to discuss about the various things. There are two indications of these physiological pacing. One in patients who require a pacemaker therapy. Second, in patients who have LV dysfunction and in whom you want to optimize the LV function because of the various conduction abnormalities plus LV dysfunction. If we look for the pacemaker therapy, the question comes, why do we need CSP? We have been doing RV apical pacing from the last 20-25 years, and if you ask from the people who are working in Bengal, they will say we have been putting the lead at the RV apex from so many years and we hardly find that there is any incidence of RV dysfunction. Well, to be very honest with you, the incidence is somewhere around 8 to 12%. There has been a registry of 50,000 patients in which they realized the variables were not the same, but what they realized was that anybody who is having more than 40% pacing of the RV, especially at the apex, he has a higher chances of developing a RV dysfunction. But despite that, the incidence is somewhere around 10%. So, if you look for the recommendation for detection of electrical dyssynchrony-induced cardiomyopathy, for every patient in whom you have given a RV pacing lead and who has a substantial RV pacing that cannot be minimized, now you have various algorithms that you can minimize the right ventricular pacing by prolonging the PR interval or making a AV sync on with programming. Otherwise, periodic assessment of ventricular function is recommended in these cases. you should go for annual or biannual assessment of LV function in patients who are having a very high proportion of RV pacing. They are known as, there are two subsets, patients who are having more than 40%, patients who are having within 20 to 40. It can lead to functional mitral regurgitation, as a result of which in some of the cases with LVBB, you might get LV dysfunction. That's why they say in patients with chronic LVBB, keep on assessing the LV function. At some point, if you find that these patients are having LV dysfunction, then in such patients, you can contemplate going in for these conduction system pacings. But despite that, the level of evidence recommendation is only 2A. So in patients who are having a substantial ventricular pacing, or patients who are totally dependent on the pacemaker, especially if you look at the patient who is having a EF of 35 to 50% and with substantial ventricular pacing, cardiac physiological pacing is reasonable. Initially, we used to go for biventricular pacing in such cases, but nowadays we have the option that we can go for left bundle branch pacing or His pacing. Left bundle branch pacing is preferred to His pacing because of the very high thresholds at times when you get when you do a His bundle pacing. The lead sometimes can dislodge, it cannot be stable, especially in patients who are dependent on 100% dependent on the RV pacing. So if you have to choose between left bundle and the RV pacing and the His pacing, you will go for the left bundle pacing in such cases. BiV pacing as such has a class 2A indication, but if you want to go for left bundle pacing, that is still a class 2B indication as per these guidelines, because of the paucity of the randomized control trial and the data comparing left bundle pacing with biventricular pacing and ejection fraction improvement at the time of writing these guidelines. If the patient is having less than substantial ventricular pacing, then the aim should be to minimize the ventricular pacing and to wait and observe for the ejection fraction. If the ejection fraction is stable, patient is having minimal ventricular pacing, it's reasonable to choose a traditional RV lead placement and minimize the RV pacing. That's a class 2A indication. But if the EF is less, and although they are having less than substantial ventricular pacing, you can contemplate CSP lead with His bundle pacing or left bundle branch area pacing as an alternative to RV pacing lead. That is still a class 2B indication with limited data. In patients who had an indicated for permanent pacing EF 3550 LVBB, and despite that they are requiring less than substantial ventricular pacing, I will say these patients are usually those with paroxysmal AV block who have left bundle branch block. In such cases, you can go for a cardiac physiological pacing, whether you can go for BiV or you can go for a physiological pacing. In patients with normal EF who are anticipated to require less than substantial pacing, CRT with BiV is not indicated. Any patient who is having normal ejection fraction with minimal ventricular pacing that is required, none of the other things are needed. Simple, go for a simple lead placement. This is just a flow chart which shows how to proceed to your patients with pacemaker therapy. I'm not going to touch the surgical part. And a patient who has a substantial ventricular pacing, if he doesn't require a ventricular pacing, EF is more, then you can think about left bundle branch area pacing or CRT with BiV. If the EF is less and left bundle branch block is there, then you should think about CRT with BiV. Besides, you have the option of left bundle branch pacing. If the patient requires substantial ventricular pacing and has LV dysfunction, then you have to choose either between biventricular pacing or you can go for left bundle or His bundle pacing. Always remember this thing, that if in a dependent patient you are doing a His bundle pacing, there should always be a backup lead to be available in case the His bundle thresholds rise or the lead dislodges or there is some issue with the His bundle lead. Now coming for CSP in LV dysfunction patients, we all know LV dysfunction patients EF 35%, LBBB morphology if the QRS is more than 150. Biventricular therapy has been time and tested and shown to reduce the heart failure hospitalizations and the mortality in these patients. It's a class 1 indication. But nowadays, even in such patients, we are looking into cases in whom you don't get a good venous anatomy as a left bundle branch pacing or a His bundle pacing as a substitute to biventricular pacing. That is known as LHOT or LOT or say HOT. It is still a class 2B indication in such cases, but I think after the details of the randomized trials that are on the way, these will become at least into class 2A. So in patients who have a EF less than 30%, sinus rhythm, LBBB, QRS more than 150, and NYHA class 1 symptoms, CRT with BIV pacing may be considered to reduce the risk. So anywhere you will see in these guidelines, BIV pacing is always given preference over left bundle or his bundle or physiological pacing. I think these guidelines, the next guidelines will have a significant change in these recommendations and level of evidence. Now there is another subset, a patient who comes to you with a QRS of 120 to 149, class 2 to class 4 symptoms and LBBB. One thing is very important which was mentioned in these guidelines, that anthropometric parameters are very important. Females who are usually smaller in size and the Asian population which is usually smaller in size, they respond much better even at a QRS of 120 to 149 millisecond. That's why many times you see that the patients, females, short statured females, even with a borderline QRS less than 150, you give them a CRT or a BIV pacing and then these patients respond beautifully with a significant improvement in the LV function. And it has been seen that height is directly, height and the response to CRT and the QRS duration are significantly related. In patients who have EF less than 35%, LBBB with QRS 120 to 149 and they are symptomatic with class 2 or class 3, you can go for CRT with BIV as per the guidelines, but off-label indications is also you can go for left bundle pacing in these cases. There are another subset which is non-left bundle branch block patients. In non-left bundle branch block patients, CRT becomes difficult, but despite that, if your patient is having a QRS duration of more than 150, and it has been seen in various studies that even with a QRS duration of more than 150, RBBB, not RBBB, intraventricular conduction defects, if in such cases you give a CRTD, sometimes these patients show an improvement in their heart failure symptoms and slight improvement in the ejection fraction by 5 to 10%. While if your QRS is totally narrow, less than 120 milliseconds, then it becomes very difficult to find whether these patients are really going to respond to these therapies or not. So in patients with EF 35 sinus, the non-LBBB pattern, non-LBBB is RBBB and intraventricular conduction defects. With a QRS more than 150, CPP may be considered to potentially improve mortality, heart failure hospitalizations in functional class. Now, if the QRS duration is less than 150, that is a gray area. In such cases also they say that if the QRS duration is less than 150 and you don't have a LBBB morphology, in such cases there is nothing which is 2A or 1. In fact, with EF less than 35, 2 to 4 symptoms, QRS less than 120, CRT is not recommended. EF less than 35, non-LBBB, QRS less than 150, and class 1 or class 2 symptoms, not class 2 or class 3. Usually in class 1 symptoms, sometimes it is recommended you just optimize the medicines of these patients. So CRT with BIV is not recommended in such cases. While if the patient is having EF less than 35%, QRS borderline, class 3 or class 4 symptoms, we don't know whether it's really going to benefit, but despite paucity of data, the observational studies and the prospective studies are showing a significant improvement in the ejection fraction, and I think that is going to be the future. So high burden RV pacing I have already established. This is more or less explaining the same thing, what I have explained in the guidelines. Now there is one more entity, atrial fibrillation patients. That is something important. Normally what we have seen is that any patient who comes to AF, they say...
Samir, I think we'll go live also if you can finish in
last slide.
Last slide.
Yeah, just last slide. So with AF, I think the first strategy should be to convert the rhythm to normal. If you can't convert the rhythm to normal, you should try to control the rate. Whether by cardioversion or whether by ablation, you should convert the rhythm to normal. Most of the times we have seen AF-induced LV dysfunction improves. So we should not be in a hurry to ablate the AV node in a patient with AF and just go for physiological pacing or biventricular pacing in such cases. But if your patient has AF, he has undergone AV node ablation and you require with a normal EF you want to give him pacing, then left bundle branch pacing can be an option. Still it is not a class 2A indication. I think with that, I'm not going to cover the pediatric population. As per the latest guidelines in the pediatric population, you should try to focus on the septal, mid-septal inflow or outflow area, not the septum, because the LBBB pacing, the septum is very thin in these kids. So you should not try to focus on the septal area. There are various knowledge gaps in our information in patients with conduction system pacing. I think with the next 1 or 2 years, all these things will be sorted. We will also have long-term data. And if I want to conclude, it's a good alternative. Data is still emerging. There are significant gaps in knowledge, but we should not make it the default mode of choice for every patient requiring pacemaker or a cardiac physiological pacing. Thank you.
Wonderful. So thanks for brilliant presentation, Samir, as usual. And so 2-3 things before we go live. I think screw is in and lead is also placed. 1 or 2 comments from my side. There is a patient population from 35 to 50% ejection fraction. Now we have class 2A recommendation for going for a CRT or a left bundle pacing. So safely we can safely go. Previously we used to hesitate, especially in all complete heart block cases. And there is also concern about, Samir, you can give a little more idea on patients with right bundle branch block, QRS of 130, 140 milliseconds. I have a 3 case series reported in journal that all these patients improved like anything. The ejection fraction went up to 15%, I tell you.
Yeah.
So do you feel this substrate with lot CRT? I did lot CRT in these cases.
So see, the problem here is that we are only having isolated case series or observational data. These are a subset which doesn't respond to anything. A patient is RBBB, you exclude him from the conduction, from the biventricular pacing. In such cases, it is always advisable you should try to do a left bundle pacing or left bundle branch area pacing. Even if you want, you can attempt for a His bundle pacing. That will be much better. But it all depends. I think the narrower the QRS will be, the better are the chances that these patients will respond. But sometimes these patients have so diffuse disease and they have biventricular dysfunction that it becomes difficult for us to find the response.
So we can go to live again, and are we connected there?
Thank
we
you.
can see them. So Deopriyo, clear sir, can you hear us? Deopriyo, can you hear us?
Yes, sir.
Yeah. So please go ahead. Is the lead fixed and you have got the parameters, or can you show us the intracardiac signals and what's the position now?
Can you show it's coming there. Yeah, the lead.
Yes, sir.
So we got.
We can see.
Left bundle pacing. You can see R prime, and our LVAT is 73 milliseconds. So we got a threshold of less than 1, and impedance is how much latest? We started with the impedance of about 900, but 930, so we are down to around 700 impedance, and actually we are very happy that we got first chance. I don't know that the effect of Debupriya on me, and I would like to show the septogram which we took. Can you show the septogram, please? Focus on the septogram.
Yeah. Can the fluoroscopy projections be there?
Okay,
Septogram.
this is the septogram. You can show.
We can see, sir. We can see.
I think this is. I was little concerned that it should not be deep enough because it's a lady. It's 1.2 centimeter septum, but fortunately the impedances are very fine, around 700 from 930. And the pacing thresholds are very good. You can see the ECG. I think practically we are done actually. So if there are any questions, the only thing I want to tell you that basically for conduction system pacing we have 2 kind of leads. One are less leads like the Medtronic 3830, which is a naked screw is outside already, and that is the lead with which most of the people have more experience. But now we have started doing conduction system pacing with the ordinary lead with Stilet. So in this situation, what we do is when we get, can you go back to the fluoro please, where we started the screwing? Can you go back to the fluoro? Go back. No. Show it. No, go back. Where we started. Go back. So this is the area projection where we started. Next. Okay. So what we do is
in this step, your assistant should stabilize the lead, the catheter, and you first take the screw out. You know, usually what we do, the screw will come out, and then after that, then you have to rotate both the screwdriver as well as the lead. Give a couple of turns, and each 1 or 2 turns check the impedances and check the current of injury, check the impedance and thresholds. So that's what we did here, and the result is very good here. So if there are any, then we check with the septogram. That is the last. Can you bring down the I-down, please? Yeah, this is our last position. Can you go to LAO? This is APE. Can you go to RAO? First of RAO 30. Okay, this is RAO 30. So you can see here. Can you show the apex of the heart? Yes. So roughly, you know, we must be around 2 centimeters below the head bundle area, and roughly, if you draw a line from the apex to the AV junction of the heart, it's 1/3 proximal and 2/3 distal to the position of the. This is a rough position. I'll show you the LAO also. Can you come to LAO? Yeah. So this is the LAO position, right into the septum, and we confirm with the septogram. So any questions at this stage, Dalip, by anybody?
Yeah, I think sheath is also out. We have slitted.
We have removed the sheath because we checked after a couple of times. We were happy and we removed the sheath. After removing sheath again, after giving 2 stitches, usually what we do, we just give 1 stitch. We again test before giving other 2 stitches. So that's what we did here. After 1 stitch, we checked the position and everything. So we are happy with it.
Yeah. So in my experience, like this. Slitters, especially Medtronic 3830 lead, sometimes you don't see the same smoothness and same grip. When you do CRT, it fits there and just slit it out. But in CSP, sometimes you can slip, and many times you have to use scissors. And this is my experience. And sir, just one question. Like now, the stylus-driven leads are up there with their sheets ready for the commercial use. How do you see your practice changing from 3830 to stylus-driven 50-50%, or which way you will, lean on?
It's a very good question, Dilip. You know, there is this 3830 is a very sturdy lead, but there are 2 problems which I don't know the answer of. One is that this is a thin lead. How it will behave in the future, I don't know. Number 2. Lead extraction may be a problem because the screw is not retractable in this situation. But I think the lead with leads like the standard leads, we have experience of many years of the performance of these leads. Plus, I think it will be easy to extract these. So I think the practice will change. Hopefully, in next couple of months or a year, that we may go 50-50 or whatever is the experience later on.
Thank you, sir. Devapriya, you have to say something?
But one thing is I want to tell you that this sheet designed by Boston, they are pretty good. I am very happy with that. Actually, I was debating whether to use SSC3 or 2, because in 2, that terminal curve is a little bit less, because I wanted that it should be perpendicular to the septum. So which I did myself. You know, you can when the obturator in, so you can make the curve little bit change. You can always change depending upon patient to patient.
Thank you, sir. I think it is a perfect demonstration of CSP by a true master. So Devapriya, your comments, and I hope patient is doing well. Hemodynamics, everything.
Patient is fine, and we are going to just put in the pacer, and we are done here.
So any questions and comments? Otherwise, we'll close the live session. Thank you, sir. Thank you, Dr. Claire, sir, Devapriya, entire Medica team.
In your lab.
Thank you, sir.
And your beautiful hospital. I'm talking to Devapriya. You have got a fantastic colleague, and I think your future of cardio is very good. Thank you, sir. Thank you for being. Thank you, sir, for your work. Bye bye. Thank you.
Great. Now we can move on to the next presentation with Dr. Karthikeyan.
So it was a wonderful demonstration by Dr. Claire, and as Dr. Dilip said, a true master. And the case was done very quickly, and that is the beauty of stellate-driven leads when we use it for conduction system pacing. Those who have experience with 3830, that also works well, but sometimes whenever I have seen a case being done live, it has taken a lot of time. So sometimes live cases are challenging because you never know what you are going to get. But anyway, masterly demonstration. So my talk for next 5 minutes, 10 minutes will be talking about remote monitoring, how it can enhance patient care. Now, healthcare is moving close to the patient. We know mobile ultrasound in emergencies, mobile point of care echoes, they have made life very easy, not only for the physicians, but for the patient also. Blood sugar, blood pressure, the different ECG systems that can be monitored at home, the Alive Core, and now there is a Ring Everbeat ECG. You just wear it a ring and it will give you the ECG. And similarly, we have home monitoring for our device patients as well. Now, smartphone, again, apart from the other uses that we commonly use it for, it has a lot of healthcare advantages. And in fact, the iPhones, the Apple, their major emphasis in newer generation, every new iteration of iPhone is healthcare. And not only about educating the patients and the users of smartphones, the diagnostic workup that can be done with the phone as well as along with it the smartwatch, how to decide what treatment to take, decision support, medication adherence. You know, all our iPhones, you can add your number of medicines that you can take, can add reminders. So all those things have made life very easy for patient and have made people more health conscious. But at the same time, the cardiac clinics are quickly approaching capacity constraint. We know the number of devices are increasing day by day, and so the number of patients that we see daily in our device clinic is also becoming more than that one can handle with the limited resources that we have. And so remote monitoring has a true value. Now, it not only improves the patient's compliance compared to traditional office-based care, it gives them more confidence. You can see more number of patients which could have been lost to follow up. And it can also detect clinically actionable events which much earlier and quickly than compared to the conventional way when the patient used to come to the office for routine interrogation and then you find there's some problem. And also it reduces the number of emergency visits or urgent in-office or in-clinic visits in patients with heart failure and takes less clinician time. So it has a lot of value. Now, in fact, in United States and the guidelines by the Heart Rhythm Society, it's actually a standard of care. So every patient who has a device is under remote monitoring in United States, and it's a class 1 indication. And in patients who are on remote monitoring, again, it is preferable to have continuous connectivity with the remote monitor. Now, the studies have also shown that patients who are more adherent to remote monitoring have better outcomes. In fact, the patients with high adherence to remote monitoring have been shown to have 53% greater survival than patients with low adherence to remote monitoring. And so not only does it improves the clinicians, reduces the clinician's load, improves the patient's clinical outcome, it also improves survival. So that's a good thing that one remote monitoring can do. And now there are two different systems by which remote monitoring can be done in device patient. The conventional way is that all patients who have a device are given an additional monitor which connects to the patient's device and then connects also through connectivity like mobile network or Wi-Fi, and then the report generated by the device is transmitted through that monitor to the server from where the clinician or a technician can read the report. But there are a lot of challenges with this available conventional technology, and so the newer devices have come which have this inbuilt monitor within the device itself. And so the device just connects with the smartphone of the patient, and this collects the report and then transmits it to the clinician portal or the server from where the clinician or the technician can read the report. Now, Bluetooth enabled smartphone based monitoring not only is quicker, easier, but improves the compliance and has a much better connectivity than conventional systems. And so the usability of smartphone based remote monitoring is much better. In fact, we have seen a lot of challenges with conventional system, and practically it never took off in our country. But with these newer devices, now the remote monitoring is picking up very rapidly. Now, what are the barriers for conventional remote monitoring? Now, studies have shown that about 47% of all device patients who are eligible for remote monitoring actually get it. And if you look at only high-end devices, the ICD and CRTD, again the figure is 47%, but patients who have smartphone-based remote monitoring, the figure goes on to become 84%. And so there are a lot of barriers. It's on the part of the physician itself. They may not advise it. The patient may not take it because he thinks that it's an additional cost, and sometimes the referring doctor thinks that it is not necessary. So all those things, and then there are challenges of monitoring actually itself. All those things add up to the barrier for conventional remote monitoring. But Bluetooth wireless technology in the newer generation devices, in which the remote monitor is inbuilt in the device itself, actually has taken away most of these barriers and has increased the acceptability of remote monitoring in device patients. And it is not only increases the acceptability, but also is much better than the conventional remote monitoring because it has a larger antenna, so allows better communication. Even patients who have a much deeper implant, has high power and improves the connections and transfer and becomes more rapid. Increases the sensitivity, allows better data reception from programmer and the app, and has faster connection establishment to the app, and is easy to set up, done during the patient's implant stay in the hospital after the implant, and patient always has a smartphone with him, so him or her, so the connectivity is almost constant and continuous. And if you talk to the patients about the feedback for smartphone based remote monitoring, patients are highly satisfied with the use of the patient app and found the app very easy to use and app messages helpful and easy to interpret. It also increases their confidence not only in their physician but also their device as well. If you look at the India, the more than 70% of patients have used the device app, remote monitoring app, at least once in a week, and most of them have given a rating of 4 or 5 out of 5 of their satisfaction rating. In Medanta, again, we have a lot of patients who have been implanted with these devices, and in fact it has made the remote monitoring actually get worked up, because otherwise it never took off. And we see a lot of alerts, and these the reports that we get could be either scheduled, which is usually monthly. We can make it, program it to be 3 monthly, once in 3 months or once in 6 months. It could be patient initiated or alert initiated if patient receives a shock or if there is a lead impedance problem. And again, the report is generated and sent to the clinician portal, and an alert is received by the patient on SMS, email, and the patient can be called and communicated if any action has to be taken. So as I said, there are 3 different types of transmission. The scheduled transmission, which again can be programmable. The patient initiated, if the patient feels some problem, he can initiate a transmission on his own. And then there are alert initiated, which again are of different levels. Suppose a patient receives a shock, it's a high red alert, and then there could be orange alerts like high threshold or patient receiving an ATP. And depending on the severity of the alert, the patient and the clinicians will be alerted to the report of the device. So a couple of examples. This is a patient who was a 50-year-old female implanted with a CRT-D device for left bundle branch block and ischemic heart failure. And the follow-up after 1 month showed that the patient is asymptomatic, but the LV and RA capture are not happening. They are in high output mode, and some problem with the capture of left ventricle and atrium. And so the patient is called and found that the atrial lead and the LV lead have been dislodged, and sometimes it is seen very commonly, not very commonly but often, but in elderly patients who have very thin subcutaneous tissue or very lax subcutaneous tissue. And this patient would have come on her next scheduled visit, which would be 5 months away. And with this remote monitoring, we could call the patient and do lead repositioning much earlier and quickly before the patient had actually any symptoms. Another patient who was implanted with single chamber ICD and received a shock, and the shock was received on 10th December at 4:40 p.m. and the next morning around same time around in the morning 11th we get an alert. The physician gets an email and an SMS that this and this patient has received a shock, and so the patient can be contacted, and if any action needs to be taken, can be taken. If the patient needs to be called in, can be done. And we get all the reports like this. So this is the EGM that you can see on your smartphone itself, wherever you are, of your patient having been delivered a shock. And so I remember a patient calling me from Dehradun at middle of the night around 11 p.m. that he has received a shock. I don't know what it is. And I asked them to send a transmission immediately, and I could check that the patient has received an inappropriate shock because he was in a hotel where the earthing was not proper and he received a shock due to electromagnetic interference. And so everything is settled. I am comfortable, patient is comfortable and reassured that nothing extra needs to be done. There is no fault in him or the device or his disease state. Another example, again showing that the atrial fibrillation and atrial tachycardia burden has increased, and if any action needs to be taken, the patient can be called in and management for AT and AF can be done. Now yesterday itself I received one alert at 3:30 in the morning. Patient is in Dubai. This is a patient who has ischemic cardiomyopathy where he came, presented to us with VT storm, and an ablation was done in 2021 when one of my former colleagues, Dr. Rakesh Sarkar, was with us, and he is from Kolkata, now he is practicing here. So we did the ablation on him and then implanted a dual chamber ICD. He has been doing well since then, but he lives far away, and now the patient is totally asymptomatic. He received an ATP for an asymptomatic episode of monomorphic VT. And as I can see from all the report that he had only 2 episodes in last 3 years, so nothing extra needed to be done, but at least it gives me confidence that he is safe and he is doing well. Finally, sometimes we can also do assisted remote monitoring, remote programming, where remotely the device can be connected through a programmer at a place which is away from the clinician, but the clinician can connect through technology and then ask the operator to do, and can actually take hold of the screen of the programmer and do whatever changes he wants to do. So this is also possible. And finally, to summarize, Bluetooth low energy devices with its mobile app is a game changer, especially in countries having low remote monitoring usage like India. Success of remote monitoring in improving clinical outcome is dependent upon patient education, local clinic workflows and industry support. Healthcare facilities will have to develop the remote monitoring infrastructure and unified workflows. Future remote monitoring may integrate additional physiological and non-physiological data from non-implantable devices like blood pressure monitoring, ECG, and blood sugar readings, and may in fact enhance patient care further. And larger patient data analytics may guide better programming recommendations and may guide therapy selection. Thank you so much for your attention.
Excellent presentation, sir. So I just have one question, that how do you triage your patients for this remote monitoring? Do you offer this to all of your patients, or you just triage?
So as was the problem earlier, most of the patients where we offered them with with conventional remote monitoring, they used to refuse it. And so I was also not enthusiastic about remote monitoring, looking at all the challenges. There were always some challenges with connections and all those technology. So, but with this smartphone-based remote monitoring, the acceptability has markedly included. I have never had a patient who got this device but said that I don't want remote monitoring. I know of a person who said that if ever I get a device, I will not opt for remote monitoring, but all my patients have never refused it. And in fact, all these are under my clinic. I can see the report, the number of patients which are within me who have a scheduled transmission done. Everything is available, all the data is available.
Thank you, sir. Any question from the floor? Or we can shift to the next presentation. So our next presenter will be Dr. Rakesh Sarkar. He will be talking on troubleshooting ICDs for appropriate therapies, simulator session.
So very good afternoon to everybody, respected chairpersons, my senior colleagues, teachers, and the audience. So today's topic is little different than the usual type of presentation. Basically, this is a simulation session which has been incorporated in the whole like podium as a part of little hands-on not training, I would say, rather to get acquainted and to get familiar with the troubleshooting part, how we can do some troubleshooting at, at our own or just at the bedside also. Sometimes this kind of acquaintance may be important. So the first case, I'll try to take you through some case-based scenario, which are basically recreated in the simulator, and we'll just try to interact or get to know what is actually happening, although these are not actually live cases. So this is the first case where a person whose ICD was programmed in such a way that the VT zone was 160 and VF zone was 200, and suddenly he came up in the emergency with the complaint of getting some therapy in the mode of some ATP as well as shock. So just to know whether it was inappropriate or appropriate shock, I think the device interrogation or the dialog box part can help you out. So what we are looking at the that programmer, can somebody volunteer from like whosoever are in the training course like DNB or DM, like. Before jumping to the diagnosis, I know that most of the cardiologists who are practicing for a long time are good at handling the device programming part, but for the fellows and the young people who want to pitch in the device part, that may be sometimes important to just understand whether this programming which is being shown in the screen, whether it is having any definitive impression, whether it is the fault with the patient or fault with the device. Okay, so just as we can see here that the programming zone we set here as VT 160 and VF as 200. But if we look at two EGMs, one on the atrial channel and another in the ventricular channel. So we can see that atrial and ventricular channel are having almost same, I think it has got freeze. Yeah. So basically, I would like to stay back in this particular part of the EGM. What we can see here, we can see that the marker channel has annotated that ventricular EGM as in the VF zone as per the interval criteria. And it got the therapy first in the form of ATP followed by shock of 40 joule. Despite the situation, still the rhythm is going on. And this is the interesting part which we can emphasize. If we look at atrial and ventricular, both the channels, both the EGMs are 1:1, and we can see that there is hardly any change of the interval even despite getting the shock. So basically what is happening here, probably atrophic cardiomyopathy, little young patient, 42 years age. So he also presented with few episodes of getting shock, and when we actually tried to look at the the device through programmer, we can see something very interesting which is being shown here also. So can we just, yeah. So we freeze this screen, and anybody can volunteer and just can say what is happening. Any unusual phenomena? Yes. So very well said. As you can see here, after atrial pacing, there is there are two ventricular EGM which has been annotated as ventricular sensing event. So it may be double counting of R, or it may be TOA. But looking at the interval, the chance of being greater of TOA over sensing, something like that. So if it is so, what is happening? Just move forward. So you can see on the right side of the screen that VT zone was set 160 and VF was set as 200. So after every atrial paced event, there is something being please. So just little on the earlier part. Yeah. So this is the situation where actually the atrial and ventricular rate was little faster, maybe as a part of sinus tachycardia. But as we can see earlier, during the normal rate also, the TOA is getting oversensed as another ventricular event. So the device actually annotated TOA as another ventricular event, and it has been binned in the ventricular fibrillation zone. So clearly the ventricular fibrillation zone doesn't require any discrimination, and it gave the therapy right away in the form of ATP followed by the shock. So how to troubleshoot this kind of situation where you cannot probably eliminate the risk of all this even after changing your polarity or increasing the blanking zone? So is there any other way to get rid of? Yeah, so there are a couple of algorithms which are available in different device vendors, like I think in Abbott there is something which is very well appreciated in the form of some advanced setting in the sensibility algorithm. So this is called low frequency attenuation. The idea of this keeping low frequency attenuation algorithm on is just to discriminate between the T wave and R wave. Means there will be some difference in the frequency of T wave and R wave, and using that property there will be some band filter which will try to eliminate the low frequency signals just to pick up the R wave rather than T wave. There may be some other algorithm which will try to look at decay delay or kind of differential T wave sensing, but here the available algorithm which is incorporated in probably all the devices of Abbott is called low frequency attenuation signal. And at the same time there may be some other algorithm which Govind sir or somebody else might tell us, but by default if you keep this algorithm on without doing much play around like increasing the ventricular blanking period or changing the polarity, you can potentially get rid of all this nuisance and avoid inappropriate shock. So third, so this is another situation where we can see stay back, please. Yeah, just little back. Yeah. So anything which is glaring or like easy to pick up from this particular please. Yeah, little back. Yeah. Yes. Little back, little back, little back. Yeah. So what do you feel, is it a kind of appropriate therapy or what is happening, any idea? So basically the ventricular rhythm has been built in the ventricular tachycardia zone. So it has been discriminated properly as VT, having almost stable interval, and after that, no, you have to go little back. You have to go little back. You can start from the beginning. You can start from the beginning. Yeah. So what is happening after binning this rhythm in the VT zone? So the device started giving ATP therapy in the form of burst pacing. Then it continued with the same cycle length almost. Then it gave shock of 25 joule, followed by go on. It gave shock of 36 joule shock, followed by go on. Then it gave 40 joules of shock, go on, and it degenerated into VF. So as we said, or as we saw, it may be VT properly with very fast VA conduction, or it may be SVT with which is being inappropriately discriminated as VT because of the zone set. Now after getting the highest amount of shock, that is 40 joule, it actually degenerated into VF. So was it a expected situation, or how to just troubleshoot this kind of situation? So basically this patient actually required external shock because it didn't convert with the usual 40 joule device therapy, and somehow he was survived. But the purpose of showing the case is sometimes it can go in such a way that the SVT or simple sinus tachycardia in a given situation can lead to inappropriate therapy, and this inappropriate therapy, maybe ATP or shock, may actually worsen the scenario, and it can generate something like VF, and which may sometimes mandate external shock also. Next please. Yeah. So last case I am going to show. Stop. So anything like, yes. So this is apparently easier rather than the other. So there is prominently ventricular EGM which are much more than the atrial EGM, and it has been going on. So what can be the situation? So the rate is set here as in the VT zone 171, in the VF zone it was set as 200. And what is the rate we are looking at in the programming, in the programmer, that is 165. So despite being it a clear VT where atrial signal are less than ventricular signal, still the device is unable to recognize it as VT because the zone set was actually less than the ventricular tachycardia cycle length. That means had it been kept in the little lower, maybe 150 or 155, it could have been easily recognized as VT. Sometimes it may be not, kind of unusual to see, because in primary prevention usually we keep the VT zone little on the higher side, but sometimes if it is already on some antiarrhythmic therapy and somehow VT generates in the given patient, so sometimes the rate may be little on the lower side and you can potentially lose the therapy in such situation. So I'm just stopping here. So I'm happy to take any question if you have.
Thank you. Excellent presentation. Is there any question from the floor? So, Rakesh, if in the baseline ECG, where in a case of a patient where you have implanted ICD, if the T wave amplitude is relatively higher, something like around 70% of the R wave, so would you be a little bit more cautious about this T wave oversensing or something?
Yeah, because sometimes in some patients, maybe hyperkalemia or hypertrophic cardiomyopathy, there will be some propensity of having higher apparently T wave amplitude. So as you said, even it can go even more than 70%. But there is something very important, that is band filter, which is there in order to just eliminate all the low frequency signals. Because if you see, the T wave frequency itself will not be as high as R wave. If you are getting also the low amplitude R wave and higher amplitude T wave, it's one of the way to just get this kind of situation where you are having that T wave oversensing. But usually if you have even sufficient amount of T wave, good enough to generate all this T wave oversensing, but this low attenuation frequency algorithm may actually help you out to get rid of this T wave oversensing. And sometimes you can play around by changing the polarity of the coil to CAN, or that RV tip to CAN. By this way you can sometimes get rid of it.
Thank you. Thank you. Okay, so we will go for the tea break now, or next presentation. Next presentation. Okay. I think we can invite our sir, Dr. Dilip Kumar sir, for the next presentation.
Itself. It's very seldom we have to pop in and see the intracardiac signals, the events, what happened. But I wanted to emphasize these things. Many times we see leads being left over in the, when we are replacing the leads or we are doing some kind of pulse generator change, you see also lead is defective, then you don't take out the lead and you just leave the lead there. stitch it out, and then the new lead goes in. So these are real not good practice and needs to be changed. I will show you some of the cases of lead extraction. So I will just quickly run through. Device infections, I wanted to re-emphasize again and again. We have some very good insights from PADI trial that if you do a procedure and then you give even 10 days of antibiotics, it is not going to work. So a device infection, the antibiotics should be pre-procedural, good part preparation, chlorhexidine, betadine scrub, and that will reduce your chance of infection by 50 to 60%. But post-procedure antibiotics, they don't have any role. So these are the risk factors. These are the patient-related risk factors. Patients with diabetes, ESRD, corticosteroid use, renal insufficiency, skin disorders, malignancy, and those patients also in heart failure or oral anticoagulants. Any hematoma is a very strong risk factor for infections. These are procedural-related factors. Procedural duration is very high. Hematoma. You can see the p-value in hematoma, 0.000001. So you have increasing chance of infection 6-fold. Lead repositioning, inexperienced operator, temporary pacemaker. We should avoid temporary pacemaker. Just I was talking to mine. I don't do TPIs even for CHB patients who are little stable, and then device replacement, generator change, and antibiotic prophylaxis before the procedure. Device-related factors: epicardial leads, abdominal pockets, more than 2 leads, dual chamber device. They are have more chance of infection. You can predict it by PADI risk score. So let's move on, and then I will not go in detail. We all know 2-3 cases of lead extraction, because we should not leave leads there. We should take it out. This was a case I think I did in 2011. 66-year-old male had a VVI pacemaker implanted in 2002. Lead with PG replacement was done 1 year back when the patient came to me. Old lead was cut. Now there was a pocket infection. So there is a lead cut and the new device is there. There is a pocket infection, fever for 2 weeks, no other identifiable source of fever, and T transthoracic was negative for any apparent vegetation, blood culture was negative, and this was the situation. You can see here one lead which is 1 year old and one lead which is 11-year-old. And then patient had a 2 weeks, 3 weeks history of fever, and we had to remove everything. And first lead which was 1 year old was easily removed, and now we were stuck with the lead which was cut, which was 10, 11 years old. And 2011 we did not have access to tight rail, we did not have access to lasers, and here we had to take it out. So how will you do it? And I had published reports on using EP catheters in extraction of trapped intracardiac devices, where I used EP catheter to deflect the device into the IVC and snare it out now after that. So in this case we did similar approach, because here the cut lead had no access from the from this end. It was deep, a little bit deep incarcerated somewhere, so we can't go and dissect the entire vein. So we used you see the quadripolar lead, quadripolar electrode, and you can see here we could take it out, and what we do is we can also take another sheet from inside, and we can snare, we can just hook it with snare. Now this bend will not come straight. Then you can easily track it down. At that time we thought I will use it, but it itself worked. The EP catheter curve was enough to bring it down in the IVC. You see the end. Otherwise, this end, I just tell you, because any one of you can be in problem in this situation. So here, if you somehow snare this, just catch this, then you will not allow this quadripolar electrode to become straightened. You are pulling it from this side, and then you are pulling the entire assembly down. So you can easily bring it back to IVC. You can have a free end, and then you can easily, you can see now, here I took the snare deep inside, so that if you catch here, 11-year-old lead can be snapped off from this place. So I went in deep, and then I removed the lead. So this was a case. And then again a patient who had a single chamber pacemaker done from right side following device infection of left side 4 months back. And the first pacemaker was implanted 5 years back, so a five-year lead, and now a new system. from left side, right side was done because infection, and the left side lead were cut again. So this cutting business should be stopped, because many times it leads to kind of sinus formation and intractable infection, and it is 5 years, 6 years, 10 years. During infection, if you do it, then chance of bacteremia is there, and if the patient has no infection, easily you can like tight rail. You can see here now on LLD tight rail went in, and and there is also two silly mistakes happen. Tight rail is never there in shelf of most of the hospitals, though they ask vendors to get the tight rail when they want to extract it. So tight rails come in two sizes, one for a lead, pacing lead, and one for ICD lead. Suppose there is IC lead you have got with a pacing lead tight rail, and a pacing lead tight rail come with 11 or 13 French. There is a different two systems are there. So if there is a pacing lead, you don't use an ICD tight rail. It will cut more and you can injure the area. So this was a pacing lead, and on LLD we could went cut in, and finally we could remove that. You can see. So tight rail is it has to be coaxial. Right side there is a problem. There is a a certain angulation happens, and it can cause some injury, and the attention is to be paid there, and you have to take a last final shot before you come out, so that there is no such, because once you, especially if you injure this SVC and it is avulsed, you have only 10 minutes before the patient exsanguates, very less time. So we have to be careful. And finally, last case which I just showed a little while back, you can use this strategy. You can put a leadless pacemaker at the same time, and you can remove the leads, because the chances of pacemaker microinfection is really minimal. So just 3 cases I thought I should share with all of you, so that if you replace next pulse generator and you find your lead defective, try your level best, or just check it earlier that lead is working or not, and keep your accessories ready with you to extract the leads. Thank you so much for the patient hearing.
Thank you, sir. Excellent presentation.
Yeah, both sides, yeah.
Eye on needle snare, you can just hold on and then put the lead in, and it catches and then take out. Medic.
Thank you all the speakers. Let us conclude the session.
We'll go to the next session, and I may invite Dr. Rana Rathore, Dr. Varun, Dr. Sumanto Chatterjee, Ashish to be there on podium. Nice. Chair.
Hello. Let's go into the next session. We invite Dr. Shunandan Sikdar. The topic is concerns versus reality, practical recommendation on the use of ARNI in heart failure. We know Dr. Shunandan Sigdar is a consultant cardiologist attached to NH Barashat. He is a known good orator. Let's start. Over to you.
Okay, I've got the presentation there. Actually, I loaded them. Yeah. So, good afternoon, everybody. So, we will present a topic, but the initial topic that I got. Go back. So, that was a medical management versus device-based management. Are we looking at lesser CRTs in future? Dilip gave a very interesting topic, but suddenly it changed. We have concerns versus reality practical recommendations on the use of ARNI. So I had actually started looking up in literature initially, and I will actually take along both the topics. So we start with a case. A 75-year-old man, old anterior MI, he had it in 2007, ejection fraction 25% only. Almost the entire LV is very entirely hypokinetic. The entire septum is fully scarred. As you can see in the right side picture, the septal thickness is around 7, and here recurrent syncope, and we saw that there is a atrial fibrillation with long pauses. Here recurrent syncope. But I actually was very much fearful whether he, even if he did a pacing, he can have a VF anytime, and how long it would last. So I initially thought of going for an AICD with one port for CS pacing. CRT-D I couldn't think of because of the financial problems. So ultimately we had sent this patient home, and you can see the narrow QRS on the right side. Ultimately left bundle area pacing was done. I couldn't get the good classical thing, but we did it in the left posterior fascicle. So what are the treatments that can be offered to this patient? So definitely ARNI is the first drug that we always think of. ARNI, SGLT2, beta blockers, MRA, and apixaban. So that is the thing that we got it. So how does do ARNI will if we have given ARNI only, could this patient be off the ICD? If we have given ARNI only, could this patient be off any device? This is the question of the topic actually. So how do you go about it? So there are a few papers. So one of this is a very important paper in ESC heart failure. Clinical impact of ARNI on eligible patient of cardiac desynchronization therapy. So if you have a patient with wide QRS, and if you have a patient with narrow QRS, and you follow them over for some time, you see if you give ARNI, the LVEF is likely to improve in the narrow QRS1. And there was 20% people had ejection fraction going up to 50%. But in the wide QRS, the improvement is very low. So if there is electrical desynchrony, the effectiveness of ARNI is less. In the right-sided the bar diagram, you can see that in those patients who have wide QRS, they have higher mortality, even if they have ejection fraction which is going up to 50%. Here is also an interesting data that says that even if you have an ejection fraction high, that is say 45-50, if you have wide QRS, the event rate and all-cause mortality is higher than if you have a narrow QRS. This is another paper that there is a ARNI which has reduced the ICD shocks and ATP and increased biventricular pacing. So if you look at ventricular arrhythmia, actually ARNI is an antiarrhythmic drug. ARNI is an antiarrhythmic drug, and it reduces the ICD shocks and it reduces the requirement for ATP. This is another one. This is a study which was done on epigenetic reasons. The impact of ARNI plus gliflozins in ischemic and non-ischemic heart failure patients. So if you look at the bar diagram on the left side, the best result was provided with ARNI plus SGLT2 compared to ARNI alone, but predominant driver was ARNI rather than SGLT2. And the result is better for ischemic heart disease patients. Ischemic heart disease patients with low ejection fraction, the result of ARNI plus SGLT2 is better than non-ischemic. And the response of CRT is improved by presence of ARNI. So as we can see, echocardiographic CRT response is improved. ARNI alone or in combination with SGLT2 increases the clinical and echocardiac response to CRT and improves the cardiac function at 12 months follow-up. Their combined benefits are especially more important in ischemic heart disease patients. There is a study with epigenetic parameters, microRNAs. So when we look at this study was done with microRNAs. The parameters they took was instead of, they had taken echocardiographic parameters, but microRNA was other parameters. So ARNI patients did better. So important thing is 34% of patients among the ARNI users became responders from non-responders. However, only 6% patients become responders among non-ARNI users. So you can use ARNI to improve the response rate of CRT among the non-responders. So this is the role that is coming up of microRNAs in looking at heart failure. So microRNAs are now coming up as an important parameters to look at heart failure. So this is a paper that shows that ARNI reduces ventricular arrhythmias in parallel with ventricular reverse remodeling with reduced ejection fraction. If you look at the bar diagram, you can see very interestingly, if you have given ARNI, after the first VT episodes, all other episodes are reduced. So before ARNI and after ARNI, second VT episode, third VT episode, fourth VT episode, they are almost nil compared to without ARNI. So it is to see that ARNI usually improves it gradually over 6 months. The time period that it takes to reduce this arrhythmic potential is around 6 months. So this is, we all know this Paradigm HF trial and 20% reduction in overall mortality. But we will come to a very interesting fact. Why does ARNI behave as an anti-arrhythmic drug? So if the entire thing lies in the calcium release kinetics. So as we can see in diastole, there is some amount of calcium leakage in a failing heart. So these are called diastolic calcium sparks. These are called diastolic calcium leaks. And we can see the green molecules, these are the calcium which are coming out even in diastole, which should not be there in a normal heart. So actually, the sacubitril component of ARNI, not the valsartan component, reduces this calcium leak in diastole. This is the reason that whenever you give ARNI to a CRT patient who is in heart failure, there is reduction in the PVC burden. Because there is reduction in the PVC burden, there is an improvement in biventricular pacing. Because there is a reduction in PVC burden, so PVC triggered VF actually goes down. So sacubitril is actually the antiarrhythmic drug. So coming to initiation and uptitration of the ARNI, we all know this. You gradually build it up, and you should stop it 36 hours. If you AC inhibitor should be stopped 36 hours before ARNI. Coming to the important thing. So you all know about hyperkalemia, but you have to importantly rule out that patient is not taking potassium supplements like Augmentin and all that. These are all important practical reasons why you have a hyperkalemia in the hospital. So coming to the summary, ARNI causes improvement in ejection fraction more in narrow QRS. It reduces the PVC and ventricular arrhythmia independent of its reverse remodeling effect. And the antiarrhythmic effect is predominantly provided by sacubitril that reduces diastolic calcium spark and improves responder rates in CRT by increasing the bi-VN pacing and reducing the PVC. So wide QRS LVBB actually responds less to ARNI and more to CRT. So actually ARNI is complementary to CRT rather than supplanting it. You can use ARNI to reduce the non-responders and reduce the degree of arrhythmia. Thank you.
Very nicely explained the mechanism, how the sacubitril prevents sudden cardiac death. Because 20% reduction in sudden cardiac death by ARNI, and this is the mechanism. Very good.
But sir, if it is an inherent property of the sacubitril, then why it is not that effective in heart failure reflex?
So actually this trial was done with sacubitril valsartan and sacubitril plus valsartan. And the mechanism is predominantly caused by sacubitril because it reduces this one when there is adrenergic drive. Adrenergic drive. Not in catecholamines heart, the sacubitril works better. So all patients who are having excitement leading to EF, sacubitril is a very good.
So any questions from the audience? So next topic is anatomical challenges in ALV lead placement by Dr. R.D. Yadav sir. Sir, what to you, sir?
First of all, thank you, Dr. Dilip, given me some opportunity to speak something. Slides. It's a load. It's taking time. If someone can present other presentations. No, they are saying it's loading.
We are taking tea break, no issue, sir.
Okay.
There is a very interesting topic which we have kept is IVHRE orientation. Like all those who wishes to clear IVHRE, we have some tips and tricks from those who have cleared it. So Sojatyo is there who will coordinate, and Mainak, I think he has cleared, so he can give inputs, and we all will give some inputs. Yeah.
Okay, ultimately it came. So anatomical challenges in LV lead placement. First of all, I want to thank Dr. Dilip, who has given me the opportunity to speak something. And most of the anatomical challenges has been dealt by Dr. Ashok Parida, where I worked together. So it was contribution of both. Still I will show someone. So consideration before procedure of venous access. Subclavian, axillary and cephalic access, whether it is blocked or not. So angiography should be done to know that you have to puncture axillary rather than subclavian, and to see it is blocked or not on the left side. Left or right sided implant, depending on whether they have infection or there is obstruction, that will depend. New implant versus upgrade. Upgrade, you must do the angiogram to see whether the vein is patent or not, particularly because if you want to change the lead or anything in upgrade, because in upgrade you need to change the lead or implant another lead. So angiography is a must before in puncturing and must puncture before opening the wound. And then depend upon the cardiac anatomy and persistent LSVC. I will show another case also. And if previous cardiac surgery, previous thoracic surgery, and which leads to be put first. RV lead, I put RV lead first. All RV leads should be screwing. We don't put tined because you cannot put at the septum where you need, because LV is round, you have to put the septum, middle of the septum here and on the lateral wall of the middle part of the lateral wall of the LV, so that synchronization occurs, fusion is better and QRS is narrow. Previously we used to do the LV lead first, and these are the coronary sinus cannulation sheath of different companies. These are the leads of the LV lead of quadripolar nowadays. We don't do bipolar lead anymore, all quadripolar lead, either from St. Jude, Medtronic or other companies. This is very important. Sheath, subselect sheath is very important, particularly if it is down looking vein. Tributary is down looking, then you need subselect of 120 degree or 130 degree rather than 90 degree. And always enter
the CS, I prefer decapolar, prefixed decapolar, prefixed curved decapolar from Cordis is my first choice. If I fail, another one is the temporary lead, temporary pacing lead from St. Jude, is because the anatomy changes with the LALV enlarges, the CS become more hockey stick origin. Previously it is more horizontal, now it's more hockey stick origin, and so the hooking is very easy if you will use the St. Jude TPI lead, which is prefixed curve, St. Jude TPI lead. And coronary venous anatomy, we have to be concentrated on the left posterior vein and left lateral vein. These two veins are the target, out of which depends upon which vein is better, either of the two, but these two veins are the target. If both veins are there, I prefer left lateral vein, because that part of the LV is last to depolarize, so you want to pre-excite that part first. And then there are problems like there may be Thevesian valve, but from above Thevesian valve is not a problem. Sometimes you might have to hook from below and then hook from the above, hook the CS from below to make the Thevesian valve down, so that upper lead from the lead from the subclavian excess goes to the CS. Then another is the Buchan's valve. Again, in Buchan's valve, you have to pass with the wire and then subslack and then pass the lead. As I told you, because normal, there is CS is more horizontal origin, whereas more hockey stick origin in patients with dilated cardiomyopathy or where LALV is enlarged. And these are the other anatomical abnormalities. Persistent LSBC is another problem, where if they have a branch, then you can put the lead very easily from the left side. But if they have no tributaries, no branch, then you cannot do. And if that is large, then the smaller one, I have failed one of the patients having dual CS, one through the persistent LSBC, and another from where tributaries are coming is from the coronary veins, CS proper. And that CS proper branch is giving, and that was narrow. My catheter could not be able to go there by any means. I have to send the patient for surgery. So if you want to know the anatomy, CT angio should be done before. If there is no contraindication from renal side, contrast load is not a problem. CT angio gives a good idea, make a frame where you want to put the lead, lateral vein or so, or posterolateral vein is there or not. So I will show the difficult case. Like always we do selective CS angio, we don't do 90% of the chance unless we cannot see the vein properly. So here the first challenge is here, it's the subclavian left side is blocked. So I am a peripheral interventionalist also, so I first open it with the balloon. There is no need to put the stent, and then put all the 3 wires and device will go. So here did the angiogram. Previously these are the older cases where I used to do selective angiogram where it is not clearly seen from the levophage of the left coronary artery injection. And you can see there is a bend in the vein, posterolateral vein, which is every contraction, it's narrowing. So here put the balloon, and over the balloon dilate it and put the subslack. And then everything goes very easily, and then put the device very easily, no problem. So this is one of the difficulties. The another is persistent LSBC, which Dr. Parida has also shown. So here is how to run. Okay. Will it run? It's not running. There was no right SBC, only the left persistent LSBC to CS was there. Can you run it? It's not running. Okay. So anyway, here the problem of putting the LV lead is not there. Putting the RV leads, ICD lead is there. So we use, as I told you, I use CS lead into the PA, and from PA we fall down the lead into the RVOT, and then to the septum, and then screw it, always screwing lead, and RA lead is screwing is very easy. And then it's not running, okay. It may be old media. Anyway, so this is another case already Dr. Parida has shown, persistent LSVC, which we did together, and same you can put the lead from the persistent LSVC on both the sides, the LV lead, RV lead and the ATL lead. Now another stenting technique, how to do stenting, he has also shown that. So this is one case where vein is okay, very nice, posterolateral vein, lead goes in, but after slitting, everything slitting, up to slitting is okay, while stitching, the lead, every contraction lead is thrown out. And this is not a screwing lead, this is the lead from the, just one more minute, the lead is from the St. Jude where there is no screwing. Medtronic has a screwing lead. If I use Medtronic device, I always use a screwing lead, it's a rule. And they have quadripolar lead with a screw in the, between third and fourth pacing electrodes. So I used two guide catheter, one delivery sheath, and how to do stenting is very important. If you have caught like that, you put the one sheet first into a CS sheet first, put two wire, one extra support wire, one usual wire, and on the usual wire, and take out the two wire, take out the sheet and reintroduce the LV sheet, and through which you want to put the lead. You put the lead with that, and another wire keep there in the CS. With that you put the guiding catheter. My choice of guide catheter is right coronary artery, and then you rotate near the origin. You see this is the guide catheter, right coronary. Rotate near the origin of the CS branch, tributaries, and then pass the PTCA wire and pass the your stent. Usually we pass shorter stent, 12 millimeter length, and depending on the size of the artery, usually 3, 3.5 or 4, depending on the size of the vein, and then deploy it, and thereafter you can slit and lead will be there, it will not come out. And there we have seen that there is no damage to the lead or no insulation defect with the long-term follow-up. I am doing this stenting for long when there was no screwing lead also. So in patient with having LV lead prolapsed out with each contraction, lead fixation is required, either Medtronic screwing lead, active fixation lead, or we need to entrap the LV lead by stenting the vein. In long term, no lead damage has been reported, and only problem is lead extraction sometimes, but that can be also done with force. Thank you.
So do you think, sir, in the future all the lead will be like pacemaker will be replaced by the screwing lead?
Yeah, I think so. I think so. All leads should, because you want to put where you want to put. That is in the basal part if you want to put the lead, because basal part is the maximum benefit. So Medtronic has this screwing lead, I use it, but St. Jude say you cannot change the lead, no, because you cannot use the Medtronic lead and device from the St. Jude, because they will not give the guarantee of 5 years or whatever, they will not give the guarantee, because if you change the lead. So you have to use the same company's everything. So where there is no screwing lead, you have to do this technique.
Very novel way shown that how to fix the lead with the stent.
Well, you know, the thing is that I had never to put a stent to fix the lead in my whole life. So we have done also.
Sometimes the leads get dislodged frequently.
Yeah, you know what, I'm surprised actually in his case, you know, there was vein was like this, and all the poles were beyond that bend. If you are beyond that bend, it should not come back. Anyway, so every case is different. That's number one. Number two, my comment is that I really don't think that we need the screwing leads, because CRT has been there for more than 20 years now. If there was a so good technology, all the companies will come with the, yes, occasionally you need that, but that you need only when the vein is short. You are not able to go distally, so that it will not get displaced. And proximally it may be, you know, the size of the veins is a little bigger. Even the screwing may not be very effective. You need a smaller vein to fix the vein.
Otherwise, it will be useless.
No, you have to go more distally to screw it.
Shown brilliant cases, and I admit that earlier we did not have any choice. Now we have choice in terms of CSP, conduction system pacing. So I think a week back I had similar kind of experience, and it happens not because of the one loop, sir. There is a coronary sinus uptake. If there is a strong angulation there, and there is angulation in the vein also, with each cardiac contraction it comes out. I have seen 2-3 cases, and last case just came out. It was so deep, so I left it there. I tried another 10 minutes and then I abandoned the case. I will do it CSP
Conduction
now.
system.
Yeah,
Yeah, it's easy. So nowadays, those people who fails CRT LV lead placement, means LV lead placement in proper place, they do conduction system pacing, which is much easier than putting the CRT. So I will say CRT is more difficult than conduction system pacing. So I will also prefer conduction system pacing. But mostly
but stent, every literature says that stent may interfere with electricals, and it can be a very can be a trouble for patient and you also. Dr. Sanjeev Kathuria had 2 cases. He did a stenting to stabilize the lead, and there was a VT and all electrical and heavier, and patient difficult to. I don't think patient was rescued. So should stay away. Master, sir can do, but others can should.
I have done more than 10 cases of by stenting this technique, and few Dr. Parida has also shown. That was also done with me. This was I did in some other place. So it depends upon, but there is no problem in this. These on follow up, there is no insulation defect, no lead fracture, nothing.
Thank you, sir. Now, may I assess your talk is there.
Okay.
He's attached with Medica Super Specialty. He's an EP fellow, and his talk will be optimization of CRT for improved patient response simulator session. Dr. Ashish, please.
So good evening, everyone. I am possibly the last batsman of this league. So I will be talking on the optimization of CRT for improved patient response simulator session with Abbott. Something is missing. Slides are missing.
Abbott has not simulated.
Okay, I got it. So CRT has improved the response in patients with heart failure dramatically, especially those who are having complete LBBB with heart failure. So after implantation, apart from the basic settings, we need to rely more on the AV delay and VV delay to optimize it properly, because the intention is to deliver the 100% biventricular pacing. So traditionally, the standard practice was to keep the AV delay at 100 and 120 milliseconds and simultaneous biventricular pacing. And with that practice, most of the patients would have 100% biventricular pacing, and the expected response rate would be around 60 to 70%. But rest 35 to 40% patient will be non-responder. And if you look at the chart, this chart will show that the reasons of non-responders, and among that, the suboptimal AV timing is one of the main important reasons of being non-responder. In that subset of the patient, what are the options we have to offer to optimize it properly? Because we can go for echo optimization, we can go for ECG optimization or device-based optimization. And no method is better than another. So today I will be concentrating more on the device-based optimization that we have with the St. Jude-based system. So there are 3 actually approaches. One is QuickOpt, second is SyncAV, and third is multi-point pacing. So I will go one by one theoretical aspects and before going into the simulator session. So in QuickOpt, the device itself judges the AV and VV timing depending upon the intracardiac electrogram. It will suggest what would be the possible AV and VV interval we can set to optimize it properly to get the best benefit. Next level CRT technologies are the sync AV and multi-point pacing. In sync AV technology, the device will prolong the A-paced V-sense and A-sense V-sense interval to allow the intrinsic beat to come in, by which it will judge what exactly the intrinsic AV delay is. Depending upon that, it will deliver the biventricular pacing at a AV interval which is less than that of the intrinsic interval. So for example, if the intrinsic AV conduction interval is 184 millisecond, the device will pace biventricularly at an AV interval of, paced AV interval of 134 millisecond to ensure biventricular pacing. So this is the basics of the dynamic AV delay. If the AV delay is fixed, the patient is doing exercise, in that case the AV delay changes. The patient might lose the biventricular capture. The basics of the fusion beat is to allow the intrinsic conduction to go on over the right bundle, and the fusion can be achieved with the biventricular pacing vectors along with the intrinsic conduction through the right bundle. So this is the biventricular pacing. The fusion is gone with both the ventricle. In sync AV technology, the fusion is possible with the three vectors. One is going through the intrinsic conduction through the right bundle with the both ventricular capture. And in sync AV CRT LV offset, the fusion is possible with the LV pacing and the intrinsic conduction. In multi-point pacing, what they do usually, in patients with LVVB, there are many parts of the LV is in dysynchronous. So if you pace multiple dysynchronous part of the LV simultaneously or a little offset or onset, then you might recruit a lot of myocardium into synchrony. So that is the basis of doing the multi-point pacing. Now, with the device, how can we stepwise approach to CRT optimization in patients who are non-responder? So on starting the interrogation, this is the first page you can see, apart from the basic parameters, you can directly go for the tests. On pressing that button, one page will appear. There is a called CRT toolkit. Here, you can go for step-by-step approach to optimize it. The first one is to measure the LV and RV conduction time. So on pressing the perform measurement, the device will automatically show which electrode, LV electrode, it had distant from the RV electrode. So it will help us to identify the longest electrical delay between the two electrodes. After that, the next thing is to measure the LV threshold. The device will automatically show you which LV electrode it had distant from the RV electrode. And depending on that, you can measure the LV threshold of that particular electrodes. After that, on pressing the quick out button, the device will suggest you the possible AV and VV interval that you need to optimize to get the best benefit. And the fourth one, the sync AV CRT technology. Here, on pressing the intrinsic AV conduction interval, the device will first assess and measure the intrinsic AV conduction interval. And you can change the sync AV CRT delta accordingly to see at which delta AV interval you are getting the narrowest QRS. You can see in the picture that on minus 100 millisecond delta interval you are getting the narrowest QRS. So that you can set. So in a recently done case, in a patient with complete LVB with ejection fraction of 30%, after doing the nominal setting with simultaneous biventricular pacing and sensed AV delay, we got the QRS of around 102. So if you see the sync AV, this is at the minus 30 delta, this is at minus 50 delta, this is at minus 70 delta, this is minus 90 delta. So you can see the changes of R wave in the V1 as well as the amount of LP pacing it will have. And this is minus 100 delta. The morphology of the QRS as well as the duration changes if you change the delta setting. So lastly, programming the multi-point pacing. So in multi-point pacing, you need to select two vectors which are at least 30 millimeter distant and keep that amount of time at least 5 milliseconds between them to recruit more amount of the myocardium so that as synchronous conduction can be achieved. To summarize, after getting the nominal parameters, at least 30 to 40% patient will be non-responder with the standard practice. So you have got two options to offer, either echo optimization and ECG optimization, or current device-based optimization can also be possible. With the device-based algorithms, you can achieve the narrow QRS in that subset of the patient. Device-based algorithms are very quick and easy to perform and may be an option in non-responder. Thank you.
Excellent. What about the Sync AV Plus?
So that is a new technology they have offered. There are some differences with the previous Sync AV. First thing, in a standard practice, we used to keep that delta interval fixed. They have reduced it to percentage. So deliver more.
During exercise, this fixed delta will not work because the intrinsic conduction is faster. So you have to shorten much more to get the biventricular pacing. So,
but that will be kept off during while you are programming the Sync AV Plus. In that case, automatically that AV delay will be off.
No, so Sync AV Plus, what they did that during exercise, if it's shortened, the delta will automatically shorten accordingly.
Right. So
even delta will be dynamic, so that adequate biventricular pacing can happen.
Okay, sir.
Anyway, Ashish, good talk. See, two things. One is that I think everybody should understand it's not just putting the leads into the heart. The understanding and program is very, very important. I've been always trying to tell that at least CRT should be handled by electrophysiologists or who have knowledge of electrophysiology. That's number one. But that thing doesn't happen in our country because I've seen many devices being implanted, but they don't know how to program it. So program is very, very important. The second thing I want to comment upon the multi-point pacing. You are part of the trial actually. But multi-point pacing initially showed some positivity, but overall the larger trial didn't show much advantage. So I really don't know whether there is some study going on. Another thing is always a question of battery also more utilized. So those are the problems with multi-point pacing.
Sir, multi-point regarding pacing, one recent trial came up that is more CRT MPP. They have shown no extra benefit with using multipolar pacing, but one crux is there. Those who are getting more than 98% pacing, biventricular pacing, in that subset of the population, it might be beneficial because non-responder to responder conversion rate is much more if the patient is getting more than 90% biventricular pacing with added MPP.
Yeah, but still it's not very a clear mandate about MPP. So one point from my side, whenever I see Sync AV and I have a question in my mind, every 36 beats you are sensing. So out of 100 beats, you have 2-3 beats you are only sensing, you are not pacing. So once you make it percentage, automatically your percentage of pacing drops from 100 to 99, 98%. Yeah. So this is a little concern from me, but maybe 98, more than 95 is more than enough.
Sir, it's about 3 consecutive beats every 256 cycles.
Yeah. So no, you can program that also.
Yeah.
Yes.
So biv pacing cannot be 100% here. This question raised because does it reduces the effectivity of the your biv pacing number?
because it
More
should
than
be
98% is okay, but
98% and a plus.
But any number of PVCs and all additional will bring it down from 98%. Yeah, it's wonderful. I think. So we can move on.
Actually, multi-point because of the availability of now conduction system pacing, multi-point pacing has gone down. Yeah. And also the trial has not shown benefit.
No,
Yes.
Yeah, Ishita.
Yeah.
Ishita has a question.
So, does LV strain imaging help in selecting the veins for which we will be putting the LV leads? LV strain imaging.
I think it is QLV which
yes,
takes.
because it also helps in deciding about the responders and non-responders, but it is not being routinely used so much.
Yes, that does help, but was with strain imaging, the desynchronous portion of the ventricle can be identified, but strain imaging cannot be is not actually good enough to identify the scarred portion. That is also showing the desynchrony. So if you are putting a LV lead on the part of the LV which is scarred but desynchronous, so that will not going to produce a good response. So in that situation, cardiac MRI will be helpful, definitely.
Thank you very much, sir. But the data has not shown that strain or echo based, any technique you take in echo has shown no benefit over ECG. So now it is all, you see in guidelines also, the all selection goes with the ECG, not with the echo.
So coming back to MPP, as the study as you quoted didn't give any benefit actually. And later they analyzed and found the way the programming was given in the protocol was the one which was leading to that. What they found is if you have two vectors and if these two vectors are 30 millimeter away and 5 milliseconds between the difference, then there is a good benefit with MPP. Because there was no protocol for this programming during that MPP study. So doctors use their own judgment on the numbers, like whether using the same nearby electrode which was 10 millimeter away, or they were using 20 millimeter away, and they were using also 40 millisecond between LV1 and LV2. So, yes.
The practical problem is that very few patients, all the 4 leads are pacing.
Yes, this is a major problem.
Sometimes there is 2 are pacing, sometimes there are 3 pacing. So it's a rare patient to have good pacing threshold in all the poles. So there is not much you can do about it.
And even thresholds are different.
Yeah.
So the consumption of battery is much more.
Right. So the best would be, as you said rightly, 30 millimeter, 3 centimeter. So that doesn't happen in many patients.
So we can move on to the quiz. Minor and Ashish, I think. Stay there. So we are moving towards a very exciting, program. That is a quiz, which is a Kahoot quiz. Mainak and Ashish, take over. They are setting up. So, Souvik, what we can do is, in the meantime, we will have a IBHRE that orientation and talk. So, it's just a kind of a chat, We'll just chat about IBHRE, how exam happens and what all we need to do. So,
Oh, there. At the mic though.
Slides.
Okay, so I think this talk is for doctors and I think for industry people as well, because IBHRE is something that both industry people and doctors are supposed to are eligible for that. So many industry people, I think you can also join in, or you can just ask your questions whenever you feel like. So this is not a didactic lecture. So these slides are not actually for the, yeah. So people who are, if you are from industry, you all can come forward. You can ask questions also. So IBHRE,
it's useful for industry people also. They also give examination for CCDS.
Change kora. So, okay. So IBHRE is the International Board of Heart Rhythm Examiners or Examination. So it's just a board board which certifies professionals, including healthcare professionals, as well as industry people, allied professionals also, who want to. It's sort of a certification. It's not obligatory, but it's a sort of certification which shows that you know about the device field and you are up to date about the device field. But it's not an obligatory thing. So you can see here that the number of people over the years who are enrolling in this, both from industry and doctors, is increasing. And the countries who have IBHRE certified professionals, so lots of countries are over here. So India is also one of them, but the other countries the usage is more, the persons are more. So it's more of a thing in Western countries than here. But I think it's an interesting concept and it should come up, because as we have seen throughout the day here, that new things are coming up, new trials, new studies are coming up, new techniques are coming up, and sometimes our routine training does not incorporate all of these things, and these are something that we need to be updated about. So, so this is just a guideline sort of thing rather than exact thing. So the first thing is that why should you be taking this exam? So actually the first step is always the hardest. And when you first take the jump, you will find that you will have certain obstructions. You will be involved in your practice. You will have some other commitments, and you will have to again go back to taking an exam. So why should we take this exam? So I already mentioned this. So this is for almost everybody can take part in this. So nurses can also actually are eligible to take this IBHRE exam. So why should we take? So before going into the other things, Moinak has recently, I think, cleared. So maybe you can also just tell us that what was your stimulus for taking this exam, or why others should be thinking about taking this exam and qualifying.
What I feel that after the preparation of this CCDS exam, my look and perception towards the device is completely different. Because honestly speaking, in most of the part of the India, during our DM tenure, what happens, we have been well trained about the technique of implantation of devices, regarding also the indications and others. But whenever it comes about the programming part, most of the things are completely given up to the industry people. So we are not being the part of the programming and all other things. And as the device part is developing rampantly nowadays, after the inclusion of the AI also, so it's our responsibility also to understand what is there inside the device, what the future is there, and how we can help our patients to the programming also. So that is the most important thing what I feel.
So there is the scientific part. So you are just implanting and you are going away. You don't know anything about what happens next. So that is an important stimulus, that you want to know exactly what you are doing, rather than just puncturing the vein and putting in leads, 2 or 3 leads or 4 leads. You want to know what exactly you are doing to the patient. So that is a very important part, and that is not there in routine curriculum. So if you, while taking this exam, the one important part is that when you go through the study material, even if nothing comes out of all this thing at the end, at least you are wiser for the process, because you know what is the up-to-date material which is there, and you know about at least a little bit about programming. So you can always try the next year and so on, but that effort will not go in vain. because you will learn things about devices that you never knew before. So that is an important part. So how to crack this exam? So many people are discouraged because of this this exam process. This is because many don't know what the exact exam process is about. Many don't want to go back and sit through the textbooks and go through that again. I think this initiative by Dr. Dilip Kumar to have this is very good, because if you know what you are going into, you can actually you will find that it is not as difficult as it is envisaged. So you can keep on planning about it and go about it. So a little bit about what this exam entails. So first of all, what I also experienced, and maybe we'll ask others also who have qualified, is that unlike the MCQ exams that we have given throughout, we have taken throughout our education, many of the MCQ exams that we have done are mostly based on rote memory. But this exam is one of the exams where most of the questions, or if you want to crack this, most of the questions will be relying on your practical knowledge. So only those people are going to qualify who actually are thinking about it, who are going and looking into the programmer, who are going and looking into how the pacing is done and how troubleshooting is done, and then augment it with your theoretical knowledge. So from your experience, drawing from on-job training and clinical experience in implant and EP studies. So I will be coming to the division of the marks system, but you must remember that physics and chemistry and all those things might be there, but whether you qualify or not is depending, most of the questions you will be able to crack only if you are able to draw from your own experience. So there are mock tests which are available online, some are paid, some are also available from industry and other partners. So you can do that and you can plan accordingly. Also something is seeking out articles concerning arrhythmias, particularly review articles in major cardiology journals. So journal articles, textbooks, mock tests, but the most important point is, I think, number one. You will have to think about looking at programmers and looking at troubleshooting yourself and drawing from your experience before you actually think of cracking this exam. Maybe Dr. Dilip Kumar, you can also, sir, say about your experience and what do you feel how to succeed in IBHRE.
So a couple of points. This is a tough exam. This is not an easy exam. If you feel that you have done 1,000 pacemakers, CID, ICDs, CRTs, good training, even then you may not crack it. And timing is very important. This number of 4-hour examination, 4 hours you have to sit there, and they will not allow you to go up 5 minutes, before 5 minutes of the examination begins. First time I went, then I had, they asked me any ID which is government issued, and I had no ID at that time. I thought they will not require an ID. So I went to my residence and brought it. Half an hour they allowed me to sit the examination, but I missed 30 minutes. If you miss 5 minutes, you are going to miss 10 questions, 5-10 questions. So timing is very important. You have to be well prepared, bring your ID, government ID, and then you reach there having a little, don't overeat, but don't undereat also, because the 4-hour examination, it will be difficult to, sometimes you feel hungry, you may not be thinking properly. And timing, if 40 sets questions are there. If you see that 30 questions you are still answered and your timing for that session is going up, you have to be very quick. So these 3-4 tricks I tell you, and most of us can clear it, provided we go with the, you will show the question from where the question comes. Question bank is obviously important, that Abbott and Medtronic both can provide you. But the portions from where the questions come, he will tell you the initial biophysics part, and then clinical infections also they come into picture. Then some of the programming parameters, then this kind of 2:1, TRP, Vankeback, ventricular safety pacing, And so these are common questions which are crosstalks. So these are the common questions which are there in each year, and so Jyoti will take it from here.
Yeah.
Yeah.
Yes, so there is no, I will be coming to that also. So earlier there was a different exam for allied personnel and there was a different exam for clinicians. Now they have combined it together. So my personal opinion is it becomes more difficult for allied personnel than for clinicians, because most of the topics that you will face, I will be giving the distribution, but most of the topics are clinical based rather than purely or engineering based sort of things. However, so this is the syllabus. So I'll go through the syllabus a little bit slowly. So there is the fundamentals of electrophysiology and electronics. There is applied science and technology. So you can see that applied science and technology has a good percentage of marks. So anything and everything comes under applied science and technology. So it can be clinical also, it can be purely physics also. But pharmacology, plain pharmacology has very less representation, ECG, clinical assessment. So these percentages might be misleading, because what I feel is that, for example, clinical assessment, you might feel that it's only 4%. But when you actually try the questions, at least 50-60% of the questions you will have to have a clinical assessment to give a judgment on. Because I remember one question during my time, it was related to cautery. So a person is having a non-cardiac surgery on an abdominal surgery, and I think a left arm surgery it was. So you have to have an idea that your left arm is the one where you are operating and how far the distance is from the cautery to your device side. So things like that, clinical assessment comes into the picture, whether it's heart failure or otherwise. Perioperative practice, clinical practice. So this is perioperative management of devices and things like that. Safety issues. Patient and device follow-up and management. So this is again a big part. So perioperative practice and device follow-up and management. So all the, what I was seeing, all the troubleshooting talks that you heard today, like T-wave oversensing or inappropriate shocks, all of these come into this part. So, and last of all is radiology. You will have some X-ray questions, X-ray or CT, some radiology questions, and you will have to interpret according to that. So this is a rough chart, but remember, like I said, previously I think the trend was different, but nowadays what I feel the trend is it's mostly clinical, with a little bit of your applied things thrown in. So this exam is done by from US. So only items which are commercially available in the US may be the basis of examination. That's not almost all the devices that we use are mostly US based, so that's not a problem. The maximum marks is 720. No passing percentage is given by them, but from experience, from know-how, you find that the passing percentage is 68 to 71%. The rank is given in percentile wise, so there is a percentile, not a percentage. But what if you want to extrapolate, that the percentage of marks that you will have to at least qualify to get the correct answers, to think that you have a reasonable chance of qualifying, is 68 to 71%. Mostly it's held in August in those times. So that is the percentage of marks. So there is a breakup of this syllabus. I think you can get it from industry people, and it's available also from the IVHRE website. So there is a breakup of everything. So we need not go into that, but there is a breakup. So if you see here, fundamentals of electrophysiology and electronics, things like ampere, charge, coulomb, ohm, volt. So these questions they can ask you these questions. So if you remember from your physics days, so power is equal to V square by R into pulse width and all those things. So these things you will have to read a little bit. But what I feel is that these questions are not the deciding questions. These are maybe 5 or 10% questions. Derived quantities, relationships, Ohm's law, power, energy, and waveforms.
They're very easy to score.
Yeah.
Very easy to score, and you don't have to put your brain there. Just you know, and then you just click it. But
Absolutely.
clinical questions, you apply 2 minutes, 3 minutes, you just think over it. So these are scoring numbers.
Yeah, it's mathematics. Oh, I have a timeline for this also.
I think 5 minutes.
So the mathematics is the advantage is you can score 100%. So it's something like this: which of the following pairs of units is incorrect? Joule, coulomb, watt, Henry, and you can Joule for energy, coulomb for charge, watt for power, Henry for inductance, capacitance for ampere hour. So things like that. These might seem simple if you go through and you are confident with these questions are some of the questions that you can score marks very easily. Something like which of the following pairs of units is incorrect? Okay, so I'll not go through all of these applied science and technology. So we as clinicians are always worried about this applied science and technology part, but it's not that different. It's a little bit of mugging up to do to be practical, but not that challenging. 32% of questions come from here, but even in this 32%, when you actually take that exam, you will find that most of these are clinical oriented. Or if you have 5 options, you will be able to remove 3 options, and from the other 2 options, you can find the option which is closest to you and then attempt. So like for example, high impedance electrodes meet delivered pacing energy requirements because of which of the following? So this is something, rather than going through the answers, so this is something, a little bit of reading you will have to do from your textbooks or whichever you are going through. So the answer is a small lead tip surface area. So a little bit of physics you will have to go and read. Applied science and technology, a little bit about your stimulation parameters, timing cycles, algorithms, defibrillation concepts and all that. So things like you were seeing these things in the talks, so you will have to get yourself conversant with interpreting the electrograms. So lots of questions will be there on electrograms. So you will, so far maybe it's not much, this is something which maybe allied people will be more comfortable with and not the clinical people. But these are lots of questions will be coming on diagrams like these. And you will have very short period of time. So it's like 50 seconds for one question if you want an exact. So you will have to think very quickly. So from now on, if somebody is planning to go take this IBHRE exam, for clinicians at least, you should have to, from whatever pacemaker patients or device patients that you are doing the procedures on, after the procedures are over, try to go and have an idea of the interface of Boston, Medtronic, St. Jude, Biotronic and all the companies that are there. If you are aware of the interface, you gain a few seconds. Then you can interpret the EGMs and you can answer quickly. So at least this you have to do, that you have to go through the programmers of all the companies. So I'll not go through all the maybe questions right now. There is pharmacology, there is electrocardiography, there is clinical assessment. These things are maybe a little bit more difficult for allied people. There will be always some questions on ECG. So you will have some ECGs where you will have to make diagnosis. These are generally not very difficult questions. These are not very difficult, but you will have to practice nonetheless. On radiology. So some radiology questions, like for example, here it's on the LV apex, so you will have to determine from the X-ray as well as the ECG. Perioperative practice, clinical practice, so this is very important. It includes indications for device therapy, indications for device and feature selection, and surgical technique. So this is lots of questions come from this, but this is again something that you will have to read and do MCQs before, and you will be able to be more comfortable about that. Clinical practice continued, some safety parameters about radiation safety, MRI compatibility, things like that. So I'll skip all these. Patient and device follow-up and management, very important. So how you follow up these device patients is very important, because this is something that we don't do usually, but in the Western countries they have device clinics and it is obligatory to have a good knowledge of follow-up. So you will have to have an idea about the programming, the device assessment on follow-up, clinical, technological, programming management and things like that. Remote monitoring, generally you will have at least 2 or 3 questions which are based on remote monitoring, because it's in those countries it's an obligatory thing. Again, I'll skip through these.
So I think
okay, I think we can
clear
have questions.
orientation has been given. If any question, Manak, you want to say something?
What I think that the best way to prepare is
I'll
through
keep on
clinical
changing the
experience.
slides. You can keep on looking also.
Clinical experience. So how did I prepare apart from books and other study materials is that I used to do regular pacemaker camps on my patients. I used to call them around 30 to 50 patients regularly, and I used to keep checking the EGMs. That I think gave me a little bit of edge in the exam.
I think it brings the, it brings the reflexes up. So once you see the questions, we don't see the programmer, the screen, then you are totally lost there. Even if you know what Rakesh was showing and everyone was blank, because they don't see it regularly, the programming screen. So we need to do it more and more so that you can clearly and very quickly, it was very clear. So A and B, you have to see the EGMs, and then you can just correlate. Is it 1:1, or atrial is coming less often and ventricular is coming less often? Just you have to see this, and it's done. So I think last event we will go for quiz, and then we will disperse. And it was a wonderful anything else? Any questions?
I think we have whatever I have said or we have discussed is all from the clinical point of view. So people from industry have also qualified. So if we can have one or two comments from their side also, maybe if Mr. Sabri or
Govind, if they can,
maybe you can have some comments about advice about this, and then maybe we can.
Anyone who has qualified CCDS can give their inputs.
Thank you, sir. I think it's a wonderful thing that Dr. Dilip could bring this in, a very important part of our journey in excellence. So as sir has already talked about it, I have nothing great to add about it. Only thing is the time, whatever time you are having, you have to go through, like what Dr. Mayank was saying, that as many programming as possible of all companies. So it is basically, you have to be thorough about all the companies, and it will be basically something like that. It is not what is happening now. It could be something, an algorithm which was happening or was available even 10 years before, 15 years before is important, because these people will be coming for follow. And whatever it has been very recent, it may not be asked in the questions, because the question paper is set at least 1 year before. So what is happening at present, this year, probably it is not going to be there. Even if you take CSP, less questions are there even up to last year. Probably this year the questions may be improving because it has become more, I think, prevalent over the period of time. So this is what my suggestion is. Thank you, sir.
Thank you. I think.
Thank you.
So we are moving to the last event of this, last session of this today's program, and this is a quiz, and I hope you will all enjoy it. Ashish and Mainak will take over now.
So we are going to have a very short but exciting session on quiz. It's an app-based quiz. So first of all, you will have to download the app. Mr. Sundeep, can you please share the QR screen? There will be 10 questions. Each will have 30 seconds of time.
Gets as competitive as possible. Right, and one more thing I wanted to point out, so each of these questions are going to have a time limit. So even if the answer is right here, it needs to get quickly on the screen. So the fastest person with the correct answer is going to have more points as compared to other individuals who are answering after that.
So we expect as much as participation as possible. So we are left out only 40-45 people inside the room.
And it's going to be a great one, no problem.
just
So
scan
you
the
can
QR
take your
code.
phones and start scanning the QR. We just have 17 people who've already entered the quiz, so you can see your names flashing up on the screen the moment you are entering the game.
So I think we are ready to start. So we will be having 10 questions. There will be 3 to 4 choices. So out of them, one will be the correct or the answer. So you'll have to choose that. And for each question, there will be 30 seconds will be the time. So let's start. So the first question is, oversensing in single chamber pacemaker leads to, so the options are number 1, overpacing, number 2, normal pacemaker function, number 3, underpacing, and number 4, none of the above. So once the time is up, we will go to the next one. So
Okay, so we already have 17 answers which are correct. So that's like majority of this room already knows the right answer. Can we move on to the next question? Okay, so we have Shilu on top, followed by Kavita and then Raj battling for the third position. So that's the next question.
In the given timing cycle diagram, the yellow block represents which part of the timing cycle? The first one is refractory period, blanking period, third is alert period, and fourth is pivot.
Dr. Kumar, no answer sharing. Superb. So we have 15 correct answers. It's the blanking period. And now let's see how the scoreboard looks like. So we again have Shilu leading with Dr. Shojato, then Dr. Shamshad. Okay, that's a new one we have on the leaderboard. Can we have the next question, please?
So it's a 85-year-old male with sinus node dysfunction and recurrent syncope and underwent conventional TPM, that is the VOO. Next morning ECG monitor shows the following ECG. What is the diagnosis? Is it undersensing? Is it lack of output? Is it oversensing? Or is it lack of capture?
We have only 10 seconds to go for this question. Okay, so we have an interesting result out here. Let's see how the scoreboard looks like with this one. Superb. Dr. Shamshad has taken this game very seriously and seems like he's gone straight up from third to the first position. So he's leading right now, followed by Shilu, followed by Dr. Shojato.
So next question. The amount of change in signal amplitude over the time is called as pulse amplitude, pulse width, sensitivity, and slew rate.
Looks like everyone knows because the answers are just popping up one after the other. That's great. So we have 12 answers saying slew rate. And this time Dr. Shojato has gotten a little more competitive in this room. So we have him on top, followed by Shilu, followed by Dr. Shamshad. Can we have the next question?
Sure. So let us come to the question number 5. What type of lead is this? Let us check the image. Is this a coaxial lead, or is it a co-radial, or multifilar, or co-bipolar? As the image is shown, what is the type of lead is this?
Superb. So let's see how the scoreboard looks now. Okay, so we have some new entrants. Shilu followed by Dr. Varun Kumar at the second place, then Dr. Saurav Das. We have a change in the leaderboard. Dr. Shojato also moving up. Can we have the next question?
LVAD for LVB area pacing.
I'm sure after the wonderful
The first option is
CSP
less than
sessions-
85, less than 75, less than 90, and the fourth option is less than 55.
I'm sure after the superb sessions on CSP, everyone should be getting this answer right. It's brilliant. We have Dr. Varun Kumar leading, followed by Dr. Saurav Das, followed by SS.
So we can go over to the next question.
Yes, please.
So question number 7. A way to determine the initial site of the left bundle branch pacing is to check which one of the following is correct. That the paced QRS morphology before fixation has a W pattern with a notch in V1. Option 2 is sensed QRS morphology has an M pattern in V3. And option 3 is paced QRS morphology before fixation has a W pattern with a notch in lead 1. Again, most of the people have answered correctly.
Now let's see how the scoreboard looks like. So we have Dr. Varun Kumar still leading the board, followed by Dr. Saurav Das. We have a mysterious T in the room who's also in the third place. We'll move over to the next question.
So 8th question, an asymptomatic patient on DDDR permanent pacemaker follow-up ECG shows the same. What is your impression? ECG machine dysfunction, minute ventilation sensor on, lead brake artifact, muscle stimulation artifact. I
We
hope
might
you can
need
see
to
it
zoom
properly.
into the picture. If you can just zoom out, okay. So we have a lot of answers around. So Dr. Varun Kumar is still leading, and this we just completed the 8th question. So 2 more questions to go.
I think the fight is going on between Varun, Dr. Saurabh, Shilu.
Yes, let's see who sustains till the end.
So the 9th question is, all are the causes of right bundle branch pattern in paced QRS complex except option 1, LV epicardial pacing, option 2, septal perforation, option 3, LV endocardial pacing, and option 4, misplaced V1 and V2 electrodes in 6th intercostal space.
Okay, change of scenario. We have Dr. Saurav Das leading, followed by T. Shilu at the 3rd position. We'll move over to the last question.
So let us come to the last question. So this is an 80-year-old male with peptic ulcer disease and GI bleed who underwent 4 months back dual chamber pacemaker for complete heart block. This time attended ER with CVA. On pacemaker inquiry, there is no apparent atrial high rate episode. This was a chest X-ray done in the ER. Which of the statement is the wrong one? 4 options are given.
The options might be flashing on your phone screens as well. You can refer to the picture on the projector.
So they have already answered, I think. So most of them have already answered.
Yes.
It's the correct answer.
So it's time to see who's on the podium. So at the 3rd place we have Shilu. Can we please have a round of applause? Followed by Dr. Saurav Das, and at the 1st place we have, drum rolls please, Mysterious T. Can we please see who is T? Superb. Can we have a great round of applause? Superb. So the Mysterious T is just right there. Thank you so much, Dr. Maina. Thank you so much, Dr. Rashesh, for the great session. Thank you so much, everyone, for participating. Dr. Dilip, over to you.
Thank you. And still you can see you see only few chairs left empty, but still it is totally full. So it's a very kind of rarely seen picture, and I want to click a picture for this. And any inputs, any suggestions, and finally words from Dr. R.D. Yadav, Dr. Rabin, just final concluding remarks.
I think it was great learning for us, and I learned a lot. This type of meeting, and this is the best way to exchange the ideas and knowledge, and I have learned a lot, I can say, because we are doing device implantation, but I am much more of electrophysiologist rather than device interrogator. So I am more of hardcore electrophysiologist. Apart from I do other subject also, but for device updates, I learn a lot. Thank you.
Thank you, sir.
Thank you. It's a wonderful experience, and I think I could see the change. Now the people are showing interest, getting interest. The quiz was amazing. Very nice. Whoever designed you, did you design the quiz? Very nice quiz. A lot of things to learn. And again, another point is that the device interrogation and that IVHRE exam, Gaitan was really incredible. So thank you very much, and I think you keep it up, and maybe if you could do somewhere else, maybe in small cities, it can be done. And Yadavis actually belong to our city. He's from Durgapur. I don't know anyone knows about it or not. So he can speak very fluent. I speak to him in Bengali.
So we have participants from Assam, from Bihar.
Oh,
I would
excellent.
like to have them just
can
there
come
a
and
few
join.
words. We have 2-3 minutes left. Mayank, please come up. Samsad, please come up. Varun, please come. And besides these 4, there are many others who have come from outside state, and
You can
we'll
share
just
your
have
feelings.
their kind of inputs.
Good evening, everyone. I think this is one of the first meeting where I have not left my chair except for the lunch. So that's all I like to say, and I think that will sum up how great this meeting was. Thank you, Dilip sir, and the entire team. Thanks a lot.
It was a great learning session, and finally, whenever we get invited by Dr. Dilip Matab, we cannot deny, because Dr. Dilip is partially from Bihar and partially from West Bengal. And whenever we go to arrhythmias or pacing modalities, we usually want to have him frequently at our place too. Thank you.
It's a very nice meeting, and Dr. Dilip has arranged so seriously that this event, everybody has absorbed into it. And I myself call myself a pseudo Bengali. I did my MBBS MD. now in Ranchi, but definitely I can't leave this place and can't forget this place. So it's really a good, nice experience.
Anyone who volunteers to give say something? Yeah, Surandan. Yeah. And then we have industry partners be ready. One of from St. Jude and Abbott, Medtronic and Boston. And Novartis. Yeah.
So I have no words to express the way this conference has grown, because the first conference actually took place in an online meeting during the time of COVID, and I was the first speaker there. So it has gone on and it has become so big that so many people are there. I wish great success of this conference and year after year, because this subject has grown and Dilip is the pioneer here, and he should go every year with this conference. Thanks, Dilip.
Now I request Sabri and Govind and Devender, if he is there, or Kaushik, and Jayanto from Novartis. Yeah.
Good evening, everyone. It's a great experience sitting from morning 9:30 till the end of the day, discussing a lot of devices. Unlike most other cardiology conferences, most of it is clinical, so it's a nice experience. And I had Medtronic Industry, and I had the opportunity of being supportive of Dr. Dilip's this program from the inception days, and we can see that it has grown in stature into a great program. So congratulations, sir, and thank you for the opportunity. It has been a wonderful experience. Thank you so much.
I'll take it. Thank you, Robin sir and Dr. Dilip. And I think this is an excellent program which we have been also be able to partner for last on the inception stage. And every time what we are seeing is the growth of this and the interest, and also the topics which are very practical and realistic. As Dr. Abhin was saying about CSP being the talk of the day, there was a lot of lectures, and we have also got the most important persons like Dr. Sanmusundaram, Dr. Karthikeya. So these are making the program more interesting, up to date, so that people can learn what is the new things which are coming up, as well as with Dr. Yadav talking about the CRT and other important things which we could be also. So this is a wonderful program, giving an all-round idea about the latest, and this is definitely, we are very thankful to be part of it. Thank you very much, sir.
Sir, I am Joyendra from Novartis. Thank you very much, Dilip Kumar sir, for giving us the opportunity to participate in this device update. We are really thankful to him, and I owe my gratitude to him. And it was today a really nice show. All the chairs were full from the entire morning. I have seen really a great program, a gala program, sir. Thank you, sir.
Hi, good evening. I'm Kaushik from Boston Scientific, and we are participating in this program for last 4 years. And this is a great opportunity for us to learn from the industry, not only for our products, for other products we are learning. Thank you to Dr. Dilip Kumar, Dr. Chakraborty, and all faculties here.